select stream pain 5 ready. excellent. يلا بسم الله. we're online.
النوت وينها؟
النص بتظهر هنا مع كل سلايد.
هذه من هنا
يمين وشمال ما بتظهرش للناس. هنا كده ينظر تظهر تحت هنا ما بتظهرش هنا. اوكي تمام. روح الجامعة.
بسم الله الرحمن الرحيم.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Welcome on the second day of 4th International Anesthesia Conference. We'll start our lectures for this session with Dr. Ala Uraibi, who will present the neuromodulation and pain management, spinal cord stimulation, and intrathecal catheters. Dr. Ala. Okay.
Yes. Bismillah ar-Rahman ar-Rahim. I'm gonna talk about might be a little bit highly specialized subject, which is neuromodulation and pain management. When we say neuromodulation, here I mean it's invasive neuromodulation because everything we give as pain treatment, like tablet, pills, patches, everything is also neuromodulation. Yes, unbearable pain. 50 years old female with metastatic cancer. Her morphine, oral morphine patches, doses keep increasing, yet she is still groaning, clenching the relays of the hospital bed. She can't speak much. She hasn't eaten in days. She looks at her family with hollow eyes, saying, "It is too much." All of us know that cancer pain is more devastating than the disease itself. No option left. What we would offer her next? This is the question. Shall we targeting another source of pain rather than oral or intravenous or transdermal? Another case which we used to face as a pain doctors, nurses, very usually, even in young population, a case of pain that outlived surgery. This is a real patient, 38-year-old man, former school teacher, had 2 spine surgeries. Now he lives with daily burning radiculopathy pain, shooting down his leg with very Walking more than a few meters is unbearable. He's tried all medications, nerve blocks, physical and cognitive therapy. Nothing works. He can't sit, can't sleep, can't live like this anymore. It's a case of what we call it failed back surgery syndrome. Shall we target another source of pain? The physiology of pain, but the psychology related to suffering. So pain is a symptom, suffering is experience. Pain is more than a biological event, it's a lived experience. The physiology of pain involves neural pathways, sodium channels, spinal modulations. But suffering is what happens after the signal reaches the brain. It is the story a patient tells themselves about their pain, what it means, how it affects their life. Suffering involves memory, fear, identity, and loss, and it is different from the pain symptom itself. Two people may experience the same injury and report very different levels of distress. That's why clinicians must treat not only symptoms, not only nociception, also narrative. Managing pain means relieving suffering also. And that often requires not only drugs, but time, trust, and understanding. I'm telling that because we anesthesiologists used to treat, to pain with invasive procedures, and unfortunately, we don't have time to deal with the patient as a whole, as a context. So, effective pain management must address both the physical and emotional aspects, even when it is related to invasive procedures. These two cases we will try to focus on the pain crossroads. Where is the source of pain? I want to highlight the origin of spinal anesthesia, highlighting the historical context of medication innovation in the late 9th century. The field of anesthesia was evolving rapidly, and the spinal cord was beginning to be understood as a critical site for pain transmission. This sets the stage for August Pierce's groundbreaking experiment in 1898. Spinal cord first practical target by this genius surgeon when he looked at the spinal cord was the early and logical target for pain intervention. Theoretical understanding of its role in sensory processing led to the idea of delivering drugs like cocaine directly into the intrathecal space. This laid the foundation of the modern spinal drug therapy. And here we focus on the dorsal horn, particularly the substantia gelatinosa, was later identified as the primary site of action. Then, in the 1950s, came the Swedish neuroscientist Bror Rex, who discovered the lamina in the dorsal horn in the spinal gray matter. And he classified it into 10 lamina, 10 layers, now called Rex laminae, based on the cytoarchitecture of neurons. Lamina 1 to 6 are in the dorsal horn and are involved in the sensory processing. Lamina 2, also called the substantia gelatinosa, is especially significant for pain modulation. It contains inhibitory interneurons and a high density of opioid receptors, making it is the main target for neuromodulation, chemical and electrical, including the intrathecal drug delivery and the spinal cord stimulation. Then, in the 60s, the spinal cord discovered to be the gateway to electrical modulation. Through the, all of you know about the gate control theory, 1965 provided the basis for understanding the pain nociception. And then the spinal cord stimulation emerged as a clinical therapy for chronic pain. The gate control theory of pain. Melzack and Wall introduced the gate control theory, transforming our understanding of pain. They proposed that signals are modulated in the spinal cord, not simply relied to the brain. The dorsal horn, particularly the substantia gelatinosa, acts as gate that either allows or blocks pain signals. Non-painful stimuli activate A beta fibers, which close the gate. That's why when we get painful stimuli, we try to rub our body part to get pain relief. So we are activating the non-painful nerve fibers, like A beta fibers. And then we are closing the gate in the level of the spinal cord. While the pain signals from the C fibers and the A delta fibers, which is the pain transmitting fibers, open the pain pathway, open the gates. Descending input from the brain also modulate this gate, explaining how even psychological factors influence pain. This theory paved the way of therapies like TENS, trans-electric nerve stimulation, and the spinal cord stimulation. So gate closed by incoming impulses from large fibers or from the brain, opened by impulses from the smaller fibers. Then we have the chemicals, also working on the same level, and mentioning here the marcaine, bupivacaine. As you know, as many of you know, it acts at the dorsal horn lamina 1 to 3, especially lamina 2, the same target, substantia gelatinosa. It is local anesthetic used in intrathecal drug delivery system, blocks voltage gate, sodium channels in nociceptive neurons. In the lamina mentioned previously. When combined with opioids like morphine, Marcaine enhances analgesic effects and reduces the systemic opioid requirements, especially in cancer pain patients. And here we are dealing with nerve fibers. So we want to block nerve fibers to block pain signals. There's different fibers that work in transmitting sensory signals hand in hand with pain signals. So in spinal anesthesia or analgesia, local anesthetic block nerve conduction by inhibiting sodium channels. Smaller, less myelinated fibers such as C and A delta fibers are blocked more easily than large myelinated fibers like A alpha motor fibers. Additionally, sensory fibers enter the spinal cord more superficially, making them more accessible to intrathecally administered anesthetists. This results in the characteristic differential block as we know it. Pain and temperature go first, followed by touch, pressure, and finally motor function. Understanding this helps to predict pain response and manage anesthesia and analgesia effectively. So as you see here, the small N myelinated fibers, the C fibers, and then the A delta fibers. And the last fibers to be recruited by the local anesthetist is the motor fibers. The autonomic fibers also is the early fibers to be recruited with the local anesthetist. That explaining why we get hypotension very early in the process. Another thing here, my affect which fibers we are targeting is the concentration of the drug. High concentration of local anesthetic will block easily the motor fibers. Again, "50-year-old female with metastatic cancer," as we said before. What would we offer next? Intrathecal analgesia through intrathecal catheter. It is not very common way in treating cancer pain, can I say? It is more popular in the Scandinavian countries and particularly Sweden. They are known to be pioneers for this type of treatment. And almost every hospital is offering this type of treatment. In 2017 study from Karolinska evaluating the efficacy of intrathecal bupivacaine alone versus Marcaine combined with morphine in patients with severe cancer pain. It was randomized. The crossover design allows each patient serve as their own control. And for cancer-related pain, intrathecal catheters, we used to use special catheters with subcutaneous port to be inserted subcutaneously and connected to CAT pump. And usually for patients, terminal patients, expectation not to live more than 6 months. If you can see here, this case I did it in Sweden before I located here. I bought this was another case, a pediatric case, like 16 years old, with sacral plexus neoplasm, very painful. And we couldn't put even the catheter through the usual way, through the L2 or L3. So I put retrograde insertion of the intrathecal catheter with the subcutaneous port there. And actually the pain relief disappeared after giving her the first bolus of Marcaine. Back to the study. It was a crossover study for 8 hours washout between the medications via bolus dose only, because it was a debate. Is Marcaine alone is best or Marcaine combined with morphine? In all these 20 patients we did in Karolinska, we put intrathecal catheters placed the usual way, insertion site of L2, L4. And medication, bolus injection under monitoring condition given, bupivacaine 2.5 milligram, and morphine, the combo group 0.25 milligram added. Total 1 ml volume. The result was both regions provide effective pain relief, no satisfactory significant difference in pain scores, no increase in side effects with morphine addition. Morphine combined with Marcaine did not enhance analgesia. So after that, we began only to give bupivacaine. The second case here for this young man after failed back surgery syndrome, I guess Dr. Abdullah Belkhair will suggest spinal cord stimulator for this patient, failed back surgery syndrome with radiculopathy pain. SES is indicated for failed back surgery syndrome, complex regional pain syndrome, various forms of chronic neuropathic pain. The standard approach includes trial phase where percutaneous leads are inserted into the pleural space under fluoroscopic guidance. These are connected to the external stimulator to test patient response. If patient relief exceeds 50%, the patient qualifies for a permanent implant. The internal pulse generator is then implanted, often in the gluteal or abdominal region, and programmed for individualized stimulation setting. Failed back surgery syndrome is the biggest group that we pain physicians recruit patients to try spinal cord stimulator.
Can we summarize?
Yes, I'm almost finished. And this study from colleagues North and Caporal and Kumar have did big impact in 2005, 4, and 7, proving that SES was more successful than reoperation and conventional treatments. And these patients had permanent STS after trial and returns to daily activity. The most important thing when we're dealing with these invasive, highly specialized devices is that not only to relieve pain, but also to increase the quality of life. Chronic pain is not just a physical signal, as we said, it's an experience shaping the life of the patient. The importance of patient-centered decision is very important. Interventional strategies succeeded when tailored to individual needs and goals, not only the symptoms. Why these techniques are difficult to be utilized for every patient. In intractable pain, intrathecal catheter analgesia offers target relief for cancer pain with lower systemic burden and enhanced comfort. Unfortunately, this method is underestimated worldwide. Thank you. Thank you.
Thank you, Dr. Oraibi, for this fruitful presentation. Good morning, everyone, again. It's my pleasure to introduce our next speaker, Dr. Nizar Al-Zughaibi, anesthesia consultant and chairman of anesthesia department at King Abdullah Specialized Hospital in Riyadh. Dr. Al-Zughaibi holds an executive master degree in health in health administration from Cornell University and is a fellow of Royal College of Physicians and Surgeons in Canada. Dr. Al-Zughaibi completed his clinical fellowship in pain management and pediatric anesthesia in Canada. Dr. Al-Zughaibi will present interventional spine techniques, what's the evidence. Please join me in welcoming Dr. Nizar for this session. Thank you.
Good morning. Thank you, Dr. Bluming, for the kind introduction. Good morning, everybody. As you're aware, axial pain related in the spine, or the lower spine or cervical spine, is a common issue. It's approximately 15% of the population suffer of this kind of pain at one stage in their life. However, there is 25% of them that transform to a chronic pain phenomena. Of course, being that much of pain, patient suffering, they get laid off work, they go to hospital, get surgeries, get interventions, pain medications, disability. All this costs the health system a huge amount of money. In the States, in 2016, it was estimated that 134 billion it cost. That was in 2016. It's probably 10 years later now. It will reach 150 billion, which is a huge amount of money that costs the health system. There are multiple reasons. There is lots of confounding factor in pain in the spine. It's not easy to pick and diagnose, in spite of the high modalities of investigations and modalities in MRIs and CT scan. You're all aware of what used to call failed back surgery syndrome or post-laminectomy syndrome or third surgical syndrome, whatever the name is. It's the people underwent successful technical surgeries, yet they don't have pain relief. So it's so complicated, and there are, if you want to see the criteria that causes pain in the back, you'll find that lots of tissues, joints, discs, nerves causes pain in the body. Pain management in general. When you manage a chronic pain, acute or chronic, but mostly in chronic pain, I always teach my resident 3 P's, 1 N. Physiotherapy, pharmacotherapy, psychotherapy, and N is the needles, injections. And that is the scope of our discussion today about the evidence for injections in the spine. If I'm going to start with the American Society of Interventional Pain Physician, one of the biggest regulating body or societies in the US, they always look into evidence on injections every now and then. This is the latest in 2021. They looked at epidurals. Epidurals done for different kind of procedures and different kind of indications. That would make it difficult to standardize and to come up with a conclusion. However, they looked at disc herniation. This is probably the strongest evidence you'll find. Okay, it's level 1, all right, for caudal and epidural, whether interlaminar or transforaminal, in cervical and lumbar, has the highest evidence. It's less for other kind of spinal stenosis. Spinal stenosis goes to level strength of 2 and moderate to strong evidence of lumbar cervical. Again, interlaminar, okay? It's not for transforaminal, for the spinal stenosis. So if you have a patient with spinal stenosis, you want to attempt a pain relief injections with steroids, you'll go with interlaminar rather than transforaminal. As you can see, the transforaminal has a lower and weak evidence, level 4 and 3. What about axial discogenic pain? Again, the evidence is level 2 with moderate to strong evidence for caudal, lumbar, and cervical interlaminar epidural steroid injection for the axial pain if you have discogenic pain. What about post-surgery syndrome, which I discussed earlier, which is you do a surgery, technically it's fine, yet the pain is persistent, and there is lots of confounding factor for these patients because probably their failure to respond or to improve their pain is related to something else. It's not the primary diagnosis that you went for by physical examination or MRI. There might be other confounding factors such as chronic pain syndrome or fibromyalgia. So post-surgical syndrome, also the evidence are fair, moderate to strong, level 2 evidence for interlaminar epidural injections in the cervical and the lumbar area. This is another review. It's more, I think, in 2023. They looked at the Cochrane database, and they found that epidural steroid injection in general, okay, they lump sum it all together, okay, they didn't go into specific. It has a strong evidence for the short, long term, which is 3 months, moderate and fair evidence for the long term, 6 month and 12 month down the road. Another reason for pain in the back or axial pain is the facetogenic pain. Facet pain causes, we do different kind of injections, whether it's intra-articular, whether it's the medial branch, or it's radiofrequency denervation of the medial branches. So the evidence behind facetogen for lumbar part, it's also fair recommendation for the diagnostic part, level 1 to 2. However, it's less for cervical and thoracic, it's level 2, but still have a good evidence for diagnostic facet injection when you do medial branch diagnostic injection with local anesthetic only. And usually the response, and most of the study they looked at, which is one of the limitations also, they look at pain relief more than 80%. Then they go and proceed with it, and they consider it a positive diagnostics. Most of the literature looked at 50% and above. Then, for the evidence of therapeutic injections for the facet in terms of steroids, intra-articular or TMO-RF, there is a fair evidence of the radiofrequency of the medial branches of the lumbar area, and also, again, fair evidence too, with moderate to strong evidence for the facet joint nerve block, the nerve block. The intra-articular, surprisingly, which is done commonly, whether for cervical or for lumbar, has a low evidence, actually. It's a very weak strength. Cervical, again, same thing, for nerve injections, and radiofrequency has fair amount of evidence. However, for the intra-articular injection, it has a very low evidence. Again, the same thing for thoracic. It's a lower evidence for facet injection, whether it's a radiofrequency or intra-articular. And the facetogenic pain related to facet arthropathy is very rare in the thoracic area, by the way, because it's a fixed spine, and usually you don't have any issues with it a lot. It's not a common block that's done frequently, as much as the lumbar and the cervical. Another issue and another source of pain for axial pain is the sacroiliac joint. Sacroiliac joint treated also intra-articular injection, steroid injection, and with denervation, more commonly these days. The intra-articular steroid injection has a poor evidence evidence it, level C, and usually they recommend not to use it as a for a steroid injection for the sacroiliac joint. The radiofrequency, also the same thing, actually, to be honest. It doesn't have a strong evidence. However, emerging evidence that cooled radiofrequency, specific kind of radiofrequency, has a better evidence compared to thermal denervation. And maybe Dr. Abul Khair in the next lecture is going to highlight some of that. What about epidural adhesolysis? You can go with epiduroscopy, you go through the caudal approach, and you go with small fiber optic, and you go to the nerve root and you inject hypertonic saline or hyaluronic acid to remove the adhesions around the nerves and free the nerves. It's the same thing, actually. It has a fair amount of evidence for long-term pain relief for the lumbar spine area. Now, saying that, I discussed most of the commonly used procedures that we do in the pain clinic, and we see a fair amount of evidence, moderate to strong evidence. Is it that simple? Unfortunately, it's not. Most of the previous slides I showed it's between 20 to 24. A new article came this year that was the discussion among our society here in the Pain Society through the British Medical Journal. They looked at the evidence in axial spine also for non-cancer chronic pain. Unfortunately, it was not that promising. They were against all injections, to be honest. All injections has no evidence, they said, in the British Medical Council. And they advised not to use steroid injection for that. So, what do we conclude with that? It's really hard. I was talking to Dr. Abdullah this morning. I did this lecture in 2014, and the evidence was poor to weak for epidural steroid injection. Now it's becoming more stronger. Now it's becoming, again, with a new study that shook the medical pain societies. So what do we understand from that? Where do we go from there? As a pain physician, what do I do? It's really puzzling. However, we all know that the chronic pain population is different subset, different group. It's not easy to dissect. Even when you look at the studies, you have to look really, really carefully. What are you looking at? What kind of injections they did, what kind of population they did, and what's their outcome, whether it's long-term, short-term, before you conclude. So it's a mixed bag. So you cannot dissect and come up with a clear idea about evidence in these populations. There is lots of confounding factor, as I said before, also, not just being a specific pathology like sciatic pain. It could be also confounded by having a fibromyalgia patient with wide spread index of pain. So I always come back to the basics. What do I do for patients with regards to chronic pain? I have fair evidence, all right, so I'll proceed with it. I involve multidisciplinary approach, not just injections, medications, physiotherapy, and psychotherapy are really important and has a strong evidence for group therapy. Then weigh the risk and benefit for each patient separately. Patient is severely, poorly diabetic control with no clear indications. I'll avoid doing steroid injection. Okay, I'd rather go with radiofrequency. Patient anticoagulant, stopping the anticoagulant has a risk for the coronaries or the strokes or CVAs. So I'll balance things, then discuss with the patient and decide the appropriate therapy. Thank you very much.
Thank you, Dr. Zohaibi, for this speech. Please welcome join me in welcoming our next speaker, Dr. Abdullah Abul Khair. He's acting chairman of the Department of Anesthesia at King Faisal Specialist Hospital and Research Center in Riyadh. He is a US board certified anesthesiologist and pain medicine specialist. He has served in key role, including deputy chairman and program director of anesthesia and pain fellowship program. Dr. Abul Khair will present radiofrequency and chronic pain. Thank you so much.
Hello, good morning. Assalamu alaikum. Thank you for the kind invitation. Thank you, Dr. Abdurrahman and Dr. Ibrahim. Thank you so much. So I'm going to be covering radiofrequency ablation in chronic pain. We'll be going over the history, also history of the chronic pain clinic in King Faisal, our patient flow and patient selection for chronic pain patients, as well as some interesting cases, new targets for radiofrequency, and a summary. So. The first known use of thermal coagulation for treatment of chronic pain was for a case of trigeminal neuralgia back in 1931 by this physician, Martin Kirschner. Direct current of 350 milliamperes was delivered through a 10 millimeter uninsulated tip which produced a lesion of unpredictable size. In the late 1950s, the first commercial radiofrequency lesion generator was developed by Kosman and Arno. This is a picture of it in the, on the right, named radiofrequency current because the same frequencies of 300 to 500 were used in radio transmitters. The first RF lesion for pain was in 1965 by Rozumov. Was a neurosurgeon. So he was pretty daring. He lesioned the spinal cord directly, lesioning the lateral spinal thalamic tract through the C1, C2 intraforaminal space. Sheely in 1975 performed the first RF lesioning for spinal pain. The medial branches of the facet joints were ablated using a 14 gauge electrode inserted through a 12 gauge guide needle. It was abandoned for a while after that because it was very invasive, very painful to do these types of procedures with large bore needles. Until about the 80s, they came up with these slim, slender, small gauge insulated radiofrequency needles, which made the procedure much more appealing to patients that had chronic pain. Reliable temperature monitoring was available and increased the safety for performing these lesions. Some of the targets that are used for radiofrequency ablation, multiple from inside the disc around the knee to the sacroiliac joint. Any structure that's causing pain that is innervated clearly can be usually receive radiofrequency. So what controls the size and the shape of the lesion that is formulated by the needle itself? So common sense, the gauge, the uninsulated length of the needle that is exposed, the temperature, and also the size. The gauge is the most important thing, plus the uninsulated size. There are other factors also that influence the lesion itself. You have patient-related, equipment-related, and procedure-related itself. So when it comes to patient-related factors that influence the gauge or the type of lesion, you have the nerve course variation itself, the peri-electrode tissue. If it's around bone, if it's around soft tissue, it will produce a different size lesion. Equipment itself, as I mentioned in the previous slide, cannula gauge, tip gauge, and circuit configuration. The procedure related factors including target temperature, how hot the tip is, and cannula angle and target. So a lot of us pain physicians have introduced pulse radiofrequency into our practice. There is a difference between pulsed and conventional radiofrequency. Pulse radiofrequency is low temperature. When you have a very highly sensitive target that is susceptible to damage and may be critical, you want to do pulse radiofrequency. The mechanism of the pulse radiofrequency uses short bursts of energy as opposed to a sustained lesioning type of high temperature lesion. The temperature is lower, pain relief duration is usually shorter with pulse radiofrequency, and it's much more safe. So applications are usually for cases like trigeminal neuralgia, more critical structures, maybe celiac plexus radiofrequency. However, it depends on the patient and kind of location of the lesion. So a little bit about the chronic pain clinic in King Faisal. King Faisal was established back in 1975. The pain clinic was maybe the earliest notes I could find was in the early 90s. However, it transformed into a full pain clinic in the early 2000s. The hospital itself has been transformed into a non-for-profit tertiary care hospital in 2021. It has it says about 1,800 beds on the hospital website, but this is what I could find earlier, 1,600. We established a hospital-based fellowship back in 2010, and thankfully, with the collaboration with other hospitals in Riyadh and in the country, a Saudi-based Saudi Commission health-based fellowship was established in 2016, 2-year fellowship. So there are some pictures of our pain clinic, the radiofrequency machines we have. It's a pretty dated location, small. It has about 2.5 exam rooms and 1 procedure room, no recovery room. So the flow is not that busy, but we were successful in the previous year to establish a pain refill clinic, which is located just directly outside the pain clinic, which made the flow much easier. And those of you practicing chronic pain know that this makes a big difference. So what are some of the limitations of practicing chronic pain in Saudi Arabia, or in our hospital, for example? Our referrals come within the hospital system and from outside the hospital system. Anything that comes from outside has to be through a primary service, for example, orthopedic surgery or oncology, and then it comes to the pain clinic inside the governmental hospital system. We have some protected slots for outside of the hospital patients. The barriers to traditional workflow, patients are extremely complex. They have either had a transplant or some type of horrible genetic disease, so not straightforward at all. Most patients are traveling from outside the city, makes appointment scheduling very difficult. There are extremely long waiting times. For a new patient, it takes about 1 year to be seen first in the pain clinic. So how do you select patients for RFA? It depends on the disease, right? So you want to make sure that trial less invasive injections first, less permanent solutions, physical therapy, over-the-counter medications. Possibly try it before giving any kind of addictive medications such as opioids. Usually patients would prefer a trial of some type of injection. Successful diagnostic blocks usually are a good predictor for a long-term effect with radiofrequency. You also may perform radiofrequency in more specialized circumstances such as cancer. The complications are similar for any other type of procedure: bleeding, infection, inadvertent injuries to unintended structures, pain at the radiofrequency site, osteonecrosis. These are some of the targets that are available in the body. As I mentioned before, anything that is innervated and doesn't have a critical structure or a critical type of innervation may be a subject of a pulsed or a lesion, RFA lesion. Some interesting cases from our clinical practice. This is a 39-year-old patient with secondary progressive multiple sclerosis with bilateral facial pain and trigeminal neuralgia that was severe in the face. Received pulse radiofrequency over the Gazarian ganglion with prolonged pain reduction with more than 70% lasting more than 1 year. The settings were 45 volts, 2 hertz, and with 20 milliseconds. And she responded very well initially. However, with time, this wore off. So we tend not to do lesion procedures with patients with multiple sclerosis because it's kind of an unpredictable outcome. We don't know how they will respond exactly. But initially, it worked really well. Another interesting case, 69-year-old male with history of hepatitis C, post-liver transplant, in 2012, diabetic hypertension, was not a surgical candidate, had successful diagnostic C3, C4, and C5 medial branch blocks in the past with pulse radiofrequency, and had responded for about 6 months with pain relief after giving pulse radiofrequency. So even these types of lesions are performed with radiofrequency ablation. If you try pulse radiofrequency, you may get the same amount of response. Another interesting case, 48-year-old female with complex regional pain syndrome of the right lower limb after ankle surgery, reported pain reduction for 6 months after each pulse radiofrequency of the lumbar sympathetic chain, and she would come every 6 months and have this procedure done. This is a unique case. It was a 13-year-old boy from Medina. He was trying to cut a piece of fruit and injured his hand. He got complex regional pain syndrome of the upper limb, and he underwent also pulse radiofrequency of the stellate ganglion under sedation, and which provided complete resolution of his pain. 40-year-old female, cervical degenerative disc disease. She got dorsal root ganglion pulse radiofrequency and responded for about 6 to 12 months. This is a recent case of patient with upper abdominal cancer, gastric cancer, severe continuous epigastric pain. We did a splanchnic nerve radiofrequency ablation of the splanchnic nerves, and he responded with 80% pain reduction. But this one was an RFA lesion. So for radiofrequency procedures, what is a new target that I've read about recently? This is the basiovertebral complex ablation, and provides pain relief for discogenic pain. It has a specific kind of setup. I don't think it's available here in the Saudi Arabia yet, but it has a specific introducer that goes through the pedicle, and you lesion intraosseously. So, experience with RF in Saudi Arabia, the service has expanded significantly. Most private and government hospitals provide the therapy. There are multiple companies that have different advantages and disadvantages. These are some pictures of the available companies. Cooled radiofrequency, as Dr. Nizar mentioned in his topic. I didn't get too deep into the evidence regarding radiofrequency because I know the evidence regarding chronic pain is fluctuating, as is mentioned in your talk. However, I agree completely with your summary of it's a big variability among our patient populations, even amongst different hospital systems, private or governmental. So it's really hard to establish kind of a standard set of care or approach. So in summary, radiofrequency treatment for chronic pain is minimally invasive technique for improving pain, relatively low cost compared to surgery or any kind of interventional implants, and avoids use of high repetitive doses of opioids in patients with chronic pain. That's it. Thank you.
Thank you, Dr. Abulkhair, for this fruitful speech and for sharing your expertise with us. Our next speaker is Dr. Fouad Abdul Qadir, who is a consultant anesthesiologist and chief of acute pain service at Dr. Sulaiman Al Habib Hospital, Al Rayyan branch in Riyadh. He holds the Jordan board and higher specialization degree in anesthesia and intensive care. He completed additional training in pediatric cardiac anesthesia and pain management in France and Italy. Dr. Abdul Qadir will present opioid sparing strategies in perioperative pain management. Please join me in welcoming Dr. Abdul Qadir.
Good morning. Thank you, Mr. Chairman.
بص يمين شمال ولو كده بنوتس النص بتظهر هنا.
Here.
يمين كده شمال ماشي. دي السلايد. انت عامل نوتس. لو في نوتس هتظهر لك في المكان ده.
This is where I'm working. So, in our practice, using opioids is so common. The problem is not using opioids and satisfaction, but the problem with opioids is the unpleasant and unaccepted problems that can appear for the patient or for the healthcare giver. So opioids are very commonly used in the post-operative period. Sometimes it was used alone. Now the environment is changing and we are going to use multimodal services for post-operative pain. Our role is to minimize that anesthesia and surgery and primary care may have in contributing to the opioid load in the community in UK or in Saudi Arabia or in any country. So it is imperative that all healthcare professionals involved in surgery and perioperative care work collaboratively to ensure robust opioid stewardship. A lot of people, millions, and surgical procedures are done everywhere. In principle, ensuring perioperative plan is drawn up in collaboration with the patient and reflects their choices and involvement in their surgical trip. All involved health practitioners have the following duties: to ensure that opioids started in the operative period and are continued necessarily or unnecessarily. To ensure that patients taking opioids are identified before surgery. This is very important. to identify risk factors of opioid, misuse of opioid, to ensure that the describing procedures and mechanisms exist at the interface between hospital and primary care, to ensure that chronic post-surgical pain is recognized and treated in correct way. So this lecture will represent the work of multi-organizational and multidisciplinary collaboration to set out the guiding principle in opioid management. Our all health professionals involved in the perioperative care should collaborate to provide the highest standard of care and highest standard of opioid stewardship. Opioids should be used carefully by healthcare professionals. This means using opioids when necessary and stopping opioids when they are no longer requested. So, as anesthesiologists, surgeons, general practitioners, and other healthcare professionals, preoperative assessment and preoperative planning is very important. Prehabilitation, complex cases, they need special plans and to change our policy. Perioperative management plan should be clear and should be formulated with the patient and communicated to the surgical and anesthetic team. So, as anesthesiologists and surgeons, intraoperative pain management should include multimodal analgesia, as has been explained yesterday by many colleagues. Evidence-based procedure-specific analgesic techniques should be used, not everyone trying to do his own method. Perioperative pain management techniques must be tailored to individual patient. Pain relief should be optimized before leaving the post-operative recovery area, and the plan should be cleared. Functional pain assessment for patients with complex pain problems should be also very clear and taken in isolation, should not be a sole indicator for administration of opioids. Immediate release opioids are preferred, and the trend now to use it intravenously and orally for perioperative period in the management of post-operative pain, and to decrease the risk of respiratory impairment and long-term continuation when simple analgesics such as paracetamol or non-steroidal anti-inflammatory drugs are used and not effective. Advice on medicine self-administration. The patient should be taught how to take medication on his own. Local protocols should be available and distributed for discharge medications. Every day we have problems with medications when we are discharging patients from surgical procedures. The hospital discharge letter must explicitly state the recommended opioid dose, amount supplied, and the planned duration of use. This should be very clear. Identification of patient for de-escalation of opioids. Medicine review post-discharge, where guidance should be given about necessary medicine review following discharge from hospital. Usually about 1 week the medication should be supplied. However, we have problems sometimes that the patient cannot follow up due to a lot of patients in the clinic, surgical clinics, and surgeon is very busy, so a lot of problems can appear. The action. The surgeons, general practitioners, other healthcare professionals should look for chronic post-surgical pain, which is defined as a clinical discomfort that lasts more than 3 months post-surgery. Here, this requires assessment either by GP or pain specialist. Fortunately, we have a lot of pain clinics all over Saudi Arabia, all over Riyadh, all over Al Habib, and in other Middle East countries. So opioids are not normally appropriate longer time treatment for chronic pain, including chronic post-surgical pain. Prehabilitation consideration should be given to reduce preoperative anxiety and catastrophes, as they may have value in the improving of post-surgical outcome, including pain. Preoperative counseling include working collaboratively with the patient and expectation management regarding opioid use and perioperative pain management. Patients with complex pain needs who may benefit from an extended stay in the post-anesthesia care unit should be identified so that appropriate plans can be formulated. Unfortunately, when our patients stay a long time in the recovery room, he go to the floor, no one had an idea why he was in the recovery room. So in complex pain cases, additional preoperative recommendation for opioid tolerant patients. For complex pain patients with high dose opioids, the opinion of pain specialist or pain consultant should be gained prior to surgery. A useful way to assess preoperative opioid consumption is through the calculation of oral morphine equivalent dose, which should be documented in the clinical record. Opioid tolerance may occur in patients taking opioids, and this likely to at 60 milligram of opioids for more than 7 days. If the enteral route is unavailable immediately after surgery, opioids conversion should be made to parenteral morphine. Rehabilitation optimization before surgery should include optimal management of preoperative pain and administration of opioids and other pain adjuvant medications. If patients in the patients who are unsuitable for preoperative opioid de-escalation, opioid taken before surgery should usually be continued throughout the surgical admission. Again, an individualized plan should be made for special patients. Buprenorphine, sublingual or transdermal, or methadone or other specific medication in other diseases such as pregnancy should be taken in consideration. Opioid sparing adjuvants also should be considered. Regarding perioperative management plan, a perioperative management plan should be formulated as we have said before. The patient should be warned that the plan may occasionally need to be altered and changed. Intraoperative pain management should follow principles, as we said before: promotion of early function return, multimodal analgesia and regional anesthesia, opioid-sparing analgesia techniques. Procedural specific analgesic techniques recommended for analgesia should be used than for over reliance on the WHO pain ladder. So pain management techniques need to be individualized, considering patient's choice, type of surgery, comorbidity, and pre-existing medicines. Yesterday we have a talk about total knee pain, post-total knee replacement pain management. So in the world, there are some recommendations: promote return of normal function and use the oral route when possible. This table will show approximate analgesic equipotencies of opioids for oral administrations. So immediate release opioids again should be taken in consideration in the world. And when analgesic requirements are reduced, reverse analgesic ladder, the WHO ladder, is recommended. So here, wean opioid first, then stop non-steroidal, then stop paracetamol. If the patient pain service should be involved in the post-surgical care, the opioid tolerant patient, inpatient psychology input may be needed to manage these patients. On discharge, there should be a clear plan for discharging these patients, a clear prescription, and the hospital discharge letter should be available in timely way and provided to all healthcare professionals involved in caring for the patient, including community pharmacists. Why? To avoid acute prescription to avoid an acute prescription of opioids inadvertently, which becoming a repeat prescription. So we get rid of refill medication. The hospital discharge letter must explicitly state the recommended opioid dose, amount supplied, and the planned duration of use. Guidance should be given about medicine review following discharge, additional recommendations for opioid tolerant patients, and finally, we close this lecture that all doctors, all paramedics should learn how to administer, how to provide opioids, and how to stop using opioids in these surgical patients. Thank you.
Thank you, Dr. Abdul Qadir. Thank you to all of our speakers for this well prepared and excellent presentations. Now we will have around 15 minutes to receive your questions, comment for our respected speakers.
Questions?
Please feel free to raise your hand if you have any question or comment.
السلام عليكم. أول حاجة شكرا جزيلا على المحاضرات التي أثرت أثرية بالمعلومات. السؤال الأول الدكتور نزار الزبيبي when the patient have low back pain, I want the difference when I use adhesiolisis technique and when I use steroid injection, and what the difference between both in effectiveness for the patient as effectiveness and as duration.
Both are they do the same thing. Even epidural interlaminar epidural steroid injection causes some kind of adhesiolisis. However, the mechanism of adhesiolisis, you need larger volume and higher concentration of hypertonic solution. So a simple the pathophysiology of adhesions in the epidural space is so complicated. Even with this simple disc, it will cause adhesions in the epidural space, not just only post-surgical pain. So it can be used for all situations, the adhesiolisis. However, it makes sense for the first injection is to go with epidural steroid injection and see how long it lasts. If it lasts for 6 months and above, you can repeat it as needed. Because the adhesiolisis is a bit complex procedure, and sometimes you need to keep the patient for 3 days. You put an epidural catheter and you give injections of hypertonic saline for the next 3 days. So the evidence again for both pretty much the same, moderate to low, to be honest.
patient with chronic lower limb ischemia. How much is the effectiveness?
So there's some variability in the types of ischemia and the types of disease. However, we have, and the duration for the effectiveness of having radio frequency for example, the lumbar sympathetic plexus for lower limb ischemia. First of all, it's only one-sided. So you have to repeat on the opposite side if you want to do it again. Usually they discourage on doing bilateral radio frequency procedures for the same patients because of severe hypotension or potential for complications. That's when it comes to radio frequency. For peripheral ischemia, usually spinal cord stimulation is a pretty good choice. Maybe Dr. Ala can elaborate on that a little bit. And it improves the circulation, improves also the, and it's more long term. You know, the batteries live for about 10 years, and it depends on the setting. We have a few patients with peripheral ischemia in our clinic that we have spinal cord stimulators implanted, and they prove very satisfying.
Exactly, I agree with that. Actually, regarding the spinal cord stimulation, you all know that the first indication in the 80s was the severe angina not responding to treatment. It was the first, and it's a great one, different from other indications from the spinal cord stimulation. And actually, we tried also in Sweden many cases with microangiopathic ischemia in the upper limbs, and we got good results actually for the perfusion and the pain management.
Any other questions?
Yes. I am not an anesthetist, I am an emergency medicine consultant, practicing medicine in Ireland, Dublin. I take the regional blocks as a pain management modality in the emergency room because, you know, pain is the most common symptom or complaint to the emergency. You guys as pain experts, especially spinal and sciatica and low back pain is very common presentation to our room. So just I'm asking as a regional block or pain management, apart from the medical treatment, morphine or opiate, what is the best blocks that can be done for sciatica pain? I know this is a big question, but it's very important for me to know that.
Thank you for the question. طبعا chronic pain specialties they're far away from emergency medicine. So we don't have any emergencies in our lifestyle except for cancer patients and acute radicular pain less than 6 months. Those are the two high priority and fast tracking kind of and CLPS less than 6 months. Those are the three indications that you fast track patients usually. With regards to pain in the patient coming to the ER with acute sciatica, you start with the simple kind of approaches from medications. You can start with non-steroidal.
We need someone inside, please.
Weak opioids.
Yes, IT
you can't
immediately.
disagree.
Immediately,
It's
please.
small. No, but this is the approach. You cannot jump to injections immediately. Okay, we'd like to hope to help patients with blocks, but it's not the.
عايزين يتشحنوا فيها وفين الشحن بتاعهم انا مش عارف.
لا ما وصلنا أي شيء.
تقديم شحن الاثنين.
شحن بطاريات بس فقط. غير لك البطارية الثاني وين؟
الثاني هناك.
شغال.
هو ده بيتشحن ولا بطاريات ولا؟
باتري.
Okay. Good morning, everyone. We have decided to resume with the next set of this next session. The next session is on obstetrics, obstetric anesthesia, and our next speaker will be Dr. Ado. He's the chairman of Saudi, King Saudi University Hospital, the anesthesia department, and he's also the assistant professor there. He trained in France and did his fellowship in obstetric anesthesia in Canada at the University of Montreal. Thank you, Dr. Ado. Please come ahead.
Thank you for the nice introduction. Assalamu alaikum. Good morning, everyone. Today we will discuss the anesthetic management of cardiac obstetric patient. I have no financial disclosure related to this talk. In the next 20 minutes, I will briefly talk about introduction, different risk stratification system used to predict the neonatal and maternal complications in a cardiac patient. And then we will explore the hemodynamic effect of pregnancy, vaginal delivery, or CS. Then we will talk about different modalities of delivery and anesthesia and analgesia suitable for cardiac patients. So as you know, the cardiovascular disease is the leading cause of maternal mortality, partially due to increasing in the average maternal age, and also, in addition to that, increasing the prevalence of comorbidities like obesity, diabetes, and hypertension. As I already said, according to CDC, the cardiovascular disease is now the leading cause of maternal mortality. There are several cardiac conditions that fall under the category of maternal heart diseases with a variation in the severity of each one. That's why several risk stratification tools have been established to or in trying to predict any neonatal or maternal complications in a cardiac pregnant lady. All these risk stratification system works as a scoring system, giving each risk factor a point. So the higher the points or the score, the more likelihood of getting cardiac or major cardiac complications. This study tried to compare the accuracy of different risk stratification system, and they, among them, they found that the modified WHO classification is the most accurate one. In the next few slides, we will talk about the hemodynamic changes of pregnancy. As you know, during the pregnancy, there will be a drop in the SVR while increasing in the cardiac output, but the end result is a drop in the blood pressure. The supine hypotension syndrome, or aortocaval compression by gravid uterus, while the pregnant lady is in supine position, can lead to decrease in the preload, cardiac output, and subsequently the blood pressure. This can be significantly improved by putting the pregnant lady in lateral position. These cardiovascular changes can begin as early as the 5th weeks of gestation. Usually the blood pressure drop during the 1st and 2nd trimester. The SVR drop while the blood volume increase. So here is a conclusion of the hemodynamic effect of pregnancy. There will be an increase in the blood volume, mainly plasma, which might lead to, subsequently lead to delusional or gestational anemia. Also, there will be a drop in the SVR, heart rate, cardiac output, and there will be a drop in the blood pressure. All these changes can make a load or strain on the heart. The labor is stressful event. The pain usually can increase the release of endogenous catecholamines, which can increase the heart rate and the cardiac output. The uterine contractions can lead to fluctuation in the blood, in the cardiac output, while the uterine involution might lead to significant increase in the cardiac output by about 80%, which can be poorly tolerated by a cardiac patient. During CS under GA, especially when the opioid are not used, there will be a surge in catecholamines level, secondary to adrenergic response to intubation and to surgical stimulation. In addition to that, there will be a direct hemodynamic effect of some hypnotic like propofol, or secondary to sympathectomy post-neuraxial. The cesarean usually carries a higher risk of bleeding compared to vaginal delivery, and we usually administer uterotonic agents for preventing postpartum hemorrhage. Unfortunately, these agents have cardiovascular side effects. So the question now, what is the ideal mode of delivery for a cardiac pregnant lady? This study tried to answer that question, and there were no significant differences in either maternal or neonatal outcome between the two groups with one exception, the higher tendency of having low birth weight and prematurity in the cesarean group. That's why the American College of Obstetricians and Gynecologists recommend that the cesarean delivery should be reserved only for obstetric indication in a pregnant lady with stable cardiac disease. Of course, in case of unstable cardiac disease, like large dissecting aortic aneurysm, critical valvular stenosis, severe decompensated pulmonary hypertension, or acute heart failure, the cesarean might be indicated. During vaginal delivery, when we administer neuraxial anesthesia, it can provide a better pain control, which decrease the release of catecholamines and decrease or lower the heart rate and the venous return. Neuraxial analgesia can be served also as a primary anesthetic technique whenever cesarean is decided. When we provided neuraxial labor analgesia, beside applying standard monitor, we should consider invasive blood pressure monitoring, especially in case of severe left-sided outflow tract obstruction or cardiomyopathy. The CVP has low utility in labor, and there is little evidence supporting the fluid co-loading or bolus. That's why it should be limited to less than 200. We should, of course, prepare vasopressors and inotropes, and whenever to be ready whenever needed. Any neuraxial labor analgesia technique can be used, but keep in your mind, in case of continuous spinal analgesia, it can result in rapid sympathectomy and profound hypotension, high or total spinal, especially when wrong dose is administered. This table showed a comparison between different neuraxial technique. Each one has a benefit and consideration in a cardiac patient. When providing neuraxial analgesia, our aim to minimize the sympathectomy by giving or by doing a slow titration, giving smaller doses, and avoiding any intrathecal local anesthetic. And as you know, the main drive for post-neuraxial hypotension is a drop in the SVR, so the cornerstone for managing or preventing post-neuraxial hypotension is giving alpha-1 agonist. Of course, we have to consider invasive arterial blood pressure monitoring. Any loss of resistance technique can be used, either saline, air, or hanging drop technique, with one exception. In case of intracardiac shunting, it's the saline is the preferred technique for loss of resistance to avoid any risk of paradoxical air embolism. The epinephrine containing test dose might induce a significant tachyarrhythmias. That's why it's better to be avoided in any patient with a history of arrhythmia, stenotic heart lesion, or severe aortopathy. An alternative to that, we can give 100 mics of fentanyl to detect intravascular misplacement of epidural catheter. The typical intrathecal test dose, by giving 45 milligram of lidocaine or 7.5 milligram of bupivacaine, might induce rapid sympathectomy and profound hypotension. An alternative to that, we can give 3 to 5 ml of epidural solution, which usually contain lower concentration of local anesthetic. The initial bolus, we should give it slowly over 10 to 20 minutes with close monitoring of heart rate, blood pressure, and motor block. any maintenance technique can be used, keeping in mind that the continuous epidural infusion is usually less effective, and it might associated with higher incidence of breakthrough pain and the need for clinician-based boluses. That's why we recommend any other boluses technique. What about the anesthetic option for cesarean? Any neuraxial technique or GA can be used. It depends on the urgency of case and the status of the patient. So in the case of giving spinal can be given as a typical dose in case of mild cardiovascular diseases, which is not recommended because it might induce sympathectomy and hypotension. While the reduced dose, it might lead to inadequate level of anesthesia, intracesarean pain, and higher risk of conversion to GA. The combined spinal epidural seemed to be a better option for a cardiac pregnant lady. The intrathecal component, we can give either opioid alone or mixed with local anesthetic or low dose of local anesthetic. And we can slowly titrate the epidural catheter. The lidocaine has a faster onset of action, not only for analgesia, but even for sympathectomy. So the local anesthetic with slower onset of action might be a better option in a cardiac patient. Ropivacaine has an advantage over bupivacaine because it's less cardiotoxic. General anesthesia can be used in case of hemodynamic instability, secondary to cardiopulmonary decompensated, or in a case of contraindication to neuraxial anesthesia. In case of emergency CS, in a patient with cardiac disease, a multidisciplinary assessment with clear plan for both situation, emergency or elective, should be done early in pregnancy, including the possibility of giving tocolytic agents, either as a prevention or treatment of premature labor or for management of fetal bradycardia. This table showed commonly used tocolytic agent in clinical practice have the beta agonist, which can increase the heart rate, myocardial contractility, and decreasing the SVR. So it should be, it can be relatively contraindicated in hypertrophic obstructive cardiomyopathy or in history of tachyarrhythmia. While the nitrate can decrease the SVR, reflex tachycardia, and it should be avoided in case of severe aortic or mitral stenosis. In case of emergency CS, with whatever type of anesthesia can be done, we should do invasive hemodynamic monitoring. If we have insight to epidural, we can do a slow titration or slow conversion or top up of that epidural, or we can go for de novo neuraxial anesthesia. In case of GA, we should avoid any hypnotic agent with a significant hemodynamic instability, or in case of trying to avoid the tachycardia, we can give opioid to blunt the adrenergic response and the tachycardia. During the CS, we usually administer uterotonic agents to prevent postpartum hemorrhage. The commonly used agents are either oxytocin or carbitocin. Unfortunately, those agents have cardiovascular side effects like drop or decrease in the SVR and the blood pressure, reflex tachycardia, increase in pulmonary vascular resistance. All these are dose and rate dependent. Just for the sake of time, I will skip all these. This is a comparison or a summary of obstetric medication, uterotonic and tocolytic, with their potential side effect and relative contraindications. Thank you so much.
you wait up here? I have a question for Dr. Mohammed Oziat. It's ready. So what are your thoughts, Dr. Adil, on, if you come this way, on phenylephrine infusion versus boluses for maintaining the blood pressure after induction of spinal anesthesia in cardiac patients? What do you think?
Of course, the infusion can give you better hemodynamic stability compared with boluses, because boluses can, it's recommended to start the infusion as a prevention before treating. And in case of any hypotension while infusion, we can increase the rate, or we can give smaller boluses instead of giving the boluses as a treatment, because we might have either excessive stimulation of alpha-1 agonist and significant decrease in the cardiac output, or we can have a lag in hypotension with boluses.
Okay, I'll ask more on that during the question session. Thank you very much. Ladies and gentlemen, I'd like to introduce Dr. Mohammed Oziat. He will talk about neurological disorders in pregnancy. Dr. Mohammed has over 20 years experience in anesthesia, having qualified in Egypt, Al Shein University, and has worked in England as well as Saudi Arabia. He's a consultant anesthetist at the King Saud University Hospital. Thank you very much.
Thank you. Welcome before I start. Great. Okay, good morning, everyone. I hope you're enjoying your conference so far. And we are going to discuss our topic for this talk. It's about neurological disease in pregnancy. We're looking into our anesthesia perspective. It's a huge topic, so when we discuss the neurological disease in pregnancy, it either can fall into one of three main categories. So initially it can be a pre-existing chronic neurological disease before the lady becomes pregnant, or a disease that becomes aggravated predominantly during pregnancy, or a pregnancy-induced condition like eclampsia and preeclampsia, which will be the talk for our next session. So pre-existing chronic neurological diseases is basically, we're going to discuss this topic, multiple sclerosis, epilepsy, spinal cord injury, neuromuscular diseases, and spinal dystrophisms. So initially in multiple sclerosis, as we all know, it's an immune-mediated chronic demyelinating disorder of the central nervous system. It's basically intermittent, relapsing, remitting courses, and it's very slow in progression. It has various presentation, either sensory or motor, or bowel dysfunction, or sleep deprivation, or decrease in mood, and all of that. It's unfortunately a disease in which you see someone you know very well who is fading in front of you very slowly. In terms of pregnancy, relapses in multiple sclerosis can happen, and it's very low in incidence, and it happens mainly in the third trimester of pregnancy and early 3 months after delivery. If relapses happen, then we should focus on the treatment on steroids, immunoglobulins, and plasma exchange. The other disease-modifying treatments that is used in multiple sclerosis, like monoclonal antibodies, you cannot use this kind of medications and cytostatic drugs because of their deleterious effect on the fetus. When you see these patients in labor ward or in your antenatal clinic, you should focus mainly on history, medications, the kind of relapses and remitting course the patient is having. Neurological examination is very important to document the existing neurological deficit before you give the patients your anesthetic. What kind of anesthetic you would use for a patient with multiple sclerosis? For a long time, it has been proposed that general anesthesia is very safe in multiple sclerosis, but actually there are two major studies that came up studying this effect in PRISMS and POPARTMAS studies, in which these studies they focused on the use of neuroaxial techniques on multiple sclerosis and the postpartum period. These studies focused on the relapse of multiple sclerosis 1 year before the incidence of pregnancy and up to 2 years after delivery of the baby. And what did they find? Actually, they find no increase in relapse of multiple sclerosis in patients who received subarachnoid blocks. This is an article published in 2023. So this is a study was published in 2023 about the patients who are suffering from multiple sclerosis. I would like to share a paragraph with you to read it together. So what's important, I would like to focus on here, that patients who are having multiple sclerosis and these patients who were included in PRIMS and Popartmus study, all of them showed good results of subarachnoid block for cesarean section with no signs of multiple sclerosis relapse within 3 to 12 months follow-up. So, and epidural analgesia, of course, has minimal risk of postpartum multiple sclerosis relapse. So, neuroaxial blocks are very safe to use in patients, particularly subarachnoid blocks, spinal blocks, for patients with multiple sclerosis. Second topic we're going to discuss is epilepsy. So epilepsy is the most common serious neurological disorder you will find in a pregnant lady. It happens with a rate of about 7 in every 1,000 patients. So if you are working in a unit in which you have like 5,000, 6,000 deliveries, you will meet at least 30 to 35 patients every year having epilepsy. The primary management goals for treating epileptic patients is the control of seizures, the teratogenic effects of anti-epileptic medications, the management of status epilepticus if it happens, and SODIP. SODIP is sudden unexplained death in epilepsy, in which basically epileptic patients die for any reason that's not related to drowning or status epilepticus, and some explanations for SODIP is about channelopathies in cardiac muscle leading to malignant arrhythmias, or patients unfortunately having fit while they're sleeping and basically they suffocate while they're sleeping. And also in epileptic patients we have to differentiate between epileptic and the non-epileptic convulsions, especially eclampsia. How we can know that? Because we can easily differentiate that with the surrounding symptoms and manifestations and investigations that happen with eclampsia. Monotherapy is safer for both fetus and mother. As we all know, there are lots of medications out there for the control of epilepsy. Most of them are teratogenic, so it's better to use drugs like lamotrigine and levetiracetam for management of epilepsy. Unfortunately, there is frequent adjustments of therapy to reach a good level to control epilepsy because, of course, of the sleep deprivation and the stress and pain the mother is in, which increases the doses of anti-epileptic medications. And they should be taken throughout pregnancy and not stopped. Seizure in the intrapartum period should be treated as eclamptic in origin because of the dangerous effects of eclampsia. Of course, you will start them on magnesium infusions. In the UK, they give about 4 grams as loading doses and 1 gram every hour for 24 hours, while in the United States, they give about 4 to 6 grams as loading and 1 to 2 grams every hour for 24 hours. Neuraxial analgesia is preferred in epileptic patients, and of course we'll try to avoid pathogen in those patients because the neuraxial analgesia and anesthesia provide better pain relief and decreases sleep deprivation, which can increase the incidence of epilepsy. If you are going to use a general anesthetic for any reason, try to avoid etomidate, and in cases of neuromuscular blockers, you have to be careful that you might need frequent dosing for neuromuscular blocker in epileptic patients because of the enzyme-inducing effects the anti-epileptic drugs have on the liver. Next, we're discussing myasthenia gravis, which is an autoimmune condition in which there are antibodies against the nicotinic acetylcholine receptors at the neuromuscular junctions. It has many challenges, for instance, medications and teratogenicity. They use drugs like azathioprine and methotrexate. You cannot use these kind of medications in pregnancy. The worsening symptoms during the whole pregnancy itself because of the increased, of course, laboring woman abdomen and decreased functional residual capacity. And during labor itself, the increased muscle weakness because of the increased contraction of the uterus and pelvic muscles. Eventually, during labor itself, there is increased muscle weakness. When we evaluate these patients before we take them to operating theater, we need to assess the bulbar and respiratory muscle weakness because this might necessitate us to give the patient mechanical ventilation and post-operative ICU admission. If patients need therapy, of course, in this while they are pregnant, we usually give them pyridostigmine, which is an anticholinesterase inhibitor, steroids, immunoglobulins, or both. Epidural is recommended to decrease the risk of myasthenic crisis caused by pain. Neuraxial techniques are safe. Spinal anesthesia is fine, but the problem with giving a patient with myasthenia gravis spinal anesthesia, if the level gets too high, this might affect the muscles and makes it worse. So it's better to give them combined spinal epidural or to its good block effect and gradual onset, and you can titrate and control the level with your epidural. If general anesthesia is required, we have to give neuromuscular blockers judiciously, because as we all know, the neuromuscular blockers, the depolarizing muscle blockers will be having resistance because of the decrease of the neuromuscular junction receptors, and the non-depolarizing muscle relaxant, you have to give about 1/10 of the dose, and you have to use, of course, neuromuscular monitoring in these patients. If you are using rocuronium or vocuronium, it's better to give sugammadex to reverse the effect of the muscle relaxant, and of course, you have to be careful with hyperkalemia. If for some reason you need to use magnesium sulfate in case she develops eclampsia or preeclampsia, for its effect in eclampsia and preeclampsia and this neuroprotection on the fetus, we have to be very careful, and the risks have to be weighed against the benefits, and whether to use magnesium sulfate or not. Also, opioids and amyloid glycoside can result in increased muscle weakness. There is some recorded cases in which placenta transfer of antibodies has happened to the baby, and this might necessitate neuromuscular weakness in the baby and the need for mechanical ventilation for about 12 to 48 hours after delivery. Then we'll discuss the hereditary neuromuscular disorder, which is like myotonia dystrophica or dystrophica myotonica. It's a genetically disease, basically classified into type 1 and type 2. Type 1 is basically a defect in protein kinase. Type 2 in the nucleic acid binding protein. It gives a range of symptoms. Cardiovascular system, it can cause cardiomyopathy, conduction defects, respiratory system, it can lead to restrictive pulmonary disease and reduced lung capacity, endocrine and neurodevelopmental retardation. Type 1 is being more severe. Luckily enough, these patients are mostly infertile and they don't see them very frequently in labor wards. For the partner with myotonia dystrophica, it's better, of course, to give a neuroaxial technique, either epidural and you top it up for cesarean section, or you give her a subarachnoid block. We're trying as much as possible to avoid general anesthesia in those patients because of increased risk of pulmonary aspiration. These patients have pharyngeal muscle weakness. These patients have decreased gastric motility. They have lower esophageal sphincter dysmotility, which will result eventually in the instance of aspiration. Non-triangles of myotonia have to be avoided, like dexmedetomidine, neostigmine, hypothermia, and shivering. As I said, neostigmine is not recommended. Controlled ventilation might be required in this kind of patients post-operatively. Spinal dystrophisms is basically a range of vertebral canal defects. So, first one on the left, this is a normal vertebral column. This is spina bifida occulta. This is meningoceal, and this is myelocele. It has many classifications. Either can be open spinal dystrophisms, like as I said, myelocele, meningocele, hemimyelocele, or closed spinal dystrophism with subcutaneous mass or without subcutaneous mass, and complex dystrophic syndromes, disorders of the midline, and also dysfunctions of the notochordal formation. So what should we do if we see one of those patients? Usually those patients will come to you with a corrected deformity. So my first advice to you, if you encounter any of those patients, to do a magnetic resonance imaging. Why is that? Because if you do an MRI for one of those patients, you might find out that during repair of these dystrophisms, the epidural space is obliterated and has been used with ligamentum flavum in the treatment of the defect itself. So anatomically, there is no epidural space. Also, the presence of the spinal cord might be changed because of the surgery itself. So if you do an MRI, at least you'll know where your spinal cord ends and where is the repair, and whether you can give a neuroaxial technique above the level of the repair. It's important to remember that these patients also can have a closed dystrophism, in which basically there is no opening, you cannot see anything, but you can see some stuff that alert your attention. For instance, if you find the instance of tufts of hair, or you find lipomas while you're doing a spinal, you might think, is this a spinal dystrophism? There is a cord tethering happening going on and I'm not sure of? Of course, in this kind of cases, an MRI will be very useful. Spinal anesthesia has been performed successfully in this kind of patients above the level of deformity or repair. General anesthesia can be complicated by the fact that these patients have kyphoscoliosis, or if neuropathy, myopathy is happening. And of course, in these patients, we'll try to avoid succinylcholine because of the symptomatic hyperkalemia that can happen. spinal cord injury are basically patients either coming with acute spinal cord injury, like in a context of major trauma. In this case, if they're coming for repairs and delivery of the baby. General anesthesia is important for acute injuries because basically it provides cardiorespiratory support, which might be needed post-operatively. If it's a chronic condition, and this is increasingly seen nowadays, you find the patient who's having chronic spinal cord injury coming to you. The only thing you need to keep in mind is the happening of autonomic dysreflexia, which happens in patients having an injury at level T6 or above, which can manifest either in increased blood pressure bradycardia, but also tachycardia can happen. The autonomic dysreflexia can vary in presentation from asymptomatic completely to mild discomfort to a life-threatening emergency. If it happens, God forbid, you can use all the vasodilators you can find around you. Nifedipine, nitrates, captopril are most commonly used. Magnesium sulfate has been used successfully in control of autonomic dysreflexia. The second part we're going to discuss is neurological disease that can be aggravated in the presence of pregnancy. So initially, there are intracranial hemorrhages. This is the most common to happen. Almost half women with intracranial hemorrhage have a history of either preeclampsia, eclampsia, or HELLP syndrome. Next is cerebral aneurysm. Usually pregnancy-induced cerebral aneurysms are aggravated by the fact that during pregnancy, cerebral vasodilatation and increased plasma volume happen, in addition to hypertension that's happening during the labor pain. This can lead either to asymptomatic manifestation or, unfortunately, the presence of intracranial hemorrhage. If the aneurysm bleeds, early intervention like clipping or coiling improves the outcome for the fetus and the baby, and if the treatment is successful, you manage them normally without any changes. Arteriovenous malformations also can happen during pregnancy, up to 8.1%. A non-pregnant woman having experienced a bleed for an AVM should go intervention before she becomes pregnant. If it's first discovered in pregnancy, the risks of interventions are basically compared to the management of voluntary termination of pregnancy at this stage because of the higher incidence of rupture of this AVM and the incidence of subarachnoid hemorrhage. Whatever the cause of intracerebral hemorrhage, the initial management should focus on well-being of the airway, protection, cardiovascular support, and neuroprotection. If delivery is necessary in the acute phase, anesthetic options is limited to mostly general anesthetic. If delivery is decided in women who have minor symptoms or are hemodynamically stable, you can consider neuroaxial techniques. Next in this cerebrovascular group is acute ischemic stroke, which is any stroke that happens in lady. Most probably is they are predisposed because of the presence of eclampsia, preeclampsia, hypertension. The cesarean delivery itself is a post-thrombotic stage, old age, black ethnicity, greater parity, and multiple gestation. The initial treatment, of course, in ischemic strokes will be thrombolysis, although it can carry the risks of increased bleeding in ladies, which might lead to abruption placenta and might limit your choices in terms of anesthetic techniques you might use. So if patients have had recently thrombolysis IV mostly may risk the giving of neuroaxial technique, and you might lead to giving them general anesthetic. Post-operatively, definitely you will need to admit them to intensive care unit to keep in mind there is an increased risk of postpartum hemorrhage. Cerebral venous thrombosis is a rare cause of stroke in the postpartum period. Is mostly because of thrombophilia, increased incidence protein C and protein S. There is a sudden onset of headache, seizures, and deteriorating level of consciousness, which is confirmed by CT or MRI. The mainstay of treatment for these patients is anticoagulation, but good news, the prognosis in pregnant ladies is better than non-pregnant ladies. Then there is the last of this category is reversible cerebral vasoconstriction syndrome. This is a very serious condition. It has significant morbidity. It's basically happening in patients with eclampsia, autoimmune disease, or use of recreational drugs. The presentation is thunderclap headaches and could be lasting for minutes to days. Together with you do angiographic study of the brain, you'll find segmental stenosis with post-stenotic dilatation. The clinical picture may be variable, non-specific, and might last for 2-3 months, and we manage them with a triple H therapy with hypervolemia, hypertension, and hemodilution. Most cases of these patients resolve within 2-3 months on their own. And last in this category is brain tumors and space-occupying lesions. We're talking about a lady who's coming to labor ward to have a cesarean section or delivery. In the context, she's having a brain tumor which was diagnosed during pregnancy or became worse during pregnancy, and she's having space-occupying lesions. The key word here is intracranial pressure and mass effect. So we need to check whether these ladies having increased intracranial pressure or mass effects or not. If you are not sure, consult a neurosurgeon to help you with the decision. If we don't have mass effect and increased intracranial pressure, definitely go with a neuroaxial technique. If there is increased intracranial pressure or mass effects, it's better to give patients general anesthesia. This is a study that was published recently in 2025 in an Italian multi-tertiary center, and they published their experience in pregnant patients with symptomatic neurological disease. As you can see, they studied about 49,000 patients, and 240 patients of them were pregnant, having various neurological diseases, including vascular abnormalities, central nervous system tumors, epilepsy, neuromuscular junction diseases, demyelinating central nervous system disease, which is multiple sclerosis, spinal dystrophism, cerebral vascular syndromes, disorders of nerve roots, hydrocephalus, TIAs, pituitary pathologies, myeloid lesions, and other disorders. So, from this tertiary center, what did they say? They used mainly neuroaxial techniques for most of these lesions. So if you check here, so this is vascular abnormalities. They given 37 out of 42 patients a neuroaxial technique. Next, in cerebral neoplasms, space-occupying lesions as we discussed, and brain tumors, they given nearly half of the patients spinal anesthesia neuroaxial techniques. Just I cannot see. Moving down for epilepsy, they have given patients mostly spinal anesthesia. Spinal dystrophisms here, they given patients mostly general anesthetic because, as I said, the technique is difficult, especially with patients who has been repaired, or even you cannot detect properly the level at which the spinal cord ends. Moving down, patients with hydrocephalus, as you can see, they given them general anesthetic for 10 out of 10 patients because of these patients all have symptoms of increased intracranial pressure and mass effect. In summary, in this center, they had about 240 patients had neurological disease during pregnancy. 166 patients had neuroaxial technique, which is about 70%. Only 73 patients, which is about 30%, had general anesthetic, and the outcomes in both conditions were all right. So in summary, if you're having a patient with neurological disease, a preoperative evaluation should be detailed, including patient's neurological status, or possible outcomes should be explained to the patient during the preoperative assessment. Contact between the neurologist or the neurosurgeon with the anesthetist is recommended in the context of multidisciplinary meeting. Optimize the medications and avoid teratogenic ones. If general anesthesia is used, you have to be cautious with neuromuscular blockers. For instance, if patients having muscular sclerosis, these patients can have hyperkalemia due to disuse atrophy of the muscles. You need to decrease the neuromuscular blockers because of the decreased muscle mass. And as we discussed, of course, in the neuromuscular diseases, you have to be cautious with your neuromuscular blocker technique. Subarachnoid and epidural blocks are considered safe in most pregnant ladies with neurological disease. Post-operative monitoring of hemodynamic respiratory function, neuromuscular, and temperature is mandatory. Specific attention is required for post-operative complications. These are my references. If anyone would like, I can share them with you. Thank you very much.
Thank you very much. Please stay up there. Well, Dr. Jumana is coming on the next chat.
I'll ask you a question.
Yeah, sure. Yeah.
So thank you very much.
Thank you very much for the interesting chat, Dr. Mohammed. I couldn't help but think of a question which comes to me often because you worked in the UK and obviously here, but the practice is very different. So some of these patients with neurological disorders will come and say, my neurologist told me not to have a spinal. It's a common occurrence here. And even some colleagues will say, oh, this patient has this condition is AV malformation, don't do a spinal. And especially in Saudi Arabia, compared to England. What are your thoughts? How do you manage this in your practice?
So in our hospital in King Saud University, we give prioritized importance to communication with the patients and basically try to correct any misinformation they are having, and even with the surgeons. And we actually have very good surgeons who are very amenable. So if we, for instance, we said this patient is having an AVM,
ولو في notes تظهر
a spinal anesthetic, we sit down together and have a discussion. I show them the evidence, and eventually they get convinced. The problem would be the patients, okay? Because of these online forums, and basically they discuss with each other the bad effects of spinal anesthetic and neuraxial effects. So what we usually do is just to keep on trying to reassure them and explain to them that basically this is misinformation and this is better for you and your baby, and we try to support them psychologically and try to explain to them as much as we can. We find lots of them actually listen to us and listen what we're saying, and they get spinals done. Thank you very much. Thank you.
Our next speaker is Dr. Jumana Baj. She's a consultant anesthetist at King Saud University Hospital with over 3 decades of experience in anesthesia, mainly obstetric anesthesia. She's originally from Syria. She will be talking about the anesthetic management of preeclampsia and eclampsia. Dr. Jumana, thank you very much.
Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. Imagine that you are on call and at midnight they called you. There is one patient admitted to the labor room as a case of preeclampsia and she's seizing. Well, now we will discuss in this lecture about preeclampsia and eclampsia management in details, because really the preeclampsia and eclampsia is a nightmare for the anesthesiologist on call in the labor room. And we'll discuss in this lecture about the epidemiology, classification of hypertension in the disorders in pregnancy, and and we'll discuss also the risk factors of preeclampsia, etiology, obstetric management, anesthesia management, and we'll end with the take-home message. Okay, the epidemiology of the anesthesia starts with the incidence is widely quoted about 3 to 4%, major cause of mortality, and delivery of the infant and the placenta. It will be the definitive treatment. Preeclampsia is a leading cause for post-operative ICU or HDU admission post-operatively. Hypertension, disorders in pregnancy, we are aware about gestational hypertension, preeclampsia, chronic hypertension, and chronic hypertension superimposed with the preeclampsia. Here with this lecture, we'll discuss about the chronic hypertension, gestational preeclampsia, chronic hypertension, the onset before 20 weeks of gestation, and may it come mild and severe like preeclampsia hypertension, and there is no proteinuria, serum creatinine will be within normal, no hemoconcentration, no thrombocytopenia, and no hemolytic. No hepatic dysfunction. And the otherwise in the preeclampsia it will be okay after 20 weeks of gestation. It will be mild or severe hypertension. Typically there is a proteinuria, and there is also present in almost of the cases the creatinine is high, and also there is thrombocytopenia, hemoconcentration, and there is liver dysfunction. What are the difference between early and late pregnancy? Before they were classifying preeclampsia as mild, moderate, and severe. Now recently they changed the classification to early and late preeclampsia, because early preeclampsia may progress quickly to the severe preeclampsia. Early preeclampsia it occurs before 34 weeks of gestation, and it happens in about 20% of the cases, and it's associated with the growth retardation because it started early, and it have a clear family history, and there is also morphology with the placenta, abnormal placenta. The etiology mainly it will be placental cause, and the risk factor it will be high family risk factor. Regarding to the late onset of preeclampsia occur after 30 weeks of pregnancy, 80% of the cases, no association with the placenta, with the growth, with the IUGR. It's maternal cause and primarily maternal cause, and most of these patients, they have other comorbidities like diabetic hypertension and SLE or antiphospholipid syndrome. What are the diagnostic criteria for preeclampsia? First, preeclampsia without severe features like blood pressure about 140 or 90, and after 20 weeks of gestation, there is a proteinuria more than 300 milligram over 24 hours, and there is a protein creatinine ratio greater than 0.3. Regarding to severe preeclampsia, blood pressure more than 160/10, there is thrombocytopenia, have less than 100,000 millimeter cubic, and serum creatinine is high. There is pulmonary edema. There is a new onset of visual disturbances, and there is impaired liver function. Risk factor for preeclampsia. The first one, it will be demographic, like advanced maternal age and black race. Genetic factors, history of preeclampsia before, history of family preeclampsia, and a partner who fathered a preeclamptic pregnancy in other woman may the mother have a preeclampsia. Could be medical condition, as I mentioned, with the late pregnancy of the anesthesia, obesity, chronic hypertension, diabetes, SLE, chronic renal disease, and antiphospholipid. Regarding to the obstetric condition, any type of pregnancy increase the placenta volume, it may induce preeclampsia, like multiple gestation and heredity for more father-related factor, nulliparity, limited pre-conceptional exposure to the potential sperm, and could be behavior factor. Smoking, it will reduce the incidence of preeclampsia. Etiology and prevention of preeclampsia. A major underlying defect is a relative imbalance between prostacyclin and the thromboxane. Everybody know about it. But then normally preeclampsia, there is prostacyclin, there will be 8 to 10-fold increase in the prostacyclin with a smaller amount of thromboxane. In the preeclampsia, there is imbalance between prostacyclin and thromboxane. Thromboxane increased from placenta and the platelets, and the prostacyclin, it will come from the endothelium and the placenta. How to take management to avoid taking or as a prophylaxis from preeclampsia. Could be antiplatelets drugs play a role. There is many studies, as they are mentioned, that the aspirin 60 milligram may reduce the incidence of preeclampsia. Could be metformin, could be antioxidant, calcium supplements, and dietary sodium restriction. Diagnostic of HELLP syndrome, which is the major complication of preeclampsia, and it will have high risk of mortality, more than 20%. First, hemolysis, abnormal peripheral blood smear with increased bilirubin greater than 1.2 gram, elevated liver enzyme transaminase more than 70 international unit, and thrombocytopenia, platelets count less than 100,000. The differential diagnosis of hemolysis elevated. What about the differential diagnosis of HELLP syndrome? First, acute fatty liver infiltration of pregnancy. Could be also cholecystitis of pregnancy. Could be diabetic patient, gallbladder disease. Could be also glomerulonephritis, hemolytic uremic syndrome, hepatitis, hepatic encephalopathy. Could be also idiopathic thrombocytopenia. Could be also peptic ulcer disease, systemic lupus, SLE, and thrombotic thrombocytopenic purpura, and viral hepatitis. What is the preeclampsia mechanism? We discussed that is the imbalance between thromboxane and thyroxine, and the thromboxane and prostacyclin. So it's multi-systemic disease, and it is due to the global endothelial cell dysfunction. Why global endothelial cell dysfunction? Because there is superficial presentation related to abnormal angiogenesis, leading to placental hypoxia and the release of soluble substance angiotensin receptor autoantibodies toxic to vascular endothelium and initiating systemic inflammatory response. Pathogenesis and clinical presentation. Cardiovascular. In severe preeclampsia, the potential, the patient has normal high cardiac output and high SPR with the normal filling pressure, normal precapillary, pulmonary capillary wedge pressure, and the central venous pressure. Despite normal filling pressure, intravascular volume is restricted 30 to 40%, and also total body water is increased. Biomarkers. Brain natriuretic peptide, PNP, usually useful to identify cardiac dysfunction in preeclampsia. And studies showed that the PNP levels correlated with the finding of the echocardiography, like cardiac dysfunction, increased systemic vascular resistance, and decreased cardiac output, and the left ventricle diastolic dysfunction. Further studies are needed, however, to define PNP threshold values that have high sensitivity and specifically for heart failure during preeclampsia. Preeclampsia prone, the patient prone to have pulmonary edema due to low oncotic pressure. The normal oncotic pressure in the normal pregnancy will be 22 millimeter mercury in the antepartum period, and in preeclampsia will be less 18. And the postpartum, the oncotic pressure will be with the normal pregnancy 17 millimeter. It will reduce to 14 millimeter mercury in preeclamptic patient. Respiratory effect of preeclampsia. The effect of preeclampsia on the respiratory system. The airway is edematous, and we have to use smaller endotracheal tube. There is pharyngeal laryngeal edema, which compromise the laryngoscopy, and it will affect the airway landmark during intubation. Airway obstruction is indicated with the patient with the preeclampsia. She will come with the hoarseness and snoring, and there is also hypoxemia. And also may the patient present with also obstructed sleep apnea, and increase there is the incidence of pulmonary edema will be increased up to 70%. Renal effect of preeclampsia on the renal system. It was renal blood flow and the GVR glomerular filtration rate are decreased, and there is a renal failure due to decreased plasma volume and due to the renal artery vasospasm. Also proteinuria increased due to the glomerulopathy, and there is high uric acid, and also the all renal function will return to normal postpartum quickly. Regarding to the effect of preeclampsia on the liver, HELP syndrome, the patient may will complain right upper quadrant pain is a serious complication. Imaging is required, especially when the increased liver enzyme, and the patient it will caused by the liver swelling and peripheral hemorrhage. Maybe there is peripheral hemorrhage or also hepatic rupture, which has high incidence of mortality up to 30%. HELP syndrome occur in 20% cases of severe preeclampsia. And this is the image for contrast enhanced CT scan, and it shows here there is a, with the arrow there is the intraparenchymal hemorrhage, and there is with the and there is here also, if you see here there is intraparenchymal hemorrhage of the liver, and here there is a hepatic rupture. Thrombocytopenia. Platelet count will be less than 110,000. Woman with the severe disease of or HELP syndrome. DIC occur with severe liver involvement, intrauterine fetal, especially with the intrauterine fetal death, placenta abruption, or postpartum hemorrhage. Activation of the coagulation system is marked by the consumption of the procoagulant, increased level of fibrin degenerative degraded products, and organ damage secondary to microthrombi formation, and in advance DIC with the maybe the patient have spontaneous hemorrhage. Neurogenic insult, severe headache, hyperexcitability, hyperreflexia, coma, visual disturbances, eclampsia may occur even with or without high blood pressure. Possible causes of the hypertension encephalopathy or cerebral edema, thrombosis, and hemorrhage vasospasm. What about obstetric management? When the patient admitted to the labor room, the plan is classically stabilize and deliver the patient. Medical management with while we are the patient waiting for delivery, first we have to start steroid supplementation 48 hours before delivery, and especially if the fetus less than 34 weeks gestation. Antihypertension medication to maintain blood pressure, mean diastolic blood pressure less than 105. Maintain supplement magnesium sulfate for seizure protection, and monitor fluid balance. Input-output, the weight of the patient, symptoms, reflexes, hematocrit, LFT, and platelet count. Indication for expedited delivery, first fetal distress, that is an indication during this period. High blood pressure despite aggressive treatment, and worsening in organ function, development of HELP, and development of eclampsia. It will be the indication for the emergency cesarean section. All women should be evaluated for any signs or symptoms of end organ involvement during admission to this patient. We have to check if the patient had severe headache, vital disturbances, if the patient had altered mentation, dyspnea, right upper quadrant, epigastric pain, nausea and vomiting, decreased urine output, or central nervous system hyperexcitability. Antihypertensive medication, most commonly for acute control, hydralazine, labetalol, and nifedipine may be used, but you have to keep in your mind that the patient may develop hypotension if the patient on magnesium sulfate. For refractory hypotension, we can go for either GTN nitroglycerin or sodium nitroprusside. Using sodium nitroprusside is limited because of the cyanide toxicity of the baby. So when we are using the sodium nitroprusside, we have to use the direct blood pressure measurement. Angiotensin converting enzyme is contraindicated due to the side effect on baby, fetal side effect. This is the medication, and this is the dose. The onset of labetalol is around 5 to 10 minutes. The faster one onset start with 20 milligram, titrated up to 220 milligram. Hydralazine, it will take onset time 10 to 20 minutes, starts 5 milligram and titrated up. Nifedipine, 10 to 20 milligram, it will be very oral in case the patient doesn't have IV access. Nicardipine infusion, start onset of action 10 to 15 milligram, and we will start this one mostly in the intensive care unit. Magnesium sulfate, everybody aware and use magnesium sulfate. Just I will summarize a mechanism of action quickly. They act on as an NMDA antagonist to raise the seizure threshold. It will be vasodilators, ameliorate neuroinflammation and the brain edema in eclamptic-like seizure. Magnesium may also protect the blood-brain barrier. It has vasodilatation on the brain by doing brain parenchymal vasodilatation. It was demonstrated by the Doppler ultrasonography, and increase the resistance and the release of prostacyclin. Magnesium sulfate indicated either prophylactic for preeclampsia, or we can use to treat seizure treatment in eclamptic patient. It will be renal excreted, and most of the preeclamptic patients, they have renal impairment. So we have to check the toxicity of the magnesium sulfate, especially if the patient had severe preeclampsia. So the patient with the magnesium toxicity will present with the chest pain, palpitation, nausea, vomiting, blurred vision, sedation, and transient hypotension, and rarely pulmonary edema. So may magnesium sulfate increase bleeding, may have patient hypotension, hemorrhage, and decrease uterine contractility, especially if the patient on magnesium sulfate intraoperatively during cesarean section. So the magnesium sulfate should be monitored, and this is the levels of the magnesium sulfate. The therapeutic level will be 4 to 7 milli equivalent per liter, and the batellar reflex will be absent about 8 to 10 millimole. The respiratory arrest will be at 12 to 15 millimole, and the cardiac arrest will be at 25 to 30. So any symptoms of or any result of high magnesium level, we have to stop the magnesium immediately, and we have to antagonize the magnesium sulfate, especially if the patient has respiratory depression. We have to stop the magnesium sulfate and start calcium gluconate 1 gram over 10 minutes. And we have to reassess the patient if she had respiratory depression or rest. We have to intubate the patient and keep her on ventilator until be fully recovered from magnesium toxicity. Seizure prophylaxis. We'll start with the magnesium sulfate 4 to 6 grams over 20 to 30 minutes, followed by the maintenance dose 1 to 2 grams per hour. The infusion is commonly initiated once the decision is made to deliver the baby, and it will be continued over 24 hours. In all pre-eclamptic patients, they are planned for cesarean section should start magnesium sulfate 2 hours pre-op, and we should continue intraoperatively until the 24 hours post-operatively. What about the treatment of eclampsia? I saw many patients, they are held down in the labor room and they have seizing, and they we give him midazolam 2 milligram, and then we shift them to the room, and then we start management aggressively. Seizures are usually short-lived. It's necessary small dose. Maybe we'll give sodium thiopental, but now we are no more using. We can give 1 to 2 milligram midazolam. Then if seizure is persist and the patient is not breathing, we have to do rapid sequence induction and intubate the patient. Patient may be extubated if she was low gestation age and non-viable, like 24, 26 weeks pregnancy. And this patient, she can, when the patient is fully awake and recovered from muscle relaxant and she received magnesium sulfate, we can extubate the patient and continue management and observation for this patient. What are the anesthesia goals for labor, analgesia, and preeclampsia? First, we have to establish and maintain hemodynamic stability. Then we have to provide excellent analgesia to prevent complication of preeclampsia, like intracranial hemorrhage, renal failure, pulmonary edema, eclampsia, and we should also be able to rapidly provide anesthesia for cesarean section. Benefits of regional anesthesia for labor in preeclampsia patient. First, it will provide superior pain relief. It will reduce blood pressure, 20% reduction in blood pressure, and small reduction in SVR and maintaining of cardiac index. The Doppler velometer shows epidural analgesia reduce the SD ratio in the uterine artery by 25% to the level of the non-preeclamptic patient. And this decreased vasoresistance, it will also relieve the vasospasm. Epidural analgesia increase the intravenous blood flow by 77% in severe preeclampsia. So it will improve placenta blood flow, and it will reduce maternal blood pressure. Fluid management. Okay, fluid management. Most of the preeclamptic patients, they have restricted blood volume. So the giving of the fluid the optimal approach to the fluid management remain controversial due to the potential pulmonary dysfunction and impaired renal function. Fluid should be given with the monitoring, invasive blood pressure monitoring, with or without non-invasive cardiac output or transesophageal echocardiography. Volume expansion is not recommended. Fluid should be limited to 80 ml per hour or 1 ml per kg per hour. In case of hemorrhage, loss should be replaced appropriately. Administering of fluid challenge, it will be restricted for before hydralazine administration or before neuroaxial anesthesia initiation or in immediate delivery, or fluid challenge is recommended also in patient with only have volume deficit and suspected or can be confirmed. Corticosteroid administration for severe preeclampsia and HELP syndrome, it will improve the platelets, and as I mentioned, it will improve fetal lung maturation. Serious management, serious maternal complication in patient with the HEL. I discussed before DIC, placenta abruption, acute renal failure, pulmonary edema, cerebral edema, retinal detachment, laryngeal edema, subcapsular liver hematoma, liver rupture, acute respiratory distress syndrome, and maternal death. Pre-anesthesia preparation. Airway is commonly edematous. Difficult airway management, we have to keep difficult intubation thoroughly accessible to us. Hemodynamic monitoring, we prefer to insert arterial line just to have beat-to-beat blood pressure measurement, especially during induction in the anesthesia and during extubation, and during giving labetalol. Fetal heart monitoring is requested. The need for arterial line also for frequent of blood gas to monitor the pH of the patient, lactate level, and to see if the patient is arterial oxygen tension, to check the oxygenation with the arterial blood gas. Use of calculated systolic blood pressure variation to estimate intravascular volume pull status, particularly in the setting of hemorrhage. No indication for pulmonary artery catheter. This is the update paper. No indication for pulmonary artery catheter. Before, we used to admit the patient to the intensive care unit, insert pulmonary artery catheter, and check the cardiac output and check the SVR and give the treatment accordingly. Nowadays, no rule for pulmonary artery catheter insertion. TEE is useful technique for valuable information about volume status, chamber size, wall thickness, and ventricular function in a critically ill patient. Neuraxial analgesia for labor and delivery, continuous lumbar epidural infusion, analgesia or combined spinal epidural analgesia are preferred method for pain management during labor. Advantage for continuous epidural infusion and composed first provision of high quality analgesia, attenuates the hypertension response to pain, and also reduction level of the circulating catecholamine and rapid initiation of epidural anesthesia in case of emergency cesarean section. Coagulation status, neuroaxial anesthesia will provide if the platelets count more than 80,000. If the patient has a platelets count between 50 to 80, you have to balance the risk. And now the thromboelastogram or rhythms, they are, it needs more future study to give us an idea about the platelets function in case of the patient platelets less than 80,000 and the patient need contraindicated for general anesthesia. Recommendation for a neuroaxial anesthesia for patient with a preeclampsia, it will be first, it should be provided by expert or skilled person. Single shot spinal better than multiple attempt. Then use of flexible wire embedded epidural catheter reduce the epidural vein trauma, and patient should be carefully monitored after delivery for a neurologic signs that may bleeding and create of the epidural hematoma. Platelets count should be checked before removal of the epidural catheter. Imaging study, neurology or neurosurgical consultation should be obtained in case any suspicion of the epidural hematoma. Lower concentration of local anesthesia is advisable because there is no, it will not mask the early onset of epidural hematoma. Sometimes they are mentioning about the vasopressor should be used in preference to instead of large volume boluses to treat hypotension. Give vasopressor, don't give too much fluid. Avoid local anesthesia solution containing epinephrine, and smaller dose of epinephrine and phenylephrine are required to restore maternal blood pressure during anesthesia.
1 minute.
In our institute, we prefer phenylephrine infusion. Anesthesia for cesarean section. Neuroaxial anesthesia occurred before spinal anesthesia or combined spinal anesthesia. Prefer combined spinal anesthesia because post-operative epidural infusion, it will reduce the pain and it will reduce blood pressure. Resuscitative fluid management strategy and use vasopressor, don't give too much fluid. Phenylephrine infusion, as I mentioned. Continuous magnesium sulfate post-operatively. Close monitoring in recovery room and titrate up antihypertension in recovery room. Hazard of general anesthesia, airway edema worsen during the disease because we have mandatory to examine the airway before induction. Laryngoscopy and intubation may lead to severe hypertension, so we have to blunt this reflex by giving labetalol and GTN, and also we can give remifentanil 0.5 microgram per kg before induction of anesthesia. Place radial artery cannula before induction of anesthesia. Verify that the smaller size of endotracheal tube. Epidural equipment needed for difficult area management should be present, and denitrogate the patient with the 100% oxygen before induction of anesthesia. Give labetalol 10 milligram before induction. Fetal heart rate should be monitored during labetalol administration. Consider alternative antihypertension medication like GTN or remifentanil. In severe heart failure patient, avoid propofol, or you can use etomidate, or titrate very small dose propofol. Consider a bolus of dose of labetalol, as I mentioned, is remifentanil, and in case any hypertension happen. Maintain volatile anesthesia agent 40 to 50 after delivery of the baby. You can give opioid, and about post-operative analgesia. Multimodal analgesia is requested. Avoid non-steroidal anti-inflammatory. Intrathecal morphine in case of spinal anesthesia. If you can give post-operative analgesia, either epidural analgesia, transverse abdominal spleen block, or quadratus lumborum block. Post-operative pain management. Close monitoring by direct pressure monitoring, arterial blood gas, and risk of pulmonary edema is we have to consider, and with sustained hypertension, stroke, and venous thromboembolism, airway obstruction, and seizure. We can conclude that the preeclampsia is a serious multi-organ system disorder of pregnancy characterized by the global endothelial dysfunction. The acute cause is still and remain, even with the many studies, and they put many prophylaxis, but still there is no effective prophylaxis. Delivery is the only effective cure. Magnesium sulfate has been proven to be beneficial medication to prevent and treat eclampsia. Epidural analgesia for labor pain management. Regional anesthesia is superior for cesarean section than general anesthesia, and also preferred. Thank you so much.
Thank you, Dr. Gabana. I'd like to invite all the presenters to take a seat at the front over there. Over there. Does anyone have any particular questions for any of the presenters? I'll start with you, Dr. Jumana. I have a question for you. Thank you. So we agreed safe to do a spinal epidural in these patients. Let's talk about the eclamptic patient. I have a question for you. So if the seizures are controlled and the platelet count is 60 without any other problems, not a complicated airway, patient is fasting, what would your experience, having worked in King Khalid and at King Saud, be for this patient? Platelet count is 60.
Okay, thank you for this question.
Yeah, so it's in a gray area.
Yes, actually, this 60, our target is 80,000, but 100,000. But in case of 60, we have a routine. We can take a sample and we can do thromboelastogram and check the platelet function. If the platelet function is normal and the study is normal, we go for spinal anesthesia.
Okay, thank you. Kim? I have a question for you, Dr. Adil. It's a follow-on to the phenylephrine infusions in management of patients with cardiac disease. In addition, I want to talk about aortocaval compression. I think Dr. Mohammed agrees. In England, every patient, or in Europe generally, every patient's usually in a left lateral tilt, which I remember in my first days in anesthesia here, the moment I asked for left lateral tilt, the surgeon was not very happy because they're not used to it. So what's your practice at King Saud, King Khalid, in terms of phenylephrine infusion and left lateral tilt in the management of cesarean sections?
For vasopressor, we usually start with phenylephrine infusion to prevent post-spinal hypertension, either for cardiac patient or non-cardiac patient, because it provides an easier control and lower incidence of swinging of blood pressure compared to boluses. I mean, if you are comfortable with boluses, you can still give a boluses, provided that you prevent the hypotension secondary to drop in the SVR without affecting the cardiac output. Regarding the left uterine displacement, it's very useful, but sometimes the obstetrician cannot tolerate this position and they ask to remove the wedge. So it depends, but if we really need to increase the preload, we can negotiate with them.
What's your experience, Dr. Mohammed, on this particular subject of left lateral tilts and phenylephrine infusion?
I agree with the trial about giving phenylephrine infusions. The thing about boluses is that you get like what we call hemodynamic pharmacokinetics. If you're comfortable doing that, fine, do it, but you'll get swingings of the hemodynamics. It's better, of course, to give infusions. When you said in the UK everyone gets, yes, everyone gets a left lateral tilt, everyone gets a wedge. Surgeons are trained to operate in these conditions. If you want to change this here, then we have to discuss with surgeons and training the fellows and residents that this is an important part for improving the hemodynamics in obstetric patients. I've seen people who do left lateral tilts for the operating table, which is not very effective enough in improving the aortic cable compression syndrome, because you need an angle of about 20 degrees. If you look into the manufacturing manual of the table itself, the maximum it can get is 20 degrees. So it's going to be very difficult to tilt the whole woman 20 degrees. So the wedge gives you better and advantageous conditions to operate in these kind of situations. If the surgeons are not comfortable with this, it's just a temporary part in the operation until we deliver the baby, and then we can just take the wedge away. So again, it comes to communication. Tabby, you just speak to the surgeons, tell them how important is that. And as Dr. Abed said, if his patient was having, for instance, as he was talking about this topic, cardiovascular problem, for instance, patients having pulmonary hypertension, all kind of these things, you will need the venous return to be in its optimal condition. So in this kind of situations, of course, we have all to compromise in order to reach the best outcome for the patient.
Any questions, anyone? This is my last question, if no one has any questions, but this question is for you, Dr. Mohammed. So a patient with neurological disorder, let's say meningomyelocele, L4-5 level, and nowadays, you know, there's been a lot of talk about segmental spinals, even doing spinals as high as T4, T5, without any pre-existing imaging. So if you have a patient who has spinal bifida corrected without any imaging in an emergency scenario, would you consider doing spinal at maybe level L1, T12? Would you?
It comes down to how comfortable is the anesthetist to do this kind of techniques. Okay, down to the training and down how easy is it to perform this kind of procedures. In the study I've brought you in my presentations about the 13 years experience in Italian tertiary center, when they're given patients with spinal staphylomas, these GAs for all of them, it was all in context of an emergency. So if you read within the article itself, they said if they had the time, they would have given spine at a higher level than the level of correction, because they are all senior anesthetists which were doing that. So the problem with spinal dystrophy is basically the conus medullaris, which is the lowest part of the spinal cord is low, usually in this kind of patient, set lower than normal. So instead of ending at L1, L2, it ends about L2, L3, all right? So if you are comfortable doing a spinal anesthetic or segmental spinal anesthetic at a higher levels, definitely go for it. I've done it a few times in my life in situations like this, but again, it comes to how comfortable is the anesthetist to do that. If you're comfortable to do that, and you know the level where the correction has been made, definitely go with it. It gets you better outcomes. Thank you.
Thank you very much. Yes, please.
Regarding to phenylephrine infusion, usually we established this service long time ago in our labor room, and we used to train our resident about phenylephrine infusion. We would start the infusion, and when we would start intrathecal injection of local anesthesia, we initiate phenylephrine infusion. The preparation, it will be 15 milligram per ml, 20 cc range, we connect it, and we start with the dose of 3 microgram per kg. And regarding to the left uterine shift, we immediately after positioning the patient in supine position, we tilt the table, we tilt the table, and they will clean the abdomen, they will break the patient, and if the surgeon requested from us to adjust the table, we will keep the table in normal position. Otherwise, we'll continue with the left lateral position until the baby delivers. Regarding to fetal infusion, may after delivery of the baby and giving baba, we have to increase a little bit dose because of the effect of baba and oxytocin. And after that, after 17 minutes from intrathecal injection, the blood pressure will be improved and we'll start to titrate down phenylephrine, and it will be off at the end of the procedure. Thank you so much.
Thank you very much. I will ask Dr. Maha to present on behalf of. Yeah, please come to the front. Dr. Alaorebi, do you mind just taking the pictures for us? Ladies first, Dr. Jumana. Thank you very much. Thank you, Dr. Adil. Please come and join us. Thank you for the presentation. And Dr. Mohammed, please come and join us. And thank you very much. Now it's our break time. We'll convene as per the program. So we'll come back for the next session at the correct time, okay? We're a bit ahead of time, but we'll follow the program. Thank you.
السيشن اللي جايه ناصر وريم، صح كده؟
تقدر اللايت سكرين تخليه اوف بعد ما يخلصون. تصوير اللايت اوف تطلع كلهم صورهم سوداء. فهمت قصدي؟
تصوير اللايت ايه؟
هم الحين بعد ما نخلص يسوون صح سبيكر مع بعض كل السيشن صح كذا. ف الباك جراوند
نقفل الباك جراوند خلاص
اذا تقدر يعني، او انه ما عندهم اضاءه كويسه يعني.
طيب
لسه ما حد
لا قال لي عشان تستارت،
عشان هو الكلام اللي في البداية مهم. خليك هنا
شوف هذا التايمر بس بدأ بدري.
لا ما حنعيد تاني، هنعمل له ستوب ونرجع نعمل له ريفورمينج. ايوه بس استنى شوي. يلا استنى دقيقة كمان، خدي لهم دقيقتين كده ولا نبدأ؟ خلاص نبدأ يعني أعتقد المهمين كلهم موجودين خلاص.
Assalamu alaikum. Good morning, everyone. Thank you for joining us today in this important session on anesthesia safety, insight, and closing gap in the safe practice. Our first distinguished speaker is Dr. Mohammed Nasser. He is a consultant in anesthesia and intensive care unit at King Fahad General Hospital, Jeddah, Ministry of Health. He served as head of department and OR service and lead the department since 2003. He held King Saud Fellowship and Saudi Board in intensive care. As well, he has a fellowship in critical care from King Faisal Specialist Hospital and Research Center. He's also held a bachelor and master degree in law, and he is a figure in medical legal committee and certified instructor in ECLS, difficult airway and conscious sedation. Now he is a supervisor and leader of anesthesia and OR in Ministry of Health. Without further delay, let's welcome Dr. Mohammed Nasser.
Thank you. Microphone. Thank you very much, Dr. Adil. Today we are going to talk about the role of anesthesia, the role of health clusters in anesthesia practice. As we all know, health sector transformation program. So what is the focus of the Saudi visions in 2030s on transforming the health sectors? They are focusing of a vibrant societies. الرؤية في 2030 بتنظر إلى أننا يكون عندنا مجتمع حيوي. So the strategic objective of the health transforming programs is to facilitate access to the health service and to improve the quality and the efficiency of the healthcare service. This is the most important things. And to enhance preventions against the health risk, plus promote the traffic safeties. Now, what is the current state of the healthcare systems in the Ministry of Health? Ministry of Health is the regulators, المنظم, supervisor, المراقب, service provider, مقدم الخدمة, and the funders, which is الممول. They are serving all these processes: regulator, supervisor, service provider, and funder. Now, the new modalities will look at what a healthcare system will look to the futures of the transforming, that the Ministry of Health will be only the regulator, the supervisor, and the legislators. يعني حتكون المنظم, المراقب, والمشرع فقط لا غير. They will not have any further things. Now, who's going to provide the service? The Health Holdings Company, الشركة السعودية القابضة, through 20 clusters. And who's going to be the founders? The ممول, the National Health Insurance Centers, which is مركز التأمين الصحي المتوفر. We will provide the service through the employed individuals, and then the virtual clinic, home care, and the primary care, and finally we'll go to the specialized hospitals. This will be the sequence. Yani these are the directions of the sequence. So what is the Health Holding Company? الشركة الصحة القابضة. It's a national state-owned company, شركة وطنية, responsible for providing comprehensive and integrated health care. يعني they are looking to get a service بشكل متكامل وبشكل شامل through the 20 health clusters serving all the regions of Kingdom of Saudi Arabia. What are the responsibility? Building, developing the health clusters is the number one. We are helping the health cluster. As we said, we have 20 health clusters, but here in Riyadh, we divide the health clusters in Riyadh with two, 3 clusters, and in Jeddah 2 clusters. They design the guideline, the strategies, and the planning. They manage assets and the human capital plannings, الموارد البشرية, and setting the priorities and the allocations. As we can see, these are the numbers of the clusters, and these are the approved bed capacities for such things. For example, here in Riyadh, we have a 44 hospital where the number capacities in the Ministry of Health is about 9,000, and we have 3 clusters. Mecca and Jeddah regions, we have 2,600 and 3,400 where there is 10 and 14 hospitals, and so on. So as you can see that Riyadh is concentrated with 44 hospitals, and it's provided the highest communities and the highest numbers of population. That why there is a more focus towards such directions. All the other regions, Tabuk, Qasim, حائل, الحدود الشمالية, all these things have got a visualized numbers of hospitals and visualized numbers of beds. The clusters will be responsible about each area. So this is the existence, Ministry of Health hospitals, including the bed capacities, including the hospitals and approved capacities. What are the foundations counseling? المجالس التأسيسية. It's a council responsible for overseeing and establishing strategies and goals for the health cluster to ensure the accountability in care. They are distributed across the regions where there is a northern regions, central regions, eastern region, and southern regions, and western regions. So they are the one who distributing the clusters according to the regions, المجالس التأسيسية. What is the National Health Insurance Centers? مركز التأمين الصحي. It's a center that organizally linked to the Ministry of Health with legal personality. Legal personality mean لها شخصية اعتبارية مستقلة إداريا ولها شخصية اعتبارية مستقلة من الناحية التموينية. فهي شركة بتمون وزارة الصحة and it's usually مرتبطة بوزير الصحة. It's aimed to pursue the health service, تشتري الخدمة and related need for accredited health institutions. What are the responsibility? Purchases the health services from accredited health institutions من المراكز الصحية المعتمدة and provide a comprehensive health benefits to the center beneficiary تلبي الاحتياجات الأساسية and supporting the responsiveness to the healthcare's need. It's control the cost, which is very important to control the cost in a transparency and a big competitions where we will compete with the private sectors as well. So it should be in transparency and in good competitions. It improve the healthcare services. That's what we are looking for, that we want to go into a level where is a competing the private levels where it's going to be on the same directions. And it will manage the cost among the providers. Ensure the availability of high quality service. So these are the most important things that I just give you as a clue where we are, where we will be the past of the Ministry of Health and will be the futures of the Ministry of Health. Now we are starting the clusters, we are starting the guidelines, and we will have a protocols for the clusters in a sequence, cascades, to be independently working alone and supervised by the Ministry of Health. For me, as a leader of Ministry of Health at this stage in anesthesia and OR, we can offer a range of initiatives and a proposal to the leaderships of the Ministry of Health to improve the quality of the anesthesia service. Now, what we did that in each cluster there is a supervisors of anesthesia and the supervisors of the OR. And these are followed or supervised by me as the leaders of the supervisors. Now, they have a special task and special plan. We will use the, number one, we're trying to unify the national anesthesia standard, and this is the most important things that I'm just focusing on the safety. Now we are talking about standardization, and the main problems that we have an individual's clinical and experience for each person's based on his clinical background and based on his educational backgrounds. And so what we want to know, and especially in the peripheral hospital, that we try our best to standardize the procedures and align in a global best practice with all help to reduce the variability and improve the quality. The most important thing is the difference in the variabilities, and this is the most important things. Strengthening the anesthesia service in Saudi Arabia, increase the number of the Saudi anesthesiologists. Now, if you just go, the current status of the Saudi anesthesiologists make about 18% of the total anesthesiologists in the kingdoms. to be totally independent. Of course, we need all the experience of all the peoples and all the nationalities, but we are in a progressive stage that need to be independent and totally independent. So 18% with the programs that starting from, let's say, 1994, and the Saudi board established around 2004, and now we are at about 20 years, and we still last year we reached into 18% still with the numbers of the resident and the specialist and the consultant, and we need to improve such a numbers. So what is the plan? We will expanding the centers and the acceptance rate, establishing the more training centers across the country, increase the acceptance rate of Saudi applicants in each centers with an arrangement of Saudi commissions of the health specialty, strengthening the technicians program. We don't have a special technicians program. We just have 5 hospitals with graduating anesthesia technicians with a baccalaureate degree. We were having all the nursing to be nursing anesthesia technicians before, and we were having a diploma from the المعاهد الصحية, which is a qualification that we have to stop. We are looking for a specialist technicians. Now we expand the numbers of the university to about 8 or 9, and we are establishing a systems for the anesthesia technician programs in the university. Continuous training of the anesthesia personnel, establishing a training program and specialized certificate for medical staffs in the field of anesthesia, making a privilege and recent advancement in the latest protocols. A mandatory training program, for example, in conscious sedation. Now it's a mandatory for Sabahi, and it's a mandatory for all the centers to start with. Difficult airway management, we have to have the workshops, and it's a mandatory. Regional anesthesia, now we are going toward the directions of the regional anesthesias in all the hospitals, especially hospitals in the periphery. And we're expanding the modern technology, investing in advanced anesthesia technology to improve the anesthesia outcome and to prevent the complications, such as advancing monitoring device. We add Massimo to all the kingdoms with a high numbers of all the things, including inotropies and BIS. I don't want to mention the numbers in millions, but it's more than 100 millions riyals. Ultrasound machine, now we are toward the directions of providing all the departments with anesthesia, ultrasound anesthesia machine. I don't think that now in each cluster there is no department without ultrasound. Rapid infusion set, now we are going toward such a directions, such as for the blood transfusions and for the fluid transfusions, and we are making a models of care, the model of care for the trauma, a model of cares for homeostasis measurement in the trauma, and the model of cares from a starting patient with high risk from the ER back to the ICU. So these model of cares, and we have a lot of initiatives in each clusters. Every supervisor there provide me a lot of things which is really promising and giving us a good directions. Cell saver is now amendations in each department in the anesthesia for the trauma per se. We will establish a fixed item for medical funding as they were previously unavailable. We are putting a new things in في التموين الطبي. We supply a lot of things in the modern technology. We are trying to provide the numbers of which is available on NABCO that will try our best to standardize, especially the National Guard, the universities, hospitals, and the military hospital. In NABCO, we will standardize the numbers of the items to be standardized in the Ministry of Health. And this is a project that I've been starting with for the last 6 months. I think next week or in the next 2 weeks we will be in a standardized manners. Finally, we collaborate a departmental improvement between the ER and between the strengthening the interdepartmental collaborations, reduce the waiting list, and this is one of the targets. and coordinate with the surgery, with the emergency department, with other department, encourage more daycare surgery, and this is directions on the control panels for all the clusters. Smooth the process, enable more daycare procedure, reduce the hospital stay, and increase the efficiency. Now we are preparing a regular quality report, and we have a 2 regular quality report that provide a continuous improvement in the anesthesia service, and this is through ADA and WASIN. In weekly basis for each cluster, we monitoring the operating outcomes and advanced daycare surgery enhancements. And this is a very new things that we are going toward. We looking for patient satisfactions. We're developing a survey and initiatives to measure the patient satisfactions. 937 is the number for any patient who complained from anything, and we should respond in 2 weeks' time, and anything has to be analyzed. We give the feedbacks, and we're trying to get for improvement. Pain surface, I know everybody interested for pain. So now we are planning to develop and managing the clinic and programs as a part of the anesthesia service to improve the quality and patients suffering from acute and chronic pain. Update the medical supply in pain, and I think we finished with this. Manage and establish an ongoing contract to ensure that they are annually provided with such things. The initiative can contribute to elevating the level of the anesthesia service, ensuring a delivery high quality care and guarantee the patient's safety. That's why we provide a decision of forming a scientific committee in the Ministry of Health. And this scientific committee is from a different specialty, from the National Guard, from the private sectors, from the medical cities, and with different specialty, university with a different specialty from all these time, and each of these members will be a part of our things as a part-timers, and we will provide them with all the tasks to reach into the target as initiative. Forming such a committee, goaling to update the medical consumables and items, review the update and existing medical consumable, and they did an excellent job on this. Expand the list of the consumables, include additional items in NIPCO, and streaming the medical supply and availability, and all medical supply and medications are now visible on the Ministry of Health dashboard. Now each clusters will send us a message in the dashboard that they don't have epidural catheters, for example, they don't have a central line, they don't have an ultrasound, and the response will be in 2 weeks to 1 month maximum to provide them with such a things. In case of shortage, each medical clusters will submit the request, and issues resolve in 2 weeks up to 3 weeks. Actually, it up to 2 months, to be honest. Forming a scientific committees, provisions modern anesthesia equipment, and coordinated with the monitoring and increased surgical procedure, reducing patient timing and focusing on increasing the number of operation performed, and reduce the waiting list and enhance the operating room to meet the risk demand. Study work system with defining anesthesiologist working hours, and this is what we are working toward the directions, but so far we don't succeed on this. And this is things that in the dashboard that we are following in the systems. We start in 2002-04 with numbers of 3,000 to 4,000 operation per week. And we ended at the end of the 2024 to 10,400 cases per week in each cluster. I think the last 2 weeks we reached the numbers of 12,000 and above. So this is a very good improvement. On the other hand, we improved the daycare surgery significantly, and the reducing the waiting times for the patient to work through. Thank you very much.
Thank you, Dr. Nasser, for the nice presentation. Our second distinguished speaker is Dr. Amr Al-Kinani. He is a consultant anesthesiologist and head of obstetric anesthesia unit at King Abdulaziz Medical City in Riyadh. He will talk about advancing safety and comfort in obstetric anesthesia. Without any further delay, please welcome Dr. Amr Al-Kinani.
Hello, everyone. First of all, I would like to thank the scientific committee to give me this chance to present today. Thank you. Yeah, sure. So we're going to talk about advancing safety and comfort in the obstetric anesthesia. And our object for this talk will have a slight introduction. Then we'll talk about the enhanced safety through best practice and emerging techniques. Third objective will be improve comfort with the patient-centered innovation and explore future direction. And we'll have at the end conclusion. So why this topic matter? Maternal mortality remain a critical issue with anesthesia-related complication contributing to adverse outcomes. And patient satisfaction in obstetric anesthesia is strongly linked to pain control, autonomy, and emotional experience. This statement, published in 2022 by the American Society of Anesthesia, it states that anesthesia-related maternal mortality is consistently with lowest frequency among all factors contributing to maternal mortality. So thanks God. Okay, our key challenging, physiologically, pregnant ladies have different physiology, and for example, they have increased cardiac output and decreased functional residual capacity, aortocaval compression, and also urgency of cesarean delivery. Decision to delivery may impact the fetal outcome, and postpartum pain and mental health. And I want to focus on this, the last key challenge, which is the postpartum pain and the effect on mothers for a while. So what is the burden of postpartum pain? Postpartum pain is a leading cause of prolonged recovery and delay bonding and persistent opioid use. And study shows that 60% of women report moderate to severe pain after vaginal delivery, and 30 to 40% of cesarean patients experience severe pain, 24 to 72 hours. Persistent pain, which may persist to more than 6 months post-delivery, occurs in 10 to 15 of the women, often linked to poorly controlled acute pain. Who's at risk? Surgical trauma. For example, with cesarean is more than vaginal delivery, but it can happen with both, and also pre-existing chronic pain or opioid intolerance. Also inadequate multimodal analgesia. What is the impact on mental health? Poorly managed postpartum pain is strongly associated with postpartum depression, and women with severe acute pain are 2 to 3 times more likely to develop postpartum depression. Opioid use further increased postpartum depression risk. Post-traumatic stress disorder, traumatic birth experience like emergency cesarean section and uncontrolled pain correlate with PTSD. Breastfeeding difficulties, pain interfere with lactation success. So we'll move to the second outline of this talk, which is enhancing safety in obstetric anesthesia. First thing, how to prevent neuroaxial anesthesia complication. The most common is hypotension management. And if I can ask a question, how many of you use nor-epi as a first-line treatment for hypotension caused by neuroaxial? Can I see hands? So no one uses it. Okay, one. Okay, so let's compare phenylephrine with norepinephrine. Norepinephrine now is getting popular due to stable heart rate and cardiac output, and neuroaxial anesthesia for cesarean delivery cause sympathetic blockade, leading to vasodilatation and hypotension in 70 to 80% of the patient. Both phenylephrine and norepinephrine are first-line vasopressors, but key difference between them, as we gonna see in this table, regarding the mechanism of action, phenylephrine is pure alpha-1, while norepinephrine is alpha-1 and beta-1 agonist with a ratio of 4:1. Phenylephrine is potent vasoconstrictor, while norepinephrine is balanced vasoconstrictor. Phenylephrine may decrease the cardiac output due to reflex bradycardia, while in norepinephrine there will be no change or slight increase, because of the beta-1 effect. Heart rate, phenylephrine can cause baroreceptor-mediated bradycardia. With norepinephrine, there will be no or slight bradycardia. Uterine blood flow preserved if the blood pressure is stable with phenylephrine, while in nor-epi, it's better preserved. So nor-epi's beta-1 activity, nor-epi's beta-1 activity offset reflex bradycardia, maintaining cardiac output better than phenylephrine. And phenylephrine pure alpha-1 effect, which can reduce cardiac output by 20%. So regarding blood pressure control, phenylephrine versus nor-epi, both effective in treat hypotension, but nor-epi require lower doses, typically 4 to 6 mics per minute, and phenylephrine is 50 to 100 mics per minute. Nor-epi causes fewer episodes of bradycardia, heart rate less than 50, of 5% compared to 20% with phenylephrine. Regarding the fetal outcome, umbilical cord pH, no significant difference between them, and nor-epi may improve fetal lactate level. Side effects, again, bradycardia can happen more with phenylephrine, rare with nor-epi. Nausea and vomiting may happen with phenylephrine due to decreased cardiac output, but less frequent to happen with norepinephrine. Hypertension, risk of bolus rapidly, can cause hypertension, while with nor-epi it's self-limiting beta effect. Extravasation injury, low with phenylephrine, but higher risk with nor-epi. So nor-epi is preferred in patients with baseline bradycardia or cardiac disease. Dosing, 50 to 100 in phenylephrine as a bolus, 4 to 8 mics nor-epi. Infusion rate is about 25 to 100, which equal to 0.5 to 1.5 mics per kg per minute. In nor-epi, it's 4 to 8 mics per minute, or 0.05 to 2.1 mics per kg per minute. So what is the advantage of nor-epi? More stable hemodynamics and easier titrate. There is no roller coaster effect. Rescue bolus for hypertension, we mentioned it in the boluses. The caution with nor-epi and phenylephrine, we have to avoid high dose of phenylephrine boluses, which can cause severe bradycardia, while nor-epi preferred IV use is safe, showing no extravasation risk at low doses, as mentioned by a study published in 2021. Why nor-epi is gaining popularity? It maintains cardiac output better, critical in preeclampsia, obesity, and cardiac disease, decrease the risk of pulmonary edema, fewer episodes of bradycardia, especially with patients with baseline low heart risk, like heart rate, as athletes. Potential placental benefits: beta-1 activity may prevent excessive uteroplacental vasoconstriction, and easier hemodynamic stability, less peak and trough than phenylephrine. Limitation: nor-epi is not yet approved by FDA for obstetric use, and phenylephrine remains cheaper and more familiar in many institutions. Limited nor-epi data in high-risk group like severe preeclampsia. Other treatment of hypotension caused by neuraxial is fluid strategy by co-loading 500 to 1000 ml crystalloid, which is superior to preloading. Okay, other than hypotension, the failed neuraxial block and rescue technique. We can use the combined spinal epidural and single shot spinal for prolonged labor. Let's talk about single shot spinal, which is quite interesting. And the drug uses for single shot spinal for labor can be fentanyl, which is pure opioid, can have minimal motor block. Sofentanil, more potent than fentanyl, and bupivacaine 1.25 to 2.5 milligram can add sensory block with increased duration. Morphine is rarely used alone, but it can be used. And the most common combination is the fentanyl 15 mics with bupivacaine 1.25 milligram. It will give you fast onset and 2 to 3 hour analgesia. Clinical application: ideal candidate for single spinal shot, early labor with rapid progress. Patient require analgesia but is likely to deliver within 1 to 2 hours. Rescue limited setting where epidural catheter or combined spinal epidural are unavailable, like some low-income countries. Patient preferences by avoiding catheter placement and reduce interventions. Contraindication: unpredictable labor duration, because of the risk of wearing off before delivery, and need for prolonged analgesia. Also allergy to local anesthesia and opioid. Efficacy and limitation: the pros of single shot spinal: faster onset, 5 to 10 minutes, versus epidural is 15 to 30 minutes. No catheter related complication like migration or infection. Lower risk of hypotension versus combined spinal epidural. The cons of single shot spinal: limited duration, it's 1 to 2 hours depending on drug. No opioid for redosing, no option for redosing, unlike the combined spinal epidural. Higher risk pruritus or nausea due to opioid. This is another comparison of the techniques. Single shot, it's 5 to 10. No redosing. The epidural and combined spinal epidural, we can redose anytime, but the hypotension is low risk with single shot spinal. So it's best for short, predictable labor. Otherwise, combined or epidural preferred. Practical consideration: drug selection. You can use opioid only, fentanyl 15 to 25 mics, minimal motor block but short duration. Opioid with low dose of bupivacaine, example 1.25, extend analgesia and motor block. Monitoring: fetal heart rate change. Opioid may cause transient fetal bradycardia, usually benign. Maternal side effects: pruritus 30 to 50%, and nausea 10 to 20%. Rescue option for single shot spinal: repeat spinal with a risk of total spinal and hypotension, or convert to epidural or combined spinal epidural if there is time for that. Systemic opioid and Internox. So post-dural puncture headache. Now we talked about hypotension, and failed analgesia, than post-dural puncture. I'll not talk about too much about this issue. It's 20 small gauge will decrease the risk of post-dural puncture headache. If you use 27, it will decrease by less than 1%. And early epidural blood patch if the conventional or conservative measures failed. Okay, managing high-risk scenario. In preeclampsia, neuraxial preferred, and avoid ephedrine because of the hypertension risk. For obesity and obstructive sleep apnea, ultrasound guided neuraxial, which improves the success time and decrease the time of trial, and capnograph post-op for opioid-induced apnea risk. Maternal hemorrhage, tranexamic within 3 hours, reduce mortality and cell salvage. And I will have few slides about the cell saver technique in obstetric because it was controversial before. It's is a conservative technique that collect, filter, and reinfuse patients' own blood lost during surgery. In obstetric, its use has been controversial, but increasingly accepted in higher risk cesarean deliveries to reduce blood transfusion. So how it works: a blood collection, suction device, aspirate blood from the surgical field, mix with anticoagulant to prevent clotting, then filter and washing by centrifuging RBCs from amniotic fluid, debris, and free hemoglobin. Leukocyte depletion filter, extra for further filtration, and reinfused by washed RBC 250 to 300 per units reinfused. So what is the key modification for obstetrics? It's double suction technique. The first suction, discard initial amniotic fluid. Second suction to collect blood for processing. Leukocyte filter, removal fetal cell and squamous cell and cytokines. Indication for cell saver in cesarean section. According to NICE guidelines, which updated in 2023, consider cell salvage and anticipated high blood loss like placenta previa, accreta, uterine rupture, patient who decline allogenic blood like Jehovah's Witness, severe anemia preoperatively. Not routinely recommended for low risk cesarean section. So high risk scenario where cell salvage is most beneficial in placenta accreta spectrum, up to 9% reduction in allogenic transfusion, and major placenta previa with prior uterine scar, maternal coagulopathy or massive hemorrhage. So what is the safety concern? Risk of amniotic fluid embolism. The old concern was theoretically risk of reinfuse of amniotic fluid. The current evidence shows that no reported amniotic fluid embolism cases with modern cell salvage. The safety measure: discard initial suction, first 500 ml, use leukocyte filter, and fetal-maternal hemorrhage and anti-D prophylaxis for patient who's negative, rhesus negative. Cost: it's cost effective in high risk cases and require trained staff and equipment availability. Clinical evidence: there is multiple trials. The last one was the NICE trial, which updated in 2023, recommend considering cell salvage in high risk cesarean section, but not in routine use. Efficacy data: reduce allogenic transfusion by 50 to 70% in high risk cesarean section. No increased risk of DIC or infection. So let's move to the improvement comfort and patient experience. For labor analgesia innovation, one of the innovation is the programmed intermittent epidural bolus, or we will refer to it by PIEB, and patient controlled epidural analgesia, which is the PCAA. The gold standard for labor analgesia, the combination represents a major advancement in labor analgesia by combining automated timed bolus, which is the BIAB, to maintain baseline analgesia, and on-demand patient-controlled bolus, the BCAA, for breakthrough pain. This system has largely replaced continuous epidural infusion due to superior outcome. Typical setting, this is a technical setting. BIAB 5 to 10 ml every 4 to 60, and BCAA 5 ml by demand, and the medication will be the same. So the mechanism of superiority, the BIAB creates pressure waves that improve drug spread in the epidural space, while the BCAA allow patient autonomy for breakthrough pain. Synergistic effect of 30 to 50% reduction in total local anesthesia dose versus continuous epidural infusion. Clinical benefits: improve analgesia quality, 15 to 20% lower pain score versus continuous epidural infusion, 40% reduction in breakthrough pain episodes, reduce intervention need, like 50% fewer manual clinician bolus required, 60% reduction in instrumental delivery. Enhanced maternal satisfaction, 90% satisfaction rate versus 70% with continuous epidural infusion. Better mobility score, important for labor progression. So this is, okay, we're gonna skip this slides. What is the advantage over traditional method? 30% lower risk of motor block, 40% reduction in hypotension episode, no increase in fetal bradycardia. Monitoring requirement, regular assessment of sensory level, target T10 to L1 in the first stage. Watch for asymptomatic block, asymmetric block, 50 to 10% incident. Monitor of pruritus, opioid related. Special population like obese patient may require 20% higher volume, consider ultrasound guide catheter replacement. Preeclampsia, excellent option, stable high hemodynamics, and may reduce dose further with ropivacaine low dose, 0.05%. Future direction, smart PIB pumps by using algorithm adjusting bolus timing based on labor progress. Wireless pumps allows ambulation without tethering, and biomarker adjustment. Cesarean delivery comfort, gentle cesarean technique, skin to skin in OR, improve bonding, and clear drapes, which may reduce maternal anxiety. Multimodal analgesia, intrathecal morphine plus tab block, decrease opioid use. IV acetaminophen, reduce pain score. Non-pharmacological method like hypnobirthing, decrease anxiety, and virtual reality for labor pain. Future direction, AI and predictive analysis, machine learning, predict hypotension, and smart epidural pumps, auto-adjust dosing. Novel drug and technique like using dexmedetomidine adjuvant, which may decrease the shivering and analgesia, and liposomal bupivacaine for prolonged block. Global and equity-focused care, low-cost spinal kit, WHO Safe Surge Initiative, and addressing racial disparities. Conclusion: safety, proactive management of hypotension, hemorrhage, and high-risk case save lives. Comfort, multimodal patient-centered approach, enhanced satisfaction. In the future, AI, novel drug, and equity-driven care with redefined obstetric anesthesia. A call to action by adopt Iraq protocol or enhance recovery after cesarean protocols, prioritize patient-centered innovation, engage in research and emerging technique. Thank you.
Thank you so much, Dr. Amir, for the insight today. It was an excellent talk. Our next speaker is Dr. Mohammed Sahibani. Dr. Mohammed Sahibani, he will talk about NORA in pediatric anesthesia. Dr. Mohammed Sahibani is pediatric anesthesiologist at King Abdulaziz Medical City, Ministry of National Guard. Please welcome Dr. Mohammed.
اضغط شيء 30 seconds بس بنزلها ثانية واحدة. هذا مو شغال، الاثنين مع بعض نواطي شوية. بص هم شايفين ده، لو في نوتس هتظهر لك هنا يمين وشمال. ماشي، قدام ورا. ادي next slide. اوكي جدا.
Assalamu alaikum. Thank you for having me today, and special thanks for the organizing committee, and also special thanks for you for your time. I'm going to talk about NORA in pediatric. What's the NORA? It is non-operating room anesthesia, or anesthesia at the remote area, or outpatient anesthesia, or office-based anesthesia. Our aim, we're going to focus on patient safety, also minimizing the physiological discomfort and pain, controlling anxiety, and also controlling the movement to allow the safe and completion of procedure, and also to return the patient to the baseline and for safe discharge. What is make NORA special? As we know, number of NORA activity has increased worldwide. This article published in 2023 showing that data from 2015 up to 2019 or 2020. It's reviewing about more than 200,000 cases. They found that about 22.7 or 23% of pediatric cases in the United States, they do it outside of the OR. Also, the procedure have become more complex, and as we know, sometimes the cost for the OR, the cost outside of OR less than cost for doing the case in OR. As we know, sometimes we are flexible when we work on an OR with the full setup, than other area or less safety area. And also we know the anesthesia playing more important roles between the patient and procedure and the environment. For the patient consideration in anesthesia, as we know in the pediatric, each specific group has special consideration. When you are treating or dealing with a premature, it's different when you are dealing with neonate. Also, when you are dealing with infant or child or toddlers or young adult. Each one has special concern regarding or special anesthesia concern regarding the dealing with or treating them. Also, what's the other challenge in pediatric patient? Not as adult, you are treating also the family. You have some time to share with the family, your decision, your plan, and also sometime you have to treat the family before the baby. Other challenge in the pediatric, as we know, most of the people, they are afraid or some have some concern when they are dealing with a pediatric and OR. It will be this more stress if you are dealing with a pediatric or a neonate or any congenital or dysmorphic airway outside OR. Also, other challenge in the pediatric, usually most concern for the people in hospitals ward, the IV and difficult IV. And other challenge also in the pediatric, when you are doing the neuro, it is the temperature, as we know, the big concern, the hypothermia for the pediatric, this is a big concern. And the last one, it is what we know, sometimes the sick patient doing like a procedure or simple procedure, the most sickness patient, pediatric, we are preparing them for the OR. Some distance. About the procedure, as we know, sometimes the challenge, the nature of the procedure, including the patient position, grade of painful, some of the procedure, the duration, and what's the also optimum anesthesia plan, providing for providing the safe patient care, and facilitating the procedure to be completed. Also, discuss the plan with the procedurist guy for the emergency and adverse outcome. Location of the neuro. This is the most common location, radiological suite for the CT, MRI intervention, or cath or cardiac cath. Also the burn unit, different clinics, some dental, urology of the ENT, or also the mental health unit for also electroconvulsion therapy, endoscope unit, and for the oncology people, the radiotherapy and the chemotherapy unit. What's the ASA? There is a mini society. They're reviewing, if you review a mini society, reviewing the standardized and requirement. I will go with the simple one, the ASA. There is also a Society of Pediatric Anesthesia. There is other European, other American Academy. But this for ASA, minimum requirement at NORA location. We should have a reliable source of oxygen, also suction, scavenging unit, and also electrical outlet, and adequate light. And this most important, staff trained to support the anesthesia. And also, before starting, we should have the emergency card ready and checked. And also, the other most important, we should have a source of communication ready anytime, and also if in case if you need help, what's the code it can help you. And also, we need also the recovery unit or post anesthesia or post procedure care unit. This another symbol to just remember, SOBME, suction, oxygen, and airway, pharmacy or pharmacy, and monitor with the equipment. This is another guideline for non-anesthesiologist who are administrating sedation or analgesia outside of the OR. You should have anyone who administrating should understand the pharmacokinetic and pharmacological of the drugs. Also, individual monitoring of the patient. This depends on the level of sedation. If it's deep sedation, you should be alone, just like don't have any tasks doing other than monitoring the patient, or he can do minor tasks if he's doing moderate sedation. Also, individual capable of establish the airway or applying the positive pressure ventilation. Another individual with adverse life support or skill, he should be available or he should be in the room during the deep sedation. This is the most common medication used in sedation outside of OR. Well, as we know, all this like midazolam, ketamine, propofol, trying to be away, or a few, and also Prisdix, trying to avoid any opioid or any medication it may cause respiratory depression. What's the key safety consideration? The environment. As we know, this is not our standard room. It's not our comfort zone as an OR. Also, sometimes the space, is limitation, space limitation, and also sometimes the accessing the patients or the shared airway or patients away from you. And other things is equipment. Ensure as we mentioned before, the challenge in pediatric, specific age has different setup, different preparation. For that, also especially in MRI, we have the compatible. It's that our device or our tools is compatible with MRI or no. Also, as a safety for monitoring, we should be enhanced to the ASA monitor, standard monitor. Also, should continuous monitoring ECG and pulse ox and also capnograph. Also, if you have the duration, it's going to be the long time. You should consider depth of anesthesia. And also, for the personnel, should be like expert. Usually, we have in that site either board eligible or assistant or consultant who's doing the case. What's other challenge? I'm just going to go through few challenge in some location of Noura. As doing the MRI, is it this compatible with any tools or any equipment is compatible? And sometimes, as we know, there is a lot of challenge from applying the standard monitors. Also using your airway tools, or also having the ventilation part from the long circuit. Sometimes we have also issue with the pump, with anesthesia machine, with the suction, everything. For the endoscopy unit, we have a different procedure, either upper GI or lower GI. Also, there is some specific concern about the procedure, other than aspiration risk or perforation or bleeding or spasm or any other complication. We have to be aware and ready for managing that. Other location, the imaging suite also, is it patient, as we mentioned before, other than this compatible with MRI or no. We have like shared our patient away. Also for the procedure specific, the time, the temperature, contrast, any side effect from the contrast or any anaphylactic shock. For the cath lab, either neuro or for cardiac, the risk of the procedure itself is a specific concern other than contrast, the bleeding, the thrombosis. And also for the personnel who is doing that one, there is a lot of risk of hazard of radiation exposed the time during the procedure. Other location, either in ER or the ward or the clinic, if they are doing any specific procedure, they need for some sedation. What's the complication in Noura? Respiratory, that's the most common complication, and I think the most concern for everybody, the respiratory complication, either a spasm or apnea. As I mentioned before, sometimes depend on the site of the location of the complication of hypothermia from the procedure itself. As MRI for pediatric, we should prepare for that. Other common complication, aspiration or post-operative nausea and vomiting. And for the neonate, hypophonemia and hypoglycemia, we should monitor that. Conclusion, the key to efficient and safe Noura practice in children rely on how to assist the patient before the starting, the pre-op assessment or the pre-procedure assessment, understanding the anatomical and physiological variation in the children compared with adult, also knowing the unique pharmacokinetic and pharmacodynamic of individual sedation agent, and also they have the standby or backup ready or antidote ready, understanding the requirement of the procedure, the time. You should have The most one, you should have efficient team communication between the anesthesia and the procedures personnel. Take-home message. Safety guideline provided by ASA must be standardized for the neuro area. Also, individual institute should develop guideline to support the safe practice for the pediatric station. In hospital, where they are doing the neuro as a routine, same as a National Guard or King Faisal, they should design neuro team or sedation team. They can provide efficient and effective and safe anesthesia. Also, all participating must have adequate training, as we have in National Guard. They have even for the non-pediatric, for the GI people or for the intervention, they should have sedation certificate, same as CPR or as any course. This another take-home message. As we know, if the patient desatic in OR, what we said, like anybody said, like I need a mask or something, and we're expecting to deliver the face mask with different size or whatever. But don't be surprised to get this answer when you are doing anesthesia outside OR. When you ask for mask, that what could be answered. This another home message. Don't do any anesthesia or something out. Don't play with a dangerous animal out of the zoo, unless if you have plan B. Remember, anything could happen. Everybody, especially the surgeon or it's easy to blame the anesthesia. And last slide summary. Anyone has spent time with the pediatric, they have been witnessed the induction of anesthesia or of doing anesthesia that have gone very well or been very difficult. But a good and careful assessment of children with a risk factor or with any congenital anomalies or any challenge, and looking for the flexibility of plan and looking for the help in case of you need available also will make this perioperative plan for each patient smooth. Hopefully discuss some challenge will improve the child and especially with their parent experience, and sometimes make this less stress on you. Thank you so much.
Thank you, Dr. Sahibani, for the nice talk. Our next speaker is Dr. Haytham Bouya, who will talk about multimodal enhanced recovery analgesia. Dr. Haytham is a senior anesthesia specialist at Dr. Sulaiman Habib Medical Group, Al Alaya branch. Dr. Haytham, the mic is yours.
Good afternoon, everybody. This is my first time for me, so I would like to thank Dr. Maher Tayyem, Dr. Ibrahim, and Dr. Ahmed. I will talk briefly about, inshallah, about multimodal analgesia. First, we'll talk about the enhanced recovery after surgery, then multimodal analgesia, then how we can implement this system. And the objective here will be discuss how lack of standardization in preoperative care can negatively impact patient outcome, introduce the enhanced recovery after surgery as a potential means to help standardize preoperative care, discuss how poorly controlled postoperative pain can impact quality and care, discuss the multimodal analgesia and the framework of an ERASI protocol and discuss the practical and the human resources required to implement the ERASI protocol. So as introduction, first here we have a study that we have two groups of patients with the same age and same risk factors. And the difference here that we have, we implement on the first group the patient normal care, and another group of patient we have implement the standardized care. What we see on the y-axis here is the length of stay and the incidence of complication before the standardized of care and after the standardized of care. And what the difference is that the length of stay and the complication in the second group after we standardize the care looks the same. So the message here, we decrease the variability, because variability is a critical thing and it's the enemy of equality. Can patient outcome improved by standardizing preoperative care? Suppose we have a patient came to do a surgery for an reason, colorectal or something, whatever. What we see that the surgeon do meetings separately, anesthesia do meetings separately, and the nurses same thing. And because of that, the immediate challenge to improve the quality of the surgical care is not discovering a new knowledge, but rather how to integrate what we already know in practice. So about the ERASI protocol, it is a multidisciplinary care pathway from the decision to do the surgery of need procedure to retain the baseline level of function and the characteristics. It's an evidence-based, patient-centered care designed to reduce the patient stress, including rehabilitation, patient involvement, and it's integrated from home until the patient returns to normal function at home. The ERAS key component here, it's compounded of three: preoperative phase, intraoperative phase, and postoperative phase. From preoperative phase, we have pre-admission counseling, and let's talk briefly about pre-admission counseling here, because most of the patients don't know that may feel a little of pain after the procedure. And when we talk about a little of pain, it not means 0 or 1, sometimes it's 2, 3, or 4. Besides, we don't prefer to use the opioid analgesia method. So in the pre-admission counseling, it's very important to tell the patient about that. After that, we will go to bowel preparation, carbohydrate loading, and the pre-medication. In intraoperative phase, we have the regional anesthesia and multimodal analgesia, short-acting anesthetic agent, avoidance of fluid overload, short incision and drainage. In the post-operative phase, we have early mobilization, multimodal analgesia, prevention of nausea, vomiting, and early removal of catheter. So when we talk about preoperative phase, like we said, we have information management and patient education, nutritional optimization, and carbohydrate loading. And when we talk about the carbohydrate loading, means that we should encourage the patient to take clear fluid until 2 hours pre-op. And if we combine the free fluid with carbohydrate loading, either it's simple carbohydrate or complex carbohydrate, like some solutions have arginine or something, it will decrease the thirst, decrease the anger, decrease the stress on the patient, and at the same time decrease the insulin resistance. After that, we have the exercise and the rehabilitation, and some studies found that if we encourage the patient to move a lot before the surgery, by 2 weeks, the length of stay will decrease after the surgery. Bowel preparation as appropriate. And here is one study conducted in 2003. Yes, 2003, that showed us only 63 patients received education on pain management prior to surgery, and third of these patients already below the basic level of health literacy. That means this will complicate the patient task, either it's to take medication or to calculate the doses. In intraoperative, we will prefer to avoid of nasogastric tube except when we need it. We need to have goal-directed fluid therapy, not to overload, appropriate use of pre-medication, use short-acting anesthesia, like when we talk about desiflurane, sevoflurane, avoidance of post-op nausea and vomiting, and maximize the use of multimodal analgesia. For post-operative, like we said, we need to maximize the multimodal analgesia, stimulate the gut motility by early oral intake, early mobilization, and early removal of drains. Some study about early mobilization found that most of the patients for first day or post-op or in the post-op period, they only mobilize like 8 to 10 minutes. And what the study found that the patient should walk for 1 mile every day, which means 15 to 20 minutes, 4 to 5 times a day, to decrease the length of stay in the hospital. And here is a study conducted in 2014. 2014, yes. That's found when we implement the ERAS on the patient versus the standardized care. When they implement the ERAS, there's a reduction by 2 days or 2.3 days of length of stay in the hospital. That means less infection, less cost by 10% and everything. Okay, what is the impact of multimodal analgesia in the era of enhanced recovery? If we have unrelieved pain, that means we have increased sympathetic activity, we have tachycardia, hypertension, decreased regional blood flow, infection and poor wound healing, increased oxygen consumption, myocardial ischemia. If we have fear and anxiety, we have impaired rehabilitation, and if we have shallow breathing, we may end with pneumonia. So multimodal analgesia as a component of ERAS, it's as in the preoperative phase, like we said, pre-admission counseling. In intraoperative phase, it's regional analgesia and anesthesia, short-acting anesthetic agent, and post-operative early mobilization, multimodal opioid sparing analgesia, prevention of nausea and vomiting, and early removal of catheters, like NG tubes and blah blah. Here is another study on pain management. Another study said pain management remained the suboptimal in acute care setting. This study conducted in 3 times. First time 1995, another time it's 2003, the last time 2014. Said that still there is something like 1/3 of the patient still have pain after each surgery. There is another important study which talk about the importance of balancing pain management with the risk of adverse event. This conducted after the patient finished the surgery, after they go home. They ask them about what they prefer. If they prefer to take a high dose of opioid with good satisfaction, but with side effects like nausea, vomiting, itching, and blah blah, or will patients prefer a moderate pain relief without taking risk of side effect? And most of the patients will choose the second option, to take low dose of opioid without any side effect. And this another study about when there's a patient with on opioid after the surgery, and we have here on y-axis the constipation, confusion, and emesis, and we see if the patient didn't take an opioid and there's no side effect, the length of stay will decrease, with emesis by 1 day, with constipation by 1 by 2, 1 by 1, and then with confusion, and with constipation 1 by 2. So opioid monotherapy has limitation. The common adverse effect of opioid is nausea, pruritus, sedation, constipation, and the clinically significant ones is the ileus, vomiting, confusion, bowel obstruction, and the life-threatening is airway obstruction, respiratory depression, and respiratory arrest. Multimodal analgesia incorporate diverse classes of non-opioid drugs. We have here, we all know we use the acetaminophen, alpha-2 agonist, gabapentinoid, local anesthesia, and NMDA receptor agonist like ketamine, NSAIDs, and steroids. And there is another way, non-pharmacological approach to pain management may include expectation management, stretching, ice, physical therapy, and acupuncture. So, multimodal techniques for preoperative pain management is combined of 2 or more analgesic agents or technique that act by different mechanisms to provide analgesia, and the American Association of Anesthesiologists take forth the recommendation, unless contraindicated, all patients should receive an around-the-clock regimen of non-opioid agent, not PRN, like NSAID, COX-2 inhibitor, acetaminophen, and consider supplemental regional anesthesia technique. That's why, because there's more 70 million patients per year undergo surgical procedure, and 80% of whom experience post-operative pain. And about the regimen we use, we start at step 1 by acetaminophen, NSAIDs, or COX-2 inhibitors with local regional anesthesia. If still we have pain, we will move to step 2, which is moderate pain. We will add some opioid to step 1. If still we have pain, after we will do step 1 and step 2 local anesthesia, we'll consider the peripheral nerve block or add sustained released opioid. So in summary, ASRA including multimodal analgesia to improve outcome and lower the cost. Variability in preoperative care practice lead to lower quality and patient outcome. Standardization in preoperative care to improve patient outcome. ASRA multimodal evidence-based from need to recovery. Integrated, the ASRA has multi-component, the pre, intra, and post-operative. ASRA improve the patient experience and outcome, and the pain is the most common. It's things that happen after the surgery, and lower the quality and the patient outcome, and balance the pain severity dependent opioid. So I will talk briefly about the ASRA implementation. If we want to implement the ASRA, we should find a champion and target population, identify the anesthesia, surgery, nursing, and administrative. ASRA champion, target willing surgeon doing procedure with long length of stay or high complication rates. Perform a gap analysis with an ASRA checklist. Hold the first work meeting and secure administrative committee with surgeon, nurses, anesthesiologists, and administrative. And this is the ASRA project team. Start from the librarian, marketing, until we go to a quality department. And we can utilize the free available resources like ASRA Society, ASRA, ANA. And this is the reference. And here I will go briefly with sample ASRA protocol. The following protocol presented to you serve as an example only. It's not an endorsement or medical recommendation. Here, like we will talk briefly, first of thing, we will do education and expectation management. Patients given a preoperative instruction regarding the proposed preoperative hospital course. All patients must attend pre-surgical education class, appropriate written patient educational brochure, preoperative nutrition and smoking cessation counseling begin, and patient is set up complex carbohydrate checks. Screening, standardized and evidence-based protocol for screening and testing. For risk-reducing measures, we will use heparin sub-Q, antibiotic prophylaxis. For goal-directed therapy, fluid therapy, optimize the fluid therapy and utilize the hemodynamic goals, not the urine output. Anesthetic optimization, use short-acting inhaled anesthetics, multimodal post-op nausea vomiting prophylaxis, minimize the opioid using multimodal analgesia, we use tab block, use thoracic epidural. We can combine it with gabapentinoid, celecoxib, acetaminophen. Close glycemic control, continue tight glycemic control throughout preoperative period in all patients. For nausea and vomiting, multimodal prophylaxis, because nausea vomiting has, it's a multifactorial thing. Sometimes it relies on the patient factor, surgery factor. So we have to use multimodal prophylaxis sometimes on ondansetron, dexamethasone, and for post-op, ondansetron and promethazine. Early removal of tubes and catheter, like we said, like NG tubes, and bladder catheter, avoid intraperitoneal drains. Early feeding and bowel stimulation. Clear liquid may start at PACO, and we start at PACO with chewing gum. early mobilization and conditioning. And after that, we will conduct audit and to collect of metric and re-evaluation study. What's the summary? ERA's summary, it's better healthcare, better patient experience, and lower the cost. Thank you.
Thank you, Dr. Haytham, for the nice presentation. Our last speaker today is Dr. Alim Zain. Dr. Alim will talk about enhanced patient safety in anesthesia. Dr. Alim is the Quality and Project Safety Manager at Dr. Sulaiman Habib Medical Group. Please welcome Dr. Alim.
I want to finish safety.
بس كليك صح دكتور
يمين وشمال.
Assalamu alaikum. Good afternoon all. This is Reem Zain, the Quality and Patient Safety Manager at Dr. Sulaiman Al Habib Group. It is an honor to be with you here today. Thank you for Dr. Ibrahim and for organizing committee to invite me to meet you.
يمين ويسار. هم شايفين الجزء لو في نوتس هتطلع لك هنا. دي next slide. ماشي.
Thank you, Doctor. I'm here today to talk about patient safety in anesthesia setting. Actually, before start talking about this topic, let me ask you or let me encourage you to think about 3 questions. What, in your opinion, what is the acceptable level of harm? Or, in the other word, what is the level of harm are you accepting for your beloved while they are seeking or under medical care? The second question is, are we doing enough to protect our patient from harm? And the third question is, are we holding ourselves up to highest level of care? So, keep these questions in your mind and let's start. I will start by reviewing some horrible numbers reported by many institutions. Let's talk about Institute of Medicine, which reported in 1995 that 100,000 deaths happened every year because of adverse event or medical errors. WHO noted that the adverse event causing to death is one of the 10 leading deaths among the world, which means that 1 out of the 10 patients experienced harm during health care. And more than 3 million deaths occur annually due to unsafe care. Also, they reported that in the low middle income countries, as many as 4 in 100 people die from unsafe care. Finally, 50% of those events are preventable. Let's talk about common adverse events lead to harm the patient. We are not talking about level of harm, if it's moderate, if it's low, if it's high, if it's sentinel event. We are talking about the harms already reaching the patient and they are avoidable. Rank number 1 is medication error. Then surgical error. 3, healthcare associated infection. 4, sepsis. 5, diagnostic error. 6, patient fall. 7, VTE. 8, pressure ulcers. 9, unsafe transfusion. 10, misidentification. Last, unsafe injection practice. So, anesthesia contributed to adverse event is not listed here, which is good news. So, I have good news to you. There is a significant development in anesthesia among the past years. I'm talking about the 20 years back. And we achieved very impressive improvement in the safety relating to anesthesia. MOI again underscored significant reduction in anesthesia related mortality. Let's see, following to the first public successfully demonstration of general anesthesia was in 1846. Followed to that, in 1848, immediately people recognized the adverse event from anesthesia. When one of patient, she was 15 years old, she developed or sustained cardiac arrest after being administered of chloroform. That was in 1848. After that, a lot of studies and a lot of development happened to the anesthesia science in order to decrease the side effect from, or not side effect, I'm talking about adverse event from anesthesia. The vision is converted from decreasing the mortality from anesthesia to improving the perioperative care. In 1954, reported based on the review of nearly 600,000 procedures, estimated the rate of anesthesia-related mortality at 64 deaths per 100,000, which is significant. Then, in 1980s, again, it was significant improvement because of continuous training and monitoring. And who knows, in 1980, which society was established? American Society of Anesthesia. Everyone in the world adopt the standard of American Society of Anesthesia, starting from 1980s to 1990s, which caused a significant development and to have safer outcome to the patient, which decreased the incident relating to anesthesia from 1 death in 1,000 patients to 1 death per 10,000 patients in 1980s. After that, based on the data from 2011 throughout 2016, mortality attributable to anesthesia administration was estimated to be 2.3% per 100,000 patients. And this is the last statistic we have. Now the question again. What is the acceptable level of harm? Is 2.3% death or harm reach the patient from 100,000 patients is acceptable? What do you think? Yes or no? Okay. So, what is the acceptable level of harm? 0 is the only acceptable number in safety. So, patient safety is the priority. We cannot accept any other number rather than 0. I'm here to talk about how we can achieve 0 level of harm to our patient. It would be achievable if we take all countermeasures. So, in 2004, WHO came together to advance that the patient safety goal is first, do not harm the patient. Again, still, we are harming our patient, and still there is a lot of reports. It is not too much, if you compare it with the other top 10 cause of harm to the patient, like medication error or wrong surgery or wrong blood transfusion. It is not that significant, but still we cannot accept any harm to reach the patient. So let's talk about zero harm. This is the last incident reported or published by Saudi Patient Safety Center. This incident happened recently here in our setting, okay? It was a death happened to 35 years old patient as the surgery team proceeded with the surgery despite the cardiac condition. The pre-anesthesia electrogram ECG showed findings that mandate evaluation further assessment. However, multiple healthcare providers missed reviewing ECG results before the surgery, which led to death. This is significant incident happened recently and published by our Saudi Patient Safety Center. Now, I can tell you a lot of stories from my experience and what I have seen during the past years about the incidents related to anesthesia, and to get a lot of lessons to be learned. But this is not my objective today. My objective today is to let you know how error could happen. So if we will know that the error happened that way, we would avoid it. There is a very simple. This is here, I will skip this slide. Here, after having our root cause analysis, they published that the root cause of this incident, as all of you know, that if we have any harm to the patient, we have to, even it is near miss, we have to have root cause analysis, we have to gather team, we have to do a very comprehensive assessment, and we need to meet all relevant staff in order to identify the gaps, uncover the causes, and put the lessons and amend the process. So the root causes was no standardized pre-anesthesia assessment. The surgery was booked before anesthesia clearance. No proper file review before starting the surgery, which reflect that the timeout was not conducted properly. Simplify the interpretation. Maybe the anesthesia on the OR room saw the ECG, but he said, okay, she's young, she has no history, so we can accept. And no proper handover between the team. Anyone know the Swiss cheese module? This is very simple metaphor, shows us or visualizing us how error could happen in our system. Healthcare system, as you know, it is very complex system, and it consisted from multiple layers or multiple barrier of defenses. Each barrier has its own holes. Sometimes the holes are big, sometimes they are small, and they are keep moving, and they are intact, by the way. They are not causing any harm unless specific situation. So just look at this metaphor and imagine that each layer of the Swiss cheese will be layer or a barrier of defense in your institution. Each layer has its holes. These holes are intact, but when they lined up and when they align together, the harm or the hazard could go through them or could break them and reach the patient. Those holes will arise for two reasons. The first reason is the active failure. Active failure means that the people who are directly involved in the care and exposed to the patient has an issue of education, or they have standard of care, substandard of care. They are not properly trained. They don't have enough resources. So the active failure happens when the people who's with intact with the patient has slips, lapses, or violation or made violations or mistakes. I think all of us know what's the difference between slips, lapses, violations, and mistakes. Violations, you know the rules, but actually and intentionally you intend to violate the rule. Not because you want to make an incident, but you want to make a shortcut. So the active failure are the big holes in our system. The other form of failure may be or called the latent failure. Latent failure are some small gaps existing in our system, but they are latent. They are not moving, they are not causing any issue unless they combine with the active failure. Latent failure or latent condition, I will give you example on latent condition like understaff. Understaff is latent condition. We don't have an issue unless the latent condition is combined with the active failure, so they allow the holes to line up, then the error will reach the patient. And this is very easy module showing us how error could happen, and it was introduced by one scientist. His name is James Reason. So going back to the last case or the case I mentioned earlier, what is the recommendation? Again, after doing root causes, after identifying the gaps, after gathering the team, we will put and uncover the causes. We will have some recommendation, such as implementation of risk assessment tool that is applied uniformly to all patients, having policy and procedure, having checklist, having uniform policies and practice, having a proper system. By the way, Swiss cheese let us know that we cannot change the human condition because a human will stay human, but we can change the condition under which human works, which means that we can change the system, but we can't change the people. So having a smooth system, having good staffing orientation, having good written policies, having good medical record documentation will assure us that harm could be mitigated, sometimes prevented. Again, this is Swiss cheese module. You shouldn't forget it, so you will gonna understand how error could happen. And I like you to go to the American Society of Anesthesia to check IRS. IRS is the incident reporting system like OVR, but it is specialized in anesthesia adverse outcome. It is anonymously. You can go there. You can check incidents happening through the past years. Also, you can report the incidents happen in your institution anonymously, and you would benchmark your action plan with other hospitals as well, and seek the recommendation of the experts. Something very important to know, that how we can classify our outcome relating to adverse event. Why it is important to classify the outcome, the negative, we are talking about negative outcome, because if you can classify it in correct way, you will know how to solve it, how to have your action plan. We have 3 categories of adverse event or safety event. First one is a serious safety event. Second one is a precursor safety event. Third one is the near misses. How we can categorize our incident? By asking ourselves these questions. And these are evidence-based. It is there in the Priscania, and I can share it with you later. Can you see the process map? The first question was, there is a deviation from the generally accepted performance standard? If no, it means that there is no adverse event. If yes, it means that the deviation, you're gonna ask yourself another question. Did the deviation reach the patient? If no, it was a deviation, but it was not reach the patient, means that it is near-miss safety event. Is it required to have RCA? The near-miss? Sometimes yes. Okay? It is depend on the severity of harm that could be caused by this event. The third question is, if it is already reached the patient, did the deviation cause moderate to severe harm or death? If no, it means that it reached the patient, but the level of harm was, thanks God, moderate or low. So it's called precursor safety event. If yes, so it is serious safety event. My recommendation is, whatever you have, whatever level of harm you got, even it reached the patient or not, for any deviation in the process, you have to go and ask why it was happening. Because sometimes those hazards are latent in our system. But with the time, it could converted from near-miss to sentinel event. Okay. By the way, near-miss, I consider near-miss as a free lessons. Free lessons because they showed us that we have deviation, but God, thanks God, it doesn't reach the patient. So, alhamdulillah, it not cost us anything. One of the challenge also we are facing when we analyze any adverse outcome or any negative outcome from any event, to distinguish between common complication and adverse or preventable adverse outcome. There is a test called non-complication test. By asking these questions, you could distinguish between adverse outcome, preventable adverse outcome, and common complication. And again, this is systematic approach. It is there in Brisbane. You can go and you can check and you can read more. The first question will be, was the procedure, treatment, or test appropriate or warranted for the patient based on the nationally recognized standard of the care? Answering yes to all the questions means this incident is common complication. Answering one no to any of these questions means that it is preventable adverse event. The second question, was the complication a known risk and were standard of care steps taken to mitigate it? Was the complication identified in the timely manner? The fourth question is, was the complication treated according to the standard of care and in a timely manner? If you're gonna ask no, if you're gonna answer no for any of these questions, that means you have preventable outcome, adverse event, safety event. You need to go back, you need to compose a team, you need to do your RCA, and you need to modify your system. The last but not the least, something everyone likes. This is the highest countermeasures. If we're gonna follow them, I will just read the title. If you're gonna follow, I can assure you that you will achieve 0 level of harm to your patient. And this slide, I collect all of this information from many institutions such as CBAHI, JCI, American Society of Medicine, and Brisbane, and many. I will leave the references at the end of this lecture. First, you have to have policies and procedures guide the provision of anesthesia care. Having all details about staff, about the OR specification, theater, and so on. Then, pre-anesthesia assessments performed prior to the administration of sedation or anesthesia immediately. Even you are checking the patient last night, even you are checking the patient this morning, you have immediately before induction of anesthesia to reassess the fitness of the patient to the anesthesia. Then, patient monitoring during after surgery until appropriate recovery. Then, anesthetic supplies and equipment, you have to have policy, you have to have checklist, you have to check it periodically as per policy or manufacturer recommendation. We have to check periodically our staff qualification and certification. Then, if our institution is performing moderate or deep sedation or analgesia, we have to make sure that everyone is doing this or performing this conscious sedation should be certified, should be trained, should have privilege, as my colleague Dr. Muhammad, I think, and Dr. Haytham mentioned before. They have a specific requirement, they have to have specific certification, ACLS, BAS, NRP, and so on. After that, we can give them the privilege if they are not anesthesiologists, if they are not intensivists, if they are not ER consultant. Other than these three categories, the doctor should have the appropriate certification, should have training from the head of department of anesthesia, should have a license, certificate in performing deep or moderate analgesia or sedation. Then he should gather the privilege from the head of department and medical director. Any question? These are the references and this is my number. I will be happy to answer any question. Thank you so much.
Thank you so much, Dr. Ali, for the nice presentation. By this presentation, we reach to the end of this session, so we invite our distinguished speaker to join us for panel discussion. If anyone has a question from audience.
Assalamu alaikum. Thank you all for the wonderful presentations we did today. Today, this presentation was designed to discuss safety and to discuss also the enhanced recovery. My question is to Dr. Muhammad Nasser. Dr. Muhammad, we had here two, I can say complete sessions regarding the ERAS protocols, ERAS analgesia, and ERAS safety. And today, I think the one-day surgery centers are expanding the Ministry of Health. Is there any standard protocol, standard training, equipments, technologies to make it like a standardized according to the kingdom regarding the one-day surgery centers?
We are going toward the scientific committees on standardizing the day case procedures. We didn't complete it yet, Dr. Ibrahim, but we are in the directions of continuing such a things on the next 2 to 3 months. But at least in each department we have the standard, in each cluster they have the standard guidelines for the day case surgery, but we want to make it as a generalized, unique standardizations for all the clusters.
Assalamu alaikum. My question to Dr. Muhammad Sribani and Dr. Reem as well, as expert pediatric anesthesiologist and patient safety manager. Is there any written law regarding anesthetizing the pediatric age group by non-pediatric anesthesiologists here in Saudi Arabia? We had this conflict many times. Sometimes they are bringing like neonate cases to non-pediatric anesthesiologists and they asked to put them to sleep. And sometimes it happened in non-operating rooms, like MRI or endoscopy suites. So either this might happen either in public or private hospitals.
Thank you for that question. I will start my part with the quality for my colleagues. I think what we have here in Saudi Arabia, every institute, they have their protocols or their rules for a certain age. Something like they have like 6 months or 1 year. What I agree for this, less than 1 year should be as pediatric anesthesiologist. But depend on the institute or the hospital. This from the quality. And
I think based on the ASRA classifications, if the patient is ASRA 1 and ASRA 2 in routine cases, we can go through this. But we usually try our best to keep below 9 months to be anesthetized by a specialized anesthesiologist, whether it is a pediatric anesthesiologist or a senior consultant who has a good experience in pediatric anesthesia. But as I mentioned before, that we have a limited numbers of the pediatric anesthesiologists in the whole kingdoms. If we make it as a standard that all patients will be anesthetized pediatrics by a pediatric anesthesiologist, then we'll end with changing on the situation. So at least we will look for the risk factor. If there is a risk factor, then we will ask for a pediatrics. But in general hospital, the only things that we work through the dentals and the ENT in age groups where there is no pediatric anesthesiologist among those, but we try our best not to anesthetize somebody who is below 9 months and with high risk in general.
If the hospital gave me the privilege to anesthetize
Yes.
the neonates and something happened to that patient, is there any legal implications on me as
Actually, your
anesthesiologist?
certificate is as a general anesthesia for the pediatrics and for the adult and for the things as a general. If you want to be specialized, there are other things, but if the hospital give you the privilege to work on such a directions and you get into complication, this is not affecting your legals because your license is being as a general anesthesiologist for the whole qualified, whether pediatric or obstetric or neuros or whatever. But in special procedures, then you can consider the specialized things. For example, neuroanesthesia, awake craniotomies, or for the pain surfaces, that should be a considerable point of view. But as a general board certificate, you have the right if you give the privilege.
My colleague here explained everything, but I want to emphasize that we need to have a good team of anesthesia in each and every hospital. And the anesthesia activity in the whole, throughout the hospital should be supervised and overseen by a qualified head of anesthesia. So any privilege, if it should be given to any other doctors, not anesthesiologists, not intensivists, not ER, should be monitored from the anesthesia, not only head of department, I'm talking about anesthesia head of department specifically. So having NRB, having pulse, having ACLS according to the age of group of age that identified by the scope of service of the hospital. And this is, I think, the ultimate way to ensure the patient safety relating to anesthesia outside the OR. Thank you.
For example, for pediatric anesthesia, we have two categories. Those who has a certificate fellowships in pediatric anesthesia and those who is having a clinical, practical evidence on long-standing working in pediatric hospitals. So those both have got the privilege to work for especially neonate. And if you ask about the neonate per se, no neonate will be anesthetized apart from a pediatric hospital or a pediatric obstetric. But definitely you have both of these, either a qualified, certified fellowships or somebody who has qualified with clinical experience and practicals on pediatric such things. So this is the safety margin.
So just last thing, I want just to add that, as I mentioned before in the presentation, the communication. When you have such this case and doing this in remote areas, just communicate with the department or anyone to have it in the right way.
Thank you very much for everyone. Now we are going to honor our speakers today. And inshallah, next session will be the last session in our conference, as we joined last session, session 9. It was distributed among the 3 sessions. The first, in the first session today, we had Dr. Fouad lecture, now Dr. Haitham, and next case will be Dr. Rami's session. So the last session was distributed along the day, and next session, inshallah, will be the last session. Now we're going to honor beginning Dr. Muhammad Nasser. Dr. Amir Kinani. Dr. Muhammad Salani. Dr. Haitham Boya. And Dr. Rizzi. And finally, we want to thank our moderator today, Dr. Adel Qarni. Thank you, Dr. Adel. Okay, we will hop to the next session.
Now we jump to the next session, and we have to welcome Dr. Abdul Aziz Al-Hazazi. Dr. Abdul Aziz is a consultant in anesthesia and pain medicine and head of the pain and management division of the British Sultan Military Medical City in Riyadh. He also serves as director of the Health Skills Development and Simulation Center. He holds a Saudi and Jordanian board in anesthesia, as well as fellowship from the College of Anesthetists of Ireland, and the FIPP degree. Let's welcome Dr. Abdul Aziz.
Assalamu alaikum. Thank you, organizing and scientific committee for organizing such a big conference for anesthesia and pain management. But unfortunately, it was overlapping with 2 big conferences in the region. That's why me and Dr. is coming from the Saudi Society of Pain Medicine within yesterday. I have nothing to disclose, so my agenda for this talk today: basics of chronic post-surgical pain, economic and quality of life impact, and high-risk procedure patients for those developed such disease. Assessment, diagnosis, management, and then we'll talk about perioperative preventive strategies. And we'll have overview about special population and emerging therapies and future direction. Although the agenda is long, but we'll try to finish it on time. Just remind you the definition of chronic post-surgical pain by International Association of Study of Pain: a pain developing or increasing in intensity after a surgical procedure or a tissue injury involving any trauma, including burns, and persisting beyond the healing process, which usually considered 3 months after surgery. The scope of chronic post-surgical pain, prevalence usually varies between 10 and 50%. Only the good thing, only 2 to 10% usually develop severe pain. and this cause impact the global economic burden and significantly impact public health. The economic impact usually in different ways. It affects sleep deprivation, and that add cost on the patient and organization. So the annual economic loss from the sleep deprivation are significant, around 411 billion. Healthcare utilization, because these patients usually visit emergency frequently after surgery, requiring different medication, different visit to OPD clinics. As well, the chronic post-surgical pain affecting the patient work performance and overall productivity, sick leaves, and etc. By mentioning all this, it affects the quality of life by affecting causing functional limitations, causing psychological trauma, especially if it lasts for a long time not treated, and as I mentioned, it affects sleep health or disturbance. What surgery type usually develop this chronic post-surgical pain? On the top, amputation, range from 50 to 85%, followed by thoracotomy, 30 to 55%, followed by breast surgeries, 20 to 30%. This is the common surgeries that usually develop chronic post-surgical pain, although others can develop chronic post-surgical pain like hernia, cesarean, and cardiac surgeries. The pathology is very difficult, but we can say just neuroplasticity, central sensitization, inflammatory response, and nervous system changes over time usually cause this phenomenon. Is it related to nerve injury intraoperatively? Although nerve injury is a key factor in developing chronic post-surgical pain, however, not all nerve injury happen intraoperatively can cause chronic pain. Risk factor, pre-existing pain, usually this type of patient, like patient coming with suffering from pain due to infection or scheduled for amputation, and patient, any procedure that having chronic pain or severe pain pre-operatively, they are at high risk of developing chronic post-surgical pain. Genetic predisposition is not our hand, psychological factor, and I will mention later what type of psychological disease that impact or increase the risk of chronic post-surgical pain. Intraoperative risk factor during surgery, we have no control over this, but usually surgical techniques, surgery duration, and tissue damage happening during surgery can increase the risk of chronic post-surgical pain. For us, it's important to control the pain post-operatively, either whatever modality or medication. We need to control pain because persisting pain or uncontrolled pain, intraoperative and post-operative, can impact increase the risk of chronic post-surgical pain. Demographic risk factor, just from the studies, it appears female genders at risk of developing this pain. Younger age and socioeconomic status, those with lower status can increase risk. Some type of patient, they have genetic factor, play a major role in causing or extending the chronic post-surgical pain after surgery. So there is gene variation and mRNA expression and personalized prevention strategies. So this is, we'll mention later, there is ongoing and future interventions that may play a major role in genetic factors. Some type of patient, they have catastrophizing structure or phenomenon or expressions they are exaggerating pain and its consequences, and these type of patient usually anxious and depressed, and they are at high risk of developing chronic post-surgical pain. Fear of pain exaggerate worry and future and extending of pain after surgery. Usually this type of patient at high risk as well. Lack of social support as well at high risk. How to diagnose? How to give you a clue about this? Usually not any pain we can label as chronic post-surgical pain, but pain that persists after 3 months, localized at the surgery site or referred area from the surgery site, and we have to look or rule out of other causes that can cause pain like infection, etc. Clinical presentation, this type of people usually presented with neuropathic pain, burning, shooting pain, electrical type pain, different from acute initial pain. Hyperalgesia and allodynia, patient may develop exaggeration or increase pain due to painful stimuli, or they have even pain with non-painful stimuli, which is called allodynia. This may cause functional impairment, especially if patient not mobilized early, or the pain limiting his walking activity. What are assessment tools used? Usually we use for pain assessment, we use NRS or VAS, visual analog score scale, neuropathic questionnaire like DNA4 or pain detect or any other pain neuropathic pain screening tool, quality of life assessment tools. We're not going in details because this we need to refer to specialized person. Imaging technique that nowadays there are a lot of studies that may help to distinguish this type of pain, like MRI, functional MRI, and PET scan. What important for us is preoperative prevention and intraoperative and postoperative prevention. So in preoperative, we have to educate the patient, discuss with the patient all possible side effects, and the modality of analgesia usually for specific surgery. Optimize pain and address psychology. If you notice that some patient may be at high risk, so you have to discuss and explain to them thoroughly the risk and modality. Intraoperative prevention for us as anesthesiologists, we have to, this is as a surgeon, nerve-sparing procedure or surgery, minimally invasive surgery, which is nowadays developing, and it may help to decrease the risk. Intraoperative management either from anesthesia or surgical team. Post-operative prevention strategy, cognitive intervention, multimodal anesthesia, as my colleague mentioned early mobilization, it helps preventing the functional immobility or limitation. Pharmacological prevention, although it's not 100% sure, but it may give with other modality decrease the risk. Gabapentinoid like pregabalin and gabapentin, ketamine, a lot of study ongoing on that, but it's not guaranteed. Local anesthetic and regional anesthesia like epidural, peripheral nerve block, interfacial plane block. I'm very happy Dr. Rizk will share with us his presentation about interfacial plane block for chronic post-surgical pain later on. Transitional pain service now coming with the service between acute pain and chronic pain, and still now it's not well established in many big centers. For us, we may start this soon, inshallah. So specialized clinic in to detect this type of patient with multidisciplinary team usually involve pain specialist, surgeon, psychologist, physical therapist. So it's multimodal approach in individualized for each patient with regular assessment. Unfortunately, this type of patient usually lost between us and surgeon, referred to acute chronic pain and see usually after 3-4 months. And surgeon usually they don't see the patient after they roll out infection in the early days post-operatively. Pharmacological management, this type of patient, I'm not going to detail in this management, but you have to refer as an anesthesiologist, you need to refer to this to a specialized team in the hospital to start neuropathic pain medication, opioid, although the concern about opioid, topical agent and other modalities that can be used like non-pharmacological physical therapy, CBT and mindfulness. More advanced intervention like nerve blocks, radiofrequency ablation and spinal cord stimulation, it may help. Psychological intervention for this type of patient like cognitive reconstruction, reconstructing coping skills, acceptance and commitment therapy, and group therapy, which is rarely used in our society. Physical rehabilitation of chronic post-surgical pain include exercise programs, manual therapy, graded activity, and it's usually help in early days. Some type of patient at high risk or because there is limitation to assist their patient or manage their pain, like children, they have developing nervous system, limited communication abilities, and psychological development stage. So they experience influence how they experience and express pain after surgery. So we have difficulty in assessing them and managing them properly. Elderly patient as well, where there is a problem with the communication, so we underestimate or under-assess their pain accurately. As well, the management of this type of patient usually difficult because they are taking different medication and difficult. There is a contraindication to use neuropathic medication or different analgesic group. Cancer survivors usually develop pain after like a mastectomy procedure, any other abdominal procedure, any part of the body procedure that at high risk of developing chronic post-surgical pain. It's very difficult to differentiate from recurrence and chronic post-surgical pain. That's why healthcare practitioner usually it's difficult for them to reach diagnosis, especially if ongoing on chemotherapy or radiotherapy, especially in the late stage. Emerging therapy, neuromodulation nowadays, DRG stimulation and high frequency spinal cord stimulation offer the target pain relief with fewer side effects. VR, it's involved in all medical fields, so it may help distracting patient from pain signals and can facilitate neuroplasticity. Personalized medicine, it's emerging medicine, may play a role in genetic study and can tailor the assessment or prevention of special problems or like chronic post-surgical pain if studies very well. So the takeaway on chronic post-surgical message, this is not uncommon, so we are facing this frequently as pain physician. Unfortunately, they are neglected. Some of surgeons, they're not aware. Patient may not aware of this as well disease, so it is common and serious. It need to include other colleagues from surgery, from physical therapy and psychologists as well. So prevent and intervene early as possible. A call to action, increase awareness to surgeon, community, improve education and continued research may give us a promising solution in the future, inshallah. That's all, and thank you for attending.
Let's welcome Dr. Mohammed Al-Jalisi with his talk about the role of regional anesthesia in preventing chronic post-surgical pain. Dr. Mohammed is a regional anesthesiologist at King Faisal Specialist Hospital and Research Center in Riyadh. He completed his clinical fellowship in regional anesthesia at McMaster University in Canada. Let's welcome Dr. Mohammed.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Can you use this? So we will be talking about just, it would be a continuation for the Dr. Abdulaziz Hazazi lecture. So it would be like a role of regional anesthesia and preventing of chronic post-surgical pain. So do we have a clue, a real, I would say, at least a basic evidence that it might work or not? So we can invest in research and discuss about this topic. The answer is yes for now. So the evidence from basic sciences research actually targeting multiple mechanisms of chronic post-surgical pain, including neuroplastic changes, immunological contributions to chronic post-surgical pain, and pain scores. So as there is hyperalgesic priming as well-known mechanism of chronic post-surgical pain, actually it would be enhanced by repeated doses of opioids. So I would say we have a consistent evidence that nerve blocks, in many cases, it reduced the opioid consumption, and it's as opioid sparing modality. Also, it's reduced the cytokines and multiple neuroinflammatory mediators. So I would say it also contribute to the hyperalgesic priming, and also to reduce all over neuroinflammatory markers after the nerve block. And pain score. We know that intensity of pain in acute stage, it's related to developing post-operative chronic pain, and nerve blocks most of the time works reduce the pain score. So clinical evidence actually still debated for multiple reasons. One of them, different techniques, heterogeneous population and surgical procedures, and I think we are facing a methodological dilemma to prove this evidence and regional anesthesia to prevent chronic post-surgical pain, as we will discuss. So, epidural. Epidural, one of the most extensively studied, especially in thoracotomy, lower limb amputations, and laparotomy. But the techniques is so different in the timing and using of additives. So actually, it is really heterogeneous even from our side, not even the population. So in our side, one of the studies actually, they used ketamine in the epidurals, and they inserted the epidural 1 day before. So it is really heterogeneous group, and the anesthesia actually techniques is so different in those cases. But let's talk about thoracotomy. Epidural use for thoracotomy. So it's most significant indications to be used because as 30 to 40% would be experienced post-surgical pain. Most beneficial in thoracotomy compared to fats. I would say there is moderate level of evidence in this case to be used in thoracic surgery. Epidural phantom pain, also one of the really significant burden to be 50 to 80% of the patients. And it actually, I would say, moderate level of evidence, and there is promising outcome. But there is obstacles in case of anticoagulation and actually resources to manage perioperatively for epidural removal and management. Mobilization and facilitation of principles of ERAS could be, I would say, clinically conflicting with that. Thoracic paravertebral block, moderate level of evidence, and modified radical mastectomy more than skin-sparing surgeries. And actually this indicates, I would say, how complex we are dealing with this phenomena. If we are saying mastectomy, but the result is not consistent with skin sparing, that means the level of trauma and the tissue spared, it might also contribute to that. So I think we have heterogeneity in our anesthetic technique and even in surgical. So I did not show any good results, I would say good results in surgeries, although most of the data came from the VATS, which is less invasive compared to the thoracotomies. Facial pain blocks, I would say TAB block studied in cesarean and inguinal hernias. Actually, but I would say meta-analysis failed actually to prevent, to come up with evidence that we could prevent chronic post-surgical pain. Serratus anterior and Bix blocks. Actually, in this case, actually serratus anterior plane blocks decrease the prevalence of chronic post-surgical pain after modified radical mastectomies. And I would say it seems to be also moderate level of evidence with good number of patients. The issue with facial plane blocks in these cases, actually, variability of technical performance, especially in abdominal, I would say quadratus lumborum blocks, and there is limited data that the facial plane blocks could contribute to reduction in chronic post-surgical pain. Peripheral nerve blocks. So double nerve catheters for lower limb phantom pain prevention. 3 RCTs did not reduce the incidence of phantom limb pain. I would say it's kind of more complex innervation, maybe obturator nerve, and also heterogeneity of the cohort in those cases, because there is very wide and very variable age grouping and risk stratification for those cases. Ilioinguinal, iliohypogastric nerve blocks. Actually, in cesarean delivery, also the level of evidence, I would say, low to moderate, and also inguinal hernia. Knee arthroplasties is one unique good study actually in Serbia. Showed a good combining adductor plus IBAC could reduce a chronic post-surgical pain. In terms of what's powered this study, actually statistics almost 160 something, good numbers in the both arms, plus long follow-up up to 2 years, which is a good one to a good study, good methodology to get. Wound infiltration. 2018 Cochrane database, actually they changed even the conclusions, but actually the wound infiltration works very well for inguinal hernia and cesarean section. So to take home messages. So for the current practice evidence, I would say improved risk stratification for the patients would be a really good modality to use multiple modalities. I would say to involve multiple modalities in those cases. The epidural analgesia continues to demonstrate a favorable outcome, but I think it's just a matter of we do have good number, but we don't have a good numbers in other blocks. So, and don't preclude the patients from at least a wound infiltration. As we see in the Cochrane database meta-analysis, it seems to be working. For future research directions, I would say we need more homogeneous cohorts in terms of surgical procedures, medical, and also the anesthetic techniques. We should focus on secondary outcomes. I would say if we can have a secondary outcomes in those researches, would be giving an idea to the future researches. So including neuroinflammatory biomarkers, precise diagnosis and characterization of chronic pain syndromes, as we know, is really subdivided. So we need to get more of diagnostic tools, more of precise diagnosis. And the pain scoring should be included in the secondary outcomes in those cases. Thank you.
Introduce. Here's time for your talk, Dr. Hassan Faiz. Next talk for Dr. Hassan Faiz al-Dawsari, optimizing outpatient shoulder surgery, a review of anesthetic options. Dr. Hassan is a consultant in regional anesthesia at King Saud Medical City in Riyadh. He completed 2 years regional anesthesia fellowship at King Saud University. He holds a Saudi board certificate in anesthesia and MBBS from the King Saudi University. Let's welcome Dr. Hassan.
Assalamu alaikum. Good afternoon. So we'll talk today about optimizing outpatient shoulder surgery. We'll review some anesthetic choice. So now the trend for surgery is outpatient surgery, or we call it day surgery, and shoulder surgery is one of them. So there is a variety of choice for anesthetic and for analgesia for this surgery. And to optimize the outcome and to decrease the length of stay, we have to make protocol and standard for all patients as much as possible. And with the day surgery and with the improved ultrasound technique for regional anesthesia, the general anesthesia is becoming less used. In comparison of outpatient total shoulder arthroplasty compared to day surgery, the decrease in the cost around $3,000 to $5,000 per surgery, and it may reach even more if you compare the whole package. It may reach even $50,000. So standardized protocol is the aim to maximize analgesia with a decreased narcotic using and decrease the overall complication. They noted that 80 to 87 to 89% of the patient will prefer to discuss what do you expect and what they are supposed to pass through from entering the hospital until discharge regarding pain, regarding anesthesia and surgical choice. So the purpose of this review to know in details, some details about our choice. So general versus regional anesthesia. General anesthesia, we have some advantage. We have a lot of people, they don't want to see whatever is going on. So they ask, I want to sleep. So they want amnesia. They want blockage of noxious stimuli. Some patient will feel noxious with any stimulus. also exposure, and it's most predictable. A lot of our colleagues can do general surgery, but some of them are not familiar with the regional anesthesia. The complication and disadvantage of general anesthesia, as everyone know, disadvantage of general anesthesia, cardiopulmonary, increase intra-op and post-op opioid use, longer PACU stay, longer hospital stay also, and more readmission for pain and sedation issues, post-op nausea, vomiting, and cerebral hypoperfusion due to positioning in this kind of surgery. So, what do we have for regional anesthesia? We have interscalene, which involve single shot and continuous catheter. You have supraclavicular brachioplexus block, infraclavicular approach, suprascapular nerve block, axillary nerve, not brachial plexus approach, and intra-articular injection by the surgeon, and high thoracic erector spinae plane block. So why regional? This opioid consumption, especially with the patient that having chronic pain, they need more dose, and this pulmonary complication, shorter hospital length of stay, and this JA related complication that we mentioned before. So, is it a better choice always? No, sometimes you need general anesthesia. So it is not 100% effective, especially if you are really familiar with regional anesthesia. There is transient or permanent nerve damage in rare cases, persistent pain, vocal cord paralysis, severe respiratory complication, local adverse reaction, and intravascular injection of local anesthetic. So, interscalene, when you think about shoulder surgery and you're thinking about a block, first thing you think about is interscalene. It's the gold standard. So we'll compare most of the next blocks with the interscalene. It is typically using a small amount of local anesthetic, longer acting, and it will stay around 24 hours if it is single shot. So contraindication, it is contraindicated in severe pulmonary condition because most likely it will cause hemiparesis, which will affect the patient, and the patient may need ICU. So you have to select your patient. So peripheral nerve condition affecting the other side, the same side, or the phrenic nerve, or some respiratory issue with the other side. So the patient cannot tolerate both sides affected. The two main methods for interscalene, either single shot or continuous catheter. So single shot, you have it's easy compared to the catheter. It have less logistic issue, and the patient can go home in the same day without issue. But the issue, it's shorter during regarding the duration, and it may have rebound phenomena effect of the pain. The continuous is much better regarding narcotic use, post-op pain. You can keep it with the patient. If you have good surface, maybe you can discharge the patient with the catheter, and patient will come later on to remove it. So interscalene complication, nerve injury, it may happen in small portion of the patient, pneumothorax, ipsilateral hemiparesis, hoarseness, vocal cord paralysis, Horner syndrome, and epidural subarachnoid placement. Another concern with interscalene is the surgical injury to the nerve. You may not be able to diagnose it if you do it pre-op. So usually I will do the block while patient is still awake pre-op, or post-op after examining the patient. So always examine the patient after your block if you do it pre-op, and examine the patient before doing it post-op. So continuous versus single shot. As I mentioned before, catheter have logistic issue and potential respiratory complication and dislodgement. And it's if you plan to do it in your hospital, you have to have proper team, trained nurse, good logistics. Perineural catheter require protocol and aptitude to assist patient caregiver. Single shot, shown to provide decreased narcotic consumption relation in the first 24 to 48 hours and less time for administration and less healthcare system cost compared to the catheter. So, superior trunk blockage, it's near the interscalene. It's a relatively novel technique intended to isolate superior trunk only of the plexus to reduce phrenic involvement. Unique complication of this technique is the injury to the dorsal scapular nerve. Supraclavicular approach is the concern if in this block is the incomplete coverage secondary to shoulder contribution of the suprascapular nerve, which emerged early from the brachial plexus. Recent meta-analysis demonstrate that supraclavicular in comparison to interscalene is comparable, but still the interscalene have higher hand. Infraclavicular, I like this block because in some patient with the short neck, obese, it may be easier. In some patient with the central line or whatever, or previous central line, previous incision in the neck, this is much easier. There are limited high quality studies in this block. However, remain option for patient with the risk for complication with the interscalene. A recent prospective and randomized trial found that infraclavicular block can be effective method for pain management for shoulder surgery, particularly when combined with the suprascapular nerve blockage. So suprascapular nerve and axillary nerve, you can use one of them. If you use suprascapular with other, we mentioned supraclavicular or infraclavicular, or you combine it with the axillary nerve. So suprascapular nerve will cover around 70% of the shoulder girdle, and the remaining will be covered by axillary nerve and other nerves. This block is typically performed by 2 injections, one at the back of the deltoid muscle and the one on the top of the trapezius muscle. So suprascapular nerve and they are not inferior to interscalene. With the decreased incidence of diaphragmatic complication, patient undergoing shoulder arthroscopy is limited. There is limited study to them. Limited study compared to open surgery. So we need more study regarding open surgery. A recent meta-analysis demonstrates suprascapular nerve to have lower incidence of Horner syndrome and other complications compared to interscalene, and noted to have significant reduction in pain score. High thoracic erector spiny plane block, there is limited number, but most of it showed limited benefit of it compared to other blocks. So adjuvant, the target of adjuvant to help and to prolong the effect of those blocks. First is periarticular injection, or we can local infiltration by surgeon. Usually local anesthetic is safe medication to use if you calculate the proper dose. So just make sure that this surgeon is aware of amount that you give, and keep communication with the surgeon. So it will increase, if you combine it with interscalene, it will decrease the narcotic need, and patient have higher satisfaction in interscalene alone, but if you combine it together, it's better for the patient. So dexamethasone, we usually use it for every patient in general anesthesia. You can use it also for patient with regional anesthesia. It will increase the duration of the action of regional anesthesia if you use it perineural mixed with the medication, or you can give it IV. Both will prolong the effect and will give you other good effect of the dexamethasone, like decreasing risk of post-op nausea and vomiting. Gabapentinoid. There is limited study regarding them compared to other medication because it is not FDA approved for acute pain, but some studies show good benefit of it. In general, to have some some down effect like sedation for patients. So mainly, if you will use it for post-op pain, you'll use it at once daily at bedtime. Cryoneurolysis, it's process of applying extremely cold temperature to targeted nerve tissue to reversibly disturb the pain signal conduction from peripheral source. So it is mainly if it will be used with suprascapular nerve, and it's shown good effect without affecting the motor. So home message, regardless of primary anesthetic choice, multimodal analgesia is crucial for the pathway to outpatient surgery. And the ideal multimodal regimen is, you cannot choose multimodal regimen to apply to all patients. You have to individualize the decision based on multimodal factor and system at play. Involvement of anesthesia and primary care giver like surgeon and nurse is utmost important when making those decisions at all stages of perioperative period. Thank you.
Our next speaker is Dr. Rex Alami. Yes, he's a consultant anesthetist and he's the head of department at the East Jeddah Ministry of Health Hospital. He did his fellowships in neuro anesthesia and pain management in Canada. And he has a hot topic to talk to us about the rise of interfascial planes, which we are all eager to hear.
Thank you, Doctor, for your nice introduction. I would like initially to thank our friend, my friend, Dr. Muhammad, for his nice invitation. I'd like also to thank Dr. Ishaq, Dr. Nasser, for their support despite the logistic challenges that they had. So, anybody knows the beauty to be an anesthesiologist? Doing education? It is a win-win. When you could make people sleep, you are a good anesthesiologist. If you could keep them awake, you're going to be a good speaker. So I'm trying to not to make you sleeping. So my talk is about the optimizing acute pain control and the rise of the interfacial blocks. Going back to the medical school, all of us learned that the usual way of the nerve blocks, original or during your residency, if you're an anesthesiologist during your residency, you'll learn that there's two common ways to do the regional anesthesia, either neuraxial or the targeting the nerve, and the benchmark is actually the nerve root. If you do it behind the nerve root, you will have neuraxial. If you do it at after the nerve emerge from the trunk, you'll targeting an original block, which is the nerve block. What is our new guest? Nurses in OR, all the time anesthesiologists will grab the ultrasound and do certain type of procedure. Anybody knows it? The most common one. So, tap lock. Every case of the cesarean section nowadays are done with the combination, either mostly spinal with a tap lock or additional. So the interfacial blocks is actually a type of regional anesthesia that emerged by injecting the local anesthetic in the interfacial space. So not like the classical way of regional blocks that you are targeting the nerve. You are going to the interfacial space and actually keeping the local anesthetic there, and that by this manner you're actually providing the analgesia or anesthesia to the patient. The other main help is actually the ultrasound. So the ultrasound make us more predictable with the landmark that we can have it, and then we made this block more and more reproducible. The interfacial blocks is actually done in two common. Is initially either started as a part of the pain management during the surgery, or in the pain medicine as a part of the management for the chronic pain patient. The help comes with the ultrasound. So the ultrasound was additional support for us to do the interfacial blocks, and it moves us from the anatomical landmark and the needling technique, as we can see later on, toward the more precise blocks. How does it work? It actually works through the targeting the nerve ending at and their branches within the interfacial space, and also the blocks can be transmitted effectively to the pain. What is the advantage of it? My previous speaker, Dr. Dosari, said we cannot do regional while the patient is asleep. Do you know, anybody knows why? Because of the risk of the interneural injury. So as our great speaker from the quality said, no harm. So what about the interfacial? The beauty of the interfacial is actually you can do it while the patient is asleep, while the patient under anesthesia. And as we said, it enhances recovery of our patient. It's actually, as Dr. Hazazi said, it plays a role also in preventing the patient of the future chronic pain as well. There was a nice publication done in 2018, and it goes from I recommend from antibodies and from anesthesia or surgeon to go back to this article, and it gives us the landmark to it. They mention in that the fascia is actually the forgotten structure. And from anatomy, as we learned, that there is two types of fascia, which is the superficial fascia and the deep fascia. And quite difficult sometimes to differentiate between them unless you know your anatomy and so on anatomy of it. And very important for a trainee to differentiate from each of them. How does it work actually? Is by applying the probe and looking for the targeted fascia, and then your aim is to spread the local anesthetic on the fascia that you are planning to target and trying to produce the block that you are doing. Today, I'll talk about certain type of them, which is the tap block, rectus block, quadratus lumborum, and Beck's block as well, and ESP, they all good friend. And we'll mention also there's different other interfacial blocks that they are not commonly known, but it is very important if you are interested, you can just go through it. The TAP block, which is our very known block, and it has been demonstrated early in 2001. Just imagine in 2001 until 2007, there was like 2 pops, 1 pops by the needle. So what about the cases from the obstetric that they have lax abdomen, or like an obese patient, or whatever variation about it? Till 2007, there was clear demonstration of the ultrasound and looking for the adequate target for that to be done. Then the evolution comes to the different types of TAP block and accordingly comes through. The anatomical landmark is actually, as we can see it in the picture. So you are looking for the fascia that is between the internal oblique and transverse abdominal muscle, and then inject your local anesthetic, producing the block. How many types of TAP block? Anybody knows? There are 6. Yes, this is why I mentioned. I kept it there because I need everybody to know about it. So TAP block is not only TAP block once. It's according to the location of your probe anatomically. And every one of them, it has its own difference. What are the applications? We can do it for cesarean section, we can do it for laparoscopic surgery, we can do it for hysterectomy, we can do it for colorectal surgery. But accordingly, if you are interested, you can look for the type of TAP block and do it according to the surgery type. So the TAP block for cesarean section is different from the other type, like the hysterectomy, for example, or laparoscopic surgeries. So we need to have better understanding of your anatomy and the surgery type to deliver adequate block. And this is when I revise cases in my hospital and the other hospitals. So a colleague comes to you and tell you that I did TAP block was not working good. The first question I ask him, what type of surgery your patient has? So is it a midline incision, or is it like transverse, or is it labically, or what type? So the type of the incision plays a role in your decision what type of block and where to apply your probe. Appendectomies, inguinal hernia, and also bariatric surgery. Quadratus lumborum block. Anybody aware of this block? Okay, quadratus lumborum is introduced in 2007. So as you see, it is 2007. And then we'll see in 2016 what happened, and then we'll see how things. So actually, the quadratus lumborum was 2007, and the aim of it is actually to target the fascia between the quadratus lumborum and psoas muscle. And this is can be reproduced according to the time of the surgery, and here we can see it in the ultrasound, the distribution of your local anesthetic targeted according to the level, the anatomical level that you want to do. What type of surgery you want to do will cover accordingly, as I said. So let's go back to hospital now. You finish this lecture and you go back to the your hospital and said you have like 92 female lady. She came for radiological gastrostomy tube insertion. The patient is Parkinson, dementic, has recurrent aspiration, Dr. Mohammed Nasser from ICU saying, I don't want to admit this patient, and your patient relative, they're saying to you, we don't want to go to ICU, what are you going to do for this patient? General anesthesia, you put the tube will be difficult to be removed, and also other concern. So what type of block you want to do for this patient? Okay, I will go with subcostal tap block. What about the pectoral nerve block? It was introduced in 2011, and the modification comes in 2012, leading to more differentiation between PECS type 1 and PECS type 2, and the better coverage. So as you see, the innervation of the PECS blocks comes from the different, so the additional of PECS 2 is with long thoracic and thoracodorsal nerve involvement. So this is very important for a special type of surgery. Which type of surgery that we need to have it? Well, no, okay. So the PECS and PECS 1 and PECS 2 is actually the differentiation between the two fascia, the deep fascia versus the superficial fascia, and also there's nice landmark, which is the pectoral artery, which could help you in the where to inject your local anesthetic according to it. ESP. I was really happy to hear from Dr. Mohammed, since he was doing his training in McMaster. And as my old friend, Dr. Shag, we came from the same background. So everybody knows Ferrero. He's a Colombian pain physician who invented, or he was able to discover his block in 2016. So actually he was there at that time, and the case was planned for a pain block. Patient came to the clinic with thoracic pain, and then he did the block, and he was able to reproduce it again with the ultrasound. The landmark here, he was good in ultrasound. So he was able to reproduce the same block with the same patient with the same landmark. So anatomically, ESP comes to know the TP, transverse process. If you can identify the transverse process, you can do the ESP block easily. And there is two types of ESP, and if you can look at in literature according to the block itself. So as I said, transverse process and the ESP is closely related. Whenever you can produce it with ultrasound, you just need to hit the lower or the inferior part of the TP, and then just with local anesthetic, you're going to spread the fascia, and this is the block. What type of surgery? The beauty of ESP is actually carried certain part of the paravertebral, and also the other interfacial blocks that you can do it even for spine surgery, for VATS, for laparoscopic surgery, also for breast surgery. So, going back to the hospital again. So, we'll go eventually at the end of this session, but you are called to have this case, which is an 84 female, known case of breast cancer. The patient planned or booked for a radical mastectomy and with axillary dissection. The patient is hypertensive, diabetic, with ejection fraction of 20. Your head of the department saying you are assigned to this case you want to do in addition to that, there is a moderate aortic stenosis. You called your cardiac anesthesiologist, he said to you, I'm busy doing cabbage. Okay. So, can we do this case, or putting the tube and sending the patient to ICU? This is one option, but the family and the caregiver are saying to you, we don't want to go ICU. You want to have a better recovery. What you'll do? Any choice? Okay, this is a case that I handled. So I choose to do a paravertebral plus PICS 2. And the patient was able to be pain-free at the end of the day. And he was discharged from the recovery to the ward. So this is going back to the anatomy of the breast. As we say, it is rich, and you need to go back to it. It comes from T2 to T6. And also this comes another part of the innervation to it. So in summary, the categories that the interfacial plane blocks are very different, and we can differentiate them into 3 categories: the cervical facial blocks, thoracic facial blocks, and abdominal facial blocks, and each of them need to have a different understanding of the anatomy. Also a colleague, I would say the common knee block, which is abductor canal block, is actually can be like a borderline between interfacial and canal block. And you need to know it in order to go reproduce it again for your patient. Remember that the customizing of your care is essential, especially of the surgical and anatomical understanding, by efficient achieving the regional anesthesia. And this is the reference. Thank you very much.
Our next speaker is Dr. Rami, who has a Jordanian and Palestinian fellowship, and he has a background or special interest in cardiac anesthesia and intensive care. And he has a novel topic that he's about to talk to us about, the role of ketamine in opioid-sparing anesthesia.
Thank you.
دي من اليسار، دي next slide، ودي السلايد اللي
تعالى هذا
دي next slide. ماشي، يمين ويسار هم شايفين دي بس. ده طيب.
السلام عليكم ورحمة الله. I'm Dr. Rami Arabasi from Ortho Hospital, Suleiman Habib Hospital. I think about the ketamine, nobody in this room did not use. One of the old player in our anesthesia team. But every day, every time he wonderful us that he has another use. We started with induction, then started with sedation, then started with him with painkiller. So it is unique in his advantage. So we will speak about the ketamine in surgical management from acute pain to enhanced recovery. And if there is time, we will put spot over for the TKR and total hip replacement and role of ketamine. First, we speak about the history of ketamine.
It is sensitized by Kelvin Stevens in 1962, and it is alternative for phencyclidine, which has a lot of complication at that time. And in 1970 become approved from FDA to use in Vietnam War because it's unique advantage for hemodynamically. Then in 1970 till 1980s, it's used as popular medication for induction of anesthesia because of its unique character. But in 1990s, after discover the propofol, sevoflurane, and the new generation of another medication of anesthesia, decline its use. But as I said, every time he wonder us that in 1920 regain use again after discovery for pain management, for chronic pain, for opioid sparing strategy. And now in 1990s become a cornerstone for multimodal analgesia. Another issue, there's another generation from ketamine, now it is esketamine, which is make more wonder for us in its use. So overview for ketamine, we will speak about the mechanism of ketamine, mechanism of action, its benefit intraoperatively, application, dosing, everything about the ketamine that we can help us. If we speak about the mechanism of action of ketamine, primary, it is an non-competitive N-methyl D-aspartic acid, which antagonist, a receptor antagonist blocking glutamate sparing, so will disrupt pain sensitization and hyperplegia. Additional hemodynamic include for pain control, it's opioid receptor modulation. It will activate immune opioid receptor, so will contribute to analgesia. Also, synergistic pathway interfere with serotonin, dopamine, calcium channel blocker, which play a role in pain relief. Also, it has anti-inflammatory effect, reducing pro-inflammatory cytokinase, so prevent neuropathic and chronic pain. Its metabolites also active, which is ketamine, which prolong the analgesia. Its application in anesthesia for acute pain and for chronic pain. For acute pain, low dose ketamine will reduce opioid consumption and improve pain score after surgery. And for emergency situation, it's effective for renal colic, for trauma, for spinal, for procedure sedation due to rapid onset. Also, it will prevent administration of its administration will preoperatively will minimize post-operative pain and opioid consumption. For chronic pain, we can use in neuropathic pain, effective in diabetic neuropathy, spinal cord injury, chemotherapy, and induce neuropathy. Complex regional pain syndrome, it will reduce allodynia and hyperalgesia in type 1, and for chronic cancer pain, adjunct to opioid for refractory cancer-related pain and contracting opioid induce hyperplegia, hyperesthesia. What's the dose and administration? We have low dose regime, sub-anesthetic dose can be used to minimize the psychomimetic side effect while retaining analgesic efficacy. Routes, we can use IV for induction of anesthesia, and its rapid onset make it suitable for induction. We can use intranasal, which is approved from FDA for depression, but it is off-label for pain. Topical and oral, emerging for localized neuropathic pain. Here we can see just can we give IV bolus infusion or intranasal. It's a duration of action, peak duration, and it is unique that we can use in this situation and give what we need. Mechanism relevant to anesthesia regarding the pain. Also, it is sympathetomimetic activity, have sympathetomimetic activity, so maintain the hemodynamic stability by increasing catecholamines release, so we can use it in critically ill patient, hypovolemic patient, hypotensive patient. It has also bronchodilator advantage, so benefit in asthmatic patient and reactive airway disease. For intraoperative pain, we can use as analgesia and opioid reduction. It will reduce intraoperative opioid requirement by 30 to 50% and lowering risk of respiratory depression and postoperative nausea and vomiting. Effective in surgeries with high postoperative pain for like abdominal, orthopedic and oncogenic procedure. It will prevent chronic pain by mitigation central sensitization and reducing risk of persist post-surgical pain after thoracotomy, after mastectomy, and it will be a decrease 40% incidence of persist post-surgical pain after mastectomy. Additional intraoperative benefit, hemodynamic stability. It prevents hypotension caused by volatile anesthetics or propofol, make it ideal for trauma, septic patient, cardiac patient. Also, it will reduce post-operative nausea and vomiting. Clinical application regarding to our anesthesia. We can use as general anesthesia to induce by using its hemodynamically instability patient and to avoid cardiovascular collapse. We can also use it as maintenance continuous infusion in 0.1 to 0.5 milligram per kg per hour with inhalation or propofol. For regional anesthesia, also it will added sedation and analgesia during nerve block or neuroaxial anesthesia without suppressing the respiratory drive. Another clinical application that relates to our anesthesia, specific surgery. For example, cardiac surgery, it maintains blood pressure during sternotomy, but we need to be care about the tachycardia, and we must be managed. For pediatric anesthesia, it is safe for procedural sedation with maintained respiratory with minimal respiratory depression. Burn surgery, it will reduce opioid needed and procedural pain during dressing change. About the clinical application by surgery type, for abdominal surgery, we can give the respective guideline recommended 0.5 milligram per kg bolus and then 0.12 milligram per kg per hour infusion. And for cardiac surgery, it will prevent post sternotomy pain, so it will maintain blood pressure, but as we said, we need to be careful about the tachycardia, and we must manage. For orthopedic, total knee arthroplasty, 0.3 to milligram per kg will reduce post-operative hyperalgesia. For burn surgery, 0.5 milligram per kg IV before debridement will decrease procedural pain score by 50%. For pediatric, we can give a sedation on non-cooperative patient. Dosing protocol, we can give either bolus or infusion or ultra low dose. For boluses, this is this is of course for pain management, not for induction of anesthesia. Can we give 0.1 to 0.5 milligram per kg IV at induction or at incision? For infusion, can we use intraoperatively and ultra low dose for patient with opioid tolerant? Combination therapy, that the unique about the ketamine that we can use with a lot of combination. We can use with midazolam, we can use with opioid in general. But I just will put light for some of this combination. We can use with propofol that we call ketifol. So will decrease the side effect of ketamine, which is psychomimetic effect usually, but also take the benefit of a propofol, which is sedation. So we can use propofol and ketamine together in 1:1 ratio or 1:3 ratio. For example, we can give 10 milligram ketamine infusion with 30 milligram propofol. This will give good analgesia, intraoperative will affect as added benefit for painkiller, plus their sedation, and will maintain the patient stable overall. With dexmedetomidine also will give synergistic analgesia with reduced delirium risk. So if we can use 0.2 to 0.7 microgram per kilogram dexmedetomidine with ketamine infusion, so will decrease delirium. Multimodal analgesia, as we can use with non-steroidal, we can use with gabapentoids medication, we can use with local anesthesia infiltration. About the side effect of ketamine, there is frequency more than 10%, and there is between 1 to 10%, and there is rare complication. About the psychomimetic effect, like hallucination, dissociation, confusion or agitation. Another side effect, cardiovascular tachycardia, hypertension, nausea, vomiting, and increased salivation. Less common but clinically significant, between 1 to 10%, as emergency delirium, nightmares, laryngospasm, hypertonia, and muscle rigidity. Now, this risk factor for psychomimetic effect, we will see that it will increase with age. It is more occur in adult, less with children. The dose, when at more than 1 milligram, become more, and less with the dose less than 0.5. If there is midazolam or not, it will play a role also. Other rare but serious adverse effect, less than 1%, is a neurological complication, as increased intracranial pressure, increased intraocular pressure. Urological with the chronic use, this will lead to ulcerative cystitis, and the patient will complain from frequency, dysuria, hematuria. Bladder fibrosis also may occur. Hepatotoxicity may occur with ketamine use, chronic use, so we need to do liver function tests. How we manage? It's simple. For hallucination, we can give midazolam 1 to 2 pre-op or pre-give ketamine. Hypertension, can use beta blocker, Ismilol or B-Lock. Emergency delirium, just assure the family to be around the patient when we at recovery. Hepatotoxicity and ulcerative colitis, avoid to use in chronicity. Post-operative transition, continue. If we will use ketamine for post-op for pain management, we can use as low-dose infusion for 24 to 48 hours to sustain analgesia. Also used in patient-controlled analgesia with BCA, morphine, or another, and it will be in dose 1.1 to 0.2 milligram per kg, either demand dose or infusion. This will decrease 30 to 50% of morphine consumption post-operatively. Evidence and guidelines, it's supported by the respective guideline for abdominal, thoracic, and major orthopedic surgery. A strong recommendation for laparoscopic cholecystectomy, open colorectal surgery. Meta-analysis confirm reduced post-operative pain score by opioid consumption 30 to 40%. ASA, American Society of Anesthesia, suggests ketamine as part of multimodal analgesia, and European Society for Regional Anesthesia endorsed ketamine for regional anesthesia to be adjunct opioid sparing or model of post-op analgesia. I need to put point about the TKR and total hip replacement and the role of ketamine in this procedure, because it is challenging for us in pain control, especially acute pain control. Why it is challenging? First, because it is surgical trauma. Bone swinging, reaming, this will increase the post-operative pain and establish for chronic post-operative chronic pain. Chronic pain risk, it is 20% for total knee replacement to occur. And because we need early recovery after surgery, so need early mobilization, and that require minimal sedation, and to also to avoid ileus that will prevent early manipulation. Use of tourniquet also play a role in the developed chronic pain. So it is challenging for us to search what can we do for the patient to prevent post-operative pain. Here, ketamine inticar and total hip as pain management. In a pre-operative, we can use ketamine IV as single dose to avoid anxiety. Intraoperative, regarding to the type of anesthesia, we can give 0.3 milligram per kg bolus and then infusion. This will throw out of the surgery. It will play a role in post-operative pain. Post-operative pain, we can use 0.05 to 0.1 infusion for 24 to 48 hours. And for sedation, we can use 1 to 2 milligram per kg IV or IM according as needed. If we compare the ketamine with other sedative agent, intraoperative, we will see that the ketamine is superior for propofol or midazolam, that it will preserve airway reflex, it will preserve, it will give us analgesia for the patient, excellent for hemodynamic stability, and we see if for its duration of action, of onset of action, also unique about and superior for propofol and midazolam. If we comparing ketamine with opioid and propofol, we will see that ketamine will opioid sparing, and there is no respiratory depression, hemodynamically is excellent, and airway reflexes is preserved comparing with opioid and propofol. We will see that it is superior over them. Now, how we can use ketamine as a salt of anesthesia, as one part of anesthesia to avoid general anesthesia. Preoperative, we can give 0.5 milligram per kg, and also we can give gabapentin 300 milligram plus tab block. About the gabapentin, they recommended to give at least for 24 hours, 24 hours to 48 hours before operation. So if we'll give ketamine 0.5 with gabapentin 300 2 days before, and with tab block, this will decrease post-chronic pain within 6 months. Intraoperative, we can give 0.2 milligram per kg infusion with the spinal anesthesia or adductor canal block. This is another strategy. Either we start before pre-op in first line. Intraop, we can use as with the spinal and adductor canal block. This will decrease intraoperative opioid requirement. For post-op, how we can use 0.1 milligram per kg for 24 hours with BCA. This will make patient manipulate within first day of post-surgery. This is another protocol. Evidence on orthopedic, it showed that 0.5 milligram per kilogram bolus and 12 milligram per kilogram per hour for 24 hours, it will decrease morphine use and will be patient move within second day of surgery. For total hip, it will show that ketamine will decrease chronic pain and also prevent chronic post-surgical pain with in other study. This is case study. I did another one, not like that, but I will speak about this case and then I will speak about my case. This is a 70 years old female, obese, with obstructive sleep apnea and hypertension. What's the protocol? To avoid general anesthesia and also to avoid spinal anesthesia. So we preoperative give 0.25 milligram per kg IV ketamine, and then give Lyrica 75 milligram. Intraoperative adductor canal block with 0.1 milligram per kg per hour ketamine, and post-op we use 0.05 milligram per kg per hour ketamine for 24 hours and paracetamol. The outcome that the patient walked 50 feet in the first day with minimal opioid, and نص الكلام رايح الظهر and discharged early in the second day of post operation. What I did, in our case, we have the same patient, the same history, 77 years old, female, obstructive sleep apnea, and ischemic heart disease. And we need to do total hip replacement for her. So our plan to avoid okay, last slide. So what we did, spinal anesthesia and infusion propofol with ketamine. We give maximum dose of fentanyl, 50 mic per spinally. This procedure sustained 7.5 hours. 7.5 hours. Patient after last 2 hours, just he feel the touch without feeling any pain. About the ketamine, there is a lot of things to speak, but I think that time it is not enough for us. Thank you for all. Thank you.
Thank you very much. Would you be kind enough to join your colleagues so that we can do the discussion? So I'll hand the mic over in a minute, but I have a few questions that I would like to ask. I know you are to ask. So my first question goes to Dr. Remai. So ketamine has a bad name because of the hallucinations. Do you come about anything in the literature that mitigates against hallucinations from using ketamine?
When I search about the hallucination, there is two strategies to avoid hallucination. First, not to give first the dose. This dose either not to give a preoperative high dose as induction. Second, to be infusion. If you give little dose, less than 0.5 milligram per kg, and make infusion for a long time, this will avoid hallucination first. Second, to give another medication with it, as a propofol or midazolam. It will decrease the hallucination risk. But as I show, it is increased with adult and less with pediatric. It is more occurrence with 1 milligram per kg, less with 0.5. And if we give medication or not.
Thank you. Dr. Reeves, your question that you gave us about your patient, the 82, I was wondering, could you have used erector spinae block and the PEC? Would it have been as effective as the paravertebrae?
The main issue with the ESP is actually needs to do it both sides, part of it, according to the. But ESPs can be a plan of that, but the anesthesia part, I can guarantee it, but the anesthetic part, I cannot. So rather than to have ESP plus sedation, I was getting why not to go for something more predictable and to have at least I can control. So TAP was for me a superior option compared to the ESP. But for abdominal surgeries, you still can do ESPs. As I mentioned, you need to, whenever, as we learned in the anatomical innervation is very, very important. And it's very important to know the surgical incision as well, especially if you are planning to do it as pre-surgical intervention.
One more. Dr. Hassan, I was wondering about your shoulders. Do you do any awake shoulders on the block alone?
Yes, we will do, sometimes we do mainly interscary block alone, we do. But we did a little bit also axillary and suprascapular nerve block together. But you have to choose the proper patient, because some of them they are unsure. and you know your surgeon. So sometimes it will take 8 hours, sometimes it's only 1 hour surgery. The position, if you have anything that like some people keep a head cap, so it will give some space to the patient, so the patient will not feel sophisticated. That's a good idea. Some people use headphone for the patient.
For pure regional, you need to have a good surgeon colleague. So the number 1, number 2, and number 3. Then the patient selection, because unless your surgeon is collaborating with you as an anesthesiologist in such cases, it will be difficult experience, especially if in sitting position. At the time that the patient starts to feel, and then you need to interfere during anesthesia, or he was like irrigating like an 80 or 90 liter of saline, and then you find that the patient is filling with subcutaneous fluid. So I agree that it's very important to build. You can do it as pure block, but you need as eventually a team.
Dr. Al-Arabi, my question is regarding the chronic post-surgical pain, role of regional anesthesia, and optimizing post-operative in all the discussions. Actually, are we sure that we can prevent post-operative surgical pain beyond 3 months? Or we are just trying?
That's what I mentioned earlier, we are just trying. There is nothing guaranteed to prevent chronic post-surgical pain. But adding different approach, medication with regional, with good pain control post-operative, it may hopefully decrease the incidence of post-surgical pain.
There's any factor, personal factor, patient that is inevitable, that the risk is high, that
gonna be at high risk for post-operative surgical pain. Like you mentioned, one of your colleagues mentioned catastrophizing.
Yes, this type of patient at high risk than others. Your question, anything to do for them? Nothing. This type of patient usually at high risk, and usually they may improve with post-operative psychological intervention like CBT, like other modalities. But this type of patient specifically, they need to understand the risks of chronic post-surgical pain early. I have one of these type of patient. He did thoracotomy, and he was very anxious after surgery. He said, if I know this will happen with me later, I will not do surgery. Although it was needed surgery. But this type of patient, as I mentioned, they need to discuss with them, explain to them the modality of intraoperative pain management, and despite that, they may still have this chronic post-surgical pain.
Unfortunately, we are in the best centers in the world. We don't have any, that communication to optimize the expectations of our patients.
So I believe there's all factors we can control it. The patient, the surgeon, it might be the surgery, the duration of the surgery. These factors cannot be predictable. But what I do recommend from our perspective as an anesthesiologist is to apply at least the preventive or the primitive analgesia, to do a block or enhance the surgeon to do infiltrated local anesthetic using multimodal. These factors we can control, and I know that there is multiple evolving studies regarding recently I was having a discussion with one of my colleagues. He has a case with for below knee amputation, and the patient was sick enough not to get regional. So he asked me, shall I do nerve block or not, since neuraxial or epidural is contraindicated because the patient has anticoagulant? I took a moment and then I just did a review, and they found that there is a retrospective study in China that they measured like 8,000 patients retrospectively. They compare a spinal to epidural, to peripheral nerve block, to general anesthesia, and they found that whenever you go from spinal epidural toward the general anesthesia, the risk of post-surgical pain, chronic pain, is getting higher. So this is what I think.
Just I wanted to share my experience with awake shoulder surgeries. During the fellowship in Canada, Dr. Jassi and I were the first fellows at McMaster University. And when we started the program there, we had a huge resistance by the surgeon to do nerve blocks. And in the middle of our fellowship, the surgeons were requesting nerve block, awake shoulder for their patients. They earned a lot from this technique. They were able to discharge their patients, and if Dr. Jassi remember that, we did almost roughly 300 awake shoulder during 6 months of our fellowship. I think that the trick in awake shoulder surgeries is the sedation. Sometimes you might have batch block or insufficient nerve blockade, but the sedation can overcome this obstacles. With good sedation, you can make your patient comfortable, supply any missing nerve blocking, and back to the fascia plane blocks. I remember we did 2 cases for clavicle ORIF under clavicopectoral fascia plane block, only without intrascalene, without superficial cervical plexus block. And I think general anesthesiologists should learn the fascia plane block, and it's easy to perform rather than the nerve block itself. Just I wanted to add this, and thank you so much.
I agree with Dr. Mohammed. We need to the trust between you and surgeon. We have seen situation before when I'm covering just only I'm covering anesthesia for orthopedic only, mainly upper extremity and lower extremity. In early days we have problem doing blocks. They're resisting, refusing. The patient will you will take time for procedure. We don't know what will the result. Maybe we'll shift to GA. Nowadays they are asking for regional anesthetists, those doing regional anesthesia. They're refusing general anesthetists, those don't have experience to do regional. So yes, the key secret is trust with surgeon and sedation.
I would add also for the technique, intrascalene is a good one, but in arthroscopic procedures, I would add cervical plexus for sure. Because the posterior port, the first one they will start, they will scream, then they will lose the trust, then the whole scenario of the day will be changing. So all GA, no way. So no, just get the cervical plexus while you are doing that. It's an easy one. It's combo technique, and you can do it.
For the patient, you have to inform the patient, touch them, apply some pressure, and tell the patient you will feel that. You are not supposed to feel nothing. You will feel some touching. That's it. Because some of them will get scared when they feel the touch. That will happen.
Does anyone else have any question?
They want to go home.
thank you very much for coming today to our closing of our this year fourth HMG Anesthesia conference. Thank you very much for the speakers who participated with us in this event. And we want now to honor our speakers, and we'll start, inshallah, by Dr. Abdulaziz Al-Hazazi. Dr. Muhammad Jilisi. Dr. Hassan Dosari. Dr. Rizq Al-Amri. And Dr. Rami Arbasi. Can we come for a group photo?
Can you switch off this? We need the black.
This Apple, is it?
Thank you very much. And now Dr. Nasser is going to
thank you all. It was very extensive 3 days. We learned a lot. Thanks for the speakers. Thanks for the committee. Thanks for the chairman, Dr. Ibrahim, who do most of the work. And let's announce that next year we will be gathering again in another HMG setup. And we decided as an organization committee to be in Jeddah. So all speakers and audience are invited. So it will be in April again. It will be 9th, 10th, and 11th. It will be Thursday, Friday, and Saturday on next April, next year. So all of you are invited in our new project in Jeddah. Thank you all.
Gracias.